participants of the conference update on chronic pain, chronic headache and pain. First of all, I would like to welcome co-chairman of this conference. Institute of Neurology and Neurosurgery of Chisinau, Moldova is very proud to host this conference in collaboration with Moldovan Society of the Study and Management of Pain, Moldovan Society of Headache and Pain, Nicolae Testimițanu State University of Medicine and Pharmacy, and Society of Neurologists of the Republic of Moldova. The conference is dedicated to the 13th anniversary of the establishment of the Functional Neurology Research Unit at the Institute of Neurology and Neurosurgery, named after academician Demir German. This research unit conducted valuable research on headache and pain field through the years. The recent one is the project founded by the National Agency for Research and Development, use of the principles of 4P medicine: preventive, predictive, personalized, and participative, in analyzing risk factors for the onset, perpetuation, and progression of chronic pain. The scientific program of the conference was endorsed by the two international societies dedicated to pain, the International Headache Society and the European Federation of Pain. The outstanding speakers will deliver a high-quality presentation for the national, regional, and international audience with the up-to-date, evidence-based knowledge on chronic headaches and pain. I invite you to enjoy the conference program with us. I would like to introduce the next speaker is Professor Stella Odobescu, one of the most prominent researcher in our country in the headache and pain. Please, Professor Stella Odobescu, I will give you the floor.
Hello, can you see me? Hello?
Yes, at
We
least
can
I
hear
can
you, but not see.
It's okay now?
Yes, it's okay.
Hello. Hello to everyone, dear participants, dear faculty, dear guests. We are very pleased to open this conference dedicated to the 30th anniversary of Laboratory of Neurology of Functional Neurology in Moldova. And now I am pleased to invite the representative of the Parliamentary Commission for Social Protection, Health and Family, Professor Mr. Adrian Belli. Professor Belli.
Good morning to everybody. Dear Mr. Director of the Institute of Neurology and Neurosurgery, Mr. Zapukhlich, the host of this great event. Dear Mrs. Minister of Health, Alana Merenko. Dear Rector of the University of Medicine and Pharmacy, Nicolae Testimițanu, Mr. Emil Ceban. Dear Mr. Vice Rector for Research Activity and also the President of Society of Neurology of the Republic of Moldova, Academician Stanislav Gropa, honored professors, guests from abroad, dear colleagues and friends. Today, under the auspices of the Institute of Neurology and Neurosurgery, an international conference is being held dedicated to headache and chronic pain syndromes. It is one of the fields that are successfully developed by the Institute based on 30 years of the activity of the Laboratory of Functional Neurology led by Professor Ion Moldovanu and his team. Pain treatment is a fundamental human right declared by WHO and International Association for the Study of Pain. Scientific and medical progress followed by logical path to form a new perception of society about pain and the suffering person. Pain was recognized as the fifth vital sign. Chronic pain syndromes finally were found as independent nosological entities in the new classification of diseases, ICD-11. If we look from a certain point of view, all these advances were made and offered by free and democratic states. In this sense, the role of the state in the development of the society, science, education, health is crucial. The state contribution to the development can be defined by a series of keywords: independence, democracy, freedom, peace, the rule of law, education, cooperation, infrastructure, health, globalization, development, economics, knowledge, information, future society, human rights, opportunities, etc. Currently, these universal values are defined by Ukraine. The only alternative for Moldova is the European Union. The European Union is the countries and generations project to which each of us must contribute. Everyone at their place of work should promote knowledge, truth, common sense, and universal values. This conference is welcome and timely. To relieve pain of the neighbor is a divine thing. Famous speakers will share their knowledge and professional experience during these 2 days. I wish you a successful event, health and optimism. Let's all pass tomorrow with confidence. Thank you.
Thank you very much, Mr. Professor Belli. And now I am honored to present the President of the Society of Neurologists from the Republic of Moldova, the Vice Rector of Nicolae Testimițanu State Medical and Pharmacy University, Professor, Academician Stanislav Gropa. Please, dear Professor.
Da, bună dimineața și vă mulțumesc pentru invitație, mulțumesc pentru participare. Onorată doamnă ministră, onorat domnul parlamentar, domnule director, doamnă profesor Odobescu, domnule profesor Moldovanu, onorați colegi, este un eveniment extrem de important pentru noi toți, deoarece astăzi avem un eveniment cu o dublă conotație. Pe de o parte, vom discuta o problemă excepțional de importantă, problema durerii. Paralel, este și un eveniment care trebuie să-l menționăm, un eveniment de celebrare 30 de ani a unui laborator de cercetări științifice în domeniul neurologiei. Un laborator care și-a adus și își aduce în continuare deci aportul pentru îmbunătățirea atât a rezultatelor de cercetare, cât și a conexiunilor internaționale, prezentarea Republicii Moldova, formare de specialiști și sigur că prezentarea unei ideologii noi în procesul de abordare a neuroștiințelor. Voi începe de la, cred că, crearea laboratorului, deoarece anume fondarea acestui laborator a indus cercetarea durerii de la început, ulterior, deci și-a extins orizonturile și vreau să menționez acel fapt că am fost martor ocular la procesele de instituire, de inaugurare acestui laborator, când tânărul profesor universitar Ion Moldovanu s-a reîntors atât din studiile postdoctorale din Moscova, din acel studiu, training pe care l-a avut în Paris și cu un mare entuziasm s-a încadrat în organizarea laboratorului, în fondarea laboratorului, în acordarea și integrarea acestui laborator atât în sistemul de sănătate din Republica noastră, cât și, sigur că, cu conexiuni importante de colaborare. Pe parcurs, problema durerii a devenit o problemă fundamentală, deci o problemă susținută de organismele internaționale care a atras atenția că omenirea nu necesită și nu poate suporta durerea. Este și, sigur că acea adresare, acel apel care astăzi este poate și mai acut decât tot timpul. Deci, fie durerea în activitățile uzuale, fie durerea pe platforma unui măcel, unui război, cum este astăzi în Ucraina, ea nu-și are loc. Menționez acel fapt că pe parcursul anilor în Republică s-au consolidat mai multe școli de studiere a durerilor, a patologiilor care induc durerea, a analizelor integrative de manifestare a durerii. Este școala profesorului Moldovanu, continuată și asociată cu activitatea doamnei profesor Odobescu, laboratorul de neurologie funcțională. Este școala domnului profesor Adrian Belăi, cu studieri profunde și cu conferințe multiple, cu implicări în studierea durerii acute, a durerii cronice, cu școală, cu doctoranți, cu publicații. Este școala de reumatologie condusă de doamna profesor Liliana Gropa, care de asemenea și are un aport esențial în studierea problemei date. Dar și alții. M-am preocupat și mă preocup și eu împreună cu colegii mei de durerea acută în cadrul patologiei neurologice. Deci considerăm că problema dată este o problemă excepțional de necesară, este o problemă extrem de interesantă și, pe de o parte, deci este o problemă care conferă deci un câmp extins de realizări. Și iată, vreau aici să transmit mesajul de salut a domnului rector, a domnului profesor universitar Emil Ceban, care vă salută pe toți și confirmă acel fapt că atât problemele de cercetare în durere, cât și alte probleme existente în neuroștiințe vor fi susținute, vor fi apreciate și astăzi în universitate se creează toate condițiile pentru a avea posibilități marcante de studiere a diferitor probleme importante pentru societate. Menționez acel fapt că numai acum câteva zile în urmă am finalizat un summit extrem de important cu o instituție de cel mai înalt rang internațional, Institutul de Inginerie Genetică și Biomedicină, care intenționează, împreună cu Universitatea de Stat de Medicină și Farmacie Nicolae Testimițanu, să-și organizeze un centru de cercetare regional, unde, pe bună seamă, ne vom putea regăsi toți noi împreună, cei care suntem din cercetare. De asemenea, noul motou, nouă strategie de predare, de abordare a medicinii este prin cercetare. Deci, studiul medicinii prin cercetare este motoul și strategia principală din universitate. În acest context, sigur că toate evenimentele care sunt legate de cercetare, care sunt rezultatul cercetărilor, sunt extrem de apreciate de rectorat. De asemenea, menționez că sunt create acum condiții excepționale cu câștigul la unui grant important din cadrul Băncii Mondiale de 2.150.000 de euro, care va consolida baza de cercetare a universității și care va putea găzdui diferite laboratoare importante ca biobanca sau laboratoare de virologie, microbiologie, laboratoare de morfologie, fiziologie și așa mai departe. Deci genomica, direcții extrem de importante. Ca președinte al Societății de Neurologie țin să salut toți colegii, să apreciez inițiativa colegilor care astăzi organizează acest meeting foarte interesant, doamna doctor Grosu și echipa integrală a domnului profesor Moldovanu, Odobescu, domnul profesor Belu și toți ceilalți care sunt implicați în studierea durerii. Vă urez sănătate și vă confirm deci, mesajul ferm a domnului rector de a susține cercetarea, de a o implementa și de a fi un pilon important în strategiile de dezvoltare ulterioară a universității. O zi bună și sigur că noutăți importante, dispoziție bună. Ieri a fost ziua râsului, cred că astăzi nu mai zâmbim și vom fi într-o dispoziție excepțională. Vă mulțumesc!
Mulțumim foarte mult, domnul academician Gropa, pentru așa niște cuvinte de apreciere și pentru susținerea la toate nivelurile a cercetărilor în domeniul durerii care sunt efectuate la noi în Institutul de Neurologie. And now it's my pleasure to present the Professor Ion Moldovanu, who will speak about the history of creation of inauguration of this functional neurology laboratory and the most important results achieved over the 30 years. Please, Oksana.
Just 1 minute.
Mm-hmm.
Oksana, dar nu se vede prezentarea.
O secundă, domn profesor. Acum se vede?
Acum se vede, dar sunt niște și alții se văd pe... Aha, ok. Deci o să vorbim astăzi despre neurologie funcțională, o temă foarte interesantă, complicată, cu foarte multe probleme, clarități și foarte multe neclarități. Următorul slide. Următorul slide, Oksana. Oksana, următorul slide.
Da, domn profesor, o secundă.
Deci, toată ideea cu neurologie funcțională a venit de la un celebru, aș spune, profesor, ulterior a fost și academician, domnul profesor Alexandru Vein. Eu am avut ocazie, și fericită ocazie, ca 11 ani să fiu în laboratorul lui în Moscova. Deci, problema neurologiei funcționale era prin plan, tulburările vegetative la fel și competențele dumnealui și echipii lui erau foarte importante. În perioada aceea se considera că el este unul din cei mai performanți savanți în Rusia. Următorul slide. Deci, ulterior, după ce am revenit în Chișinău și am fondat împreună cu domnul Vovc, deci, laboratorul de neurologie funcțională, evident că am avut posibilitatea toți anii ăștia să participăm la diferite congrese, datorită faptului că am avut foarte mulți persoane din rețelele astea de, business sau nu de business, de cercetare. Și aici dumneavoastră îl vedeți pe domnul Vein. Se vede săgeata mea sau nu? domnul Vein, cu echipa, ne întâlnim de fiecare dată și el era foarte, foarte activ, urmărea cu un interes foarte mare toate publicațiile care noi le avem. Noi avem foarte multe publicații. Mergem mai departe. Deci, din partea stângă, vedeți Carte vegetativă de răstrojstva. Asta e un manual fundamental, cu vreo 400 probabil de pagini sau mai mult. Asta e versiunea a treia. Eu nu vreau să fiu de modest, dar am avut cele mai multe articole în cartea asta, deci 100, aproape 200 de articole. Și vreau să vorbesc că practicienii în domeniul tulburărilor de mișcare au trecut de la psihogenie la tulburări funcționale de mișcare, în timp ce epileptologii continuă să dezbată conceptul de crize funcționale versus crize disociative versus crize non-epileptice psihogene. Celelalte denumiri ale sale, de exemplu, tulburările de conversie, tulburări psihogene și în trecut isterie, indică o mare încărcătură istorică de această tulburare. Într-adevăr, mai ales isteria. Isteria are câteva secole, vreo 7 sau 8 secole de prezență și totdeauna se considera că isteria este o boală ce ține de fel de crime, de criminalități, etc. Deci o parte din pacienți, mai ales femeile, erau arși pe rug, considerau că ele sunt legate cu diavolul, etc. Deci istoria e foarte dramatică. Mergem pe departe, următoarea. Deci, dumneavoastră, este în partea stângă un coperta revistei Functional Neurology. Da, revistă din Italia. Și noi cu domnul Vop, acolo se vede, am publicat un articol o secundă, posibil Paradigm of Functional Neurology. Deci au fost multe recenzii la articolul ăsta. Acum, este un moment foarte interesant. Când la dumneavoastră vine un pacient și are foarte multe simptome, dureri de cap, tulburări de respirație, dureri abdominale, este vertij, se aude un sunet puternic. Deci și pacientul dat este trimis la investigații. Ulterior el vine din nou la dumneavoastră și investigațiile au arătat că nu este nimic organic. Și atunci se pornește o istorie că pacientul nu are nimic organic, dar în schimb suferă foarte mult. Și istoria asta cu suferința că nu găsim nimic organic a fost o istorie foarte tumultoasă, aș spune eu. Și de ce cauză? Fiindcă se considera dacă nu e nimic, acolo nici boală nu este. Ulterior, bine s-a conștientizat că pacienții ăștia pot suferi foarte, foarte mult. Și aici, prima frază care este aici este că în cele din urmă eticheta organic versus non-organic este fals dualistă în ceea ce privește creierul și mintea. În apelurile pentru eliminarea acestei sunt bine întemeiate. Adică cât de clar n-ar fi că pacientul ăsta organic nu are nimic, totul e funcțional, nu e atât de simplu. Deci între organic și funcțional sunt atâtea elemente complicate, neclare, că doar acum cei care profund problematica asta consideră că poate vreo 20% din conexiunile care sunt între diferite structuri ale creierului, de care eu o să vorbesc un pic mai departe, deci fac aceea că organic și non-organic nu sunt două chestii diferite, dar este posibil un continuum. În ultimii 5, s-a întâmplat așa că o perioadă până la apariția aparatelor ca MRT, etc., functional MRI, deci a fost un declin foarte mare și, în schimb, în ultimii 10-15 ani a avut loc o renaștere a interesului pentru acest domeniu clinic de TNF. TNF, tulburare neurologică funcțională, așa o să spun. Deci, vreau să spun că în afară de asta, deci a apărut o nouă societate, TNF, Functional Neurological Society, care este multidisciplinară și are foarte mare perspectivă. Problema care este că o parte din medicii, am spune așa, organiciști, totuși nu pot accepta că pacienții ăștia involuntar fac anumite, eu știu, trucuri ca să aibă anumite avantaje, etc., dar lucrul ăsta e foarte complicat. Adică aici sunt niște dileme neobișnuite. Mergem mai departe. Următorul. Deci, în partea stângă, noi am scris, vă zic, cu domnul Vein, o carte, Neurogena hiperventilația. A apărut, el, sigur că a scris prefața, dar eu l-am pus ca primul autor. Deci, tulburările neurologic funcționale sunt următoarele. Pacienții deja pot afla acum despre cauza, diagnosticul și tratamentul următoarelor afecțiuni, care crize non-epileptice, ne mai spun și psihotice, slăbiciune, paralizie funcțională, tulburări funcționale de mișcare, sunt foarte multe și o să vă arăt câteva dintre însele, dacă o să miște, că la mine se mișcă. O să o rog pe Oxana ca să apese. Înapoi, Oxana, te rog, înapoi. Deci, dureri de cap cronice zilnice, vertijul și de realizare, tulburări funcționale de vorbire, de înghițire, sindromul oboselei cronice, probleme cu somnul, memoria, atenția, atacuri de panică, depresie, etc. Dumneavoastră, vedeți că sunt foarte multe și ele, lista asta poate fi continuată. Următorul. Acum, Oxana, jos în partea stângă, apasă și o să înceapă să miște pacientul ăsta. Nu, înapoi. Jos, la colțul din stânga, săgeata, apasă, te rog, în partea stângă, mai sus, pe ăsta negru. Nu. Mai jos, apasă, jos, apasă, acum apasă, încă, păcat. Că bărbatul ăsta, un pacient de nostru, care vreo 7-8 ani a fost urmărit de noi. Bine, acum urmărit și el avea niște accese de mișcări involuntare foarte dramatice și păcat că nu merge aparatul, mă rog. Oxana, mai încearcă, te rog, încă o dată, fiindcă e tare important. E că acolo unde acum apasă, decât 2 ori apasă. Nu merge. Bine, mergem mai departe. Deci, următoarea pacient încearcă, din nou, în partea stângă, jos, încearcă, apasă, de vreo 2 ori. Fă clicuri. Bine, deci pacienta respectivă are un sindrom foarte interesant, clănțănește din dinți. Dinți cu o viteză foarte mare, foarte frecvent, adică permanent în mișcare. Eu am vorbit cu dânsa, m-a întrebat-o, am rugat să scoată limba într-o parte, în alta, așa mai departe, și gura cascatul tot vibrează. Deci, păcat că nu se mișcă, că nu se mișcările astea. Merge mai departe. Încearcă și aici, partea stângă jos, încearcă. Asta deja e din... Cum nu merg, nu înțeleg. Jos, încearcă. Înapoi. Deci, pacienta asta are niște contracții asimetrice, foarte intense, atunci când vorbește, atunci când are emoții, care uneori dispar totalmente. Și ea este drăguță, simpatică, fără de contracțiile cele care o fac să fie cu totul dezagreabilă. Următorul. Acum, probabil că îl cunoașteți toți pe Jean-Martin Charcot din Franța, care s-a ocupat, a lucrat în domeniul isteriei. Charcot a fost primul care a constatat că femeile cu isterie, ele sunt pacienții, asta este o boală și lucrul ăsta, el vreo 20 de ani s-a ocupat cu isteria și în principiu era atât de celebru că de lumea întreagă, cei mai mari președinți de țară sau oameni bogați veneau la dânsul la consultații. Deci el considera că sunt pseudocrize, sunt crize isterice și o problemă foarte mare era să înțeleagă, dar ele sunt provocate special, voluntar sau nu. Ele apar, mă rog, în funcție de anumite ritmuri interne, etc. Deci, Charcot, până la urmă, a constatat, au fost foarte multe discuții, cercetări, cum și care este cauza cum este cauza acestor explozii, mai ales că ele aveau de astea. Mergem mai departe. Ceva a trecut. Da, e bun. Deci, dă-te rog pe Charcot înapoi un pic să termin gândul. Deci, până la urmă, Charcot credea că totuși pacientele astea provoacă toate accesele astea, deci voluntar, și ceea ce probabil, parțial, era adevărat, dar la o parte dintre însele, deci erau involuntare și cel mai important este faptul că toate crizele astea care credeau că epilepsie, fără doar și poate. Acum, în centrele de epilepsie, unde monitorizează și ziua și noaptea encefalograma, 30% din pacienții care vin cu epilepsie au crize epileptice. PNES ăsta e psihogenic, non-epileptic, seizure. Deci 30% din pacienți internați nu au epilepsie. Deci stres foarte mare pentru pacienți, pentru că ei au accesele astea și nu-i clar, ele sunt cumva, eu știu, provocate sau nu, rămâne o enigmă foarte mare. Mergem mai departe. Acum o să vorbim despre Moldavian Headache Team. Bine, noi avem mai mulți colegi care au lucrat cu cefaleele. Dumneavoastră vedeți echipa noastră. Mergem mai departe. Deci, Ludovescu Stella deci, a făcut o lucrare într-un ușor remarcabil, doctor abilitat, migrenă cronică și tulburări vegetative asociate. Deci, consultant a fost domnul academician Stanislav Gropa și academicianul Victor Lăcustă. Mergem mai departe. Deci, ideea a fost foarte interesantă. Deci, sunt anumite strategii neadecvate, diagnostic greșite, sunt fel de fobii și s-a constatat că este o intercalare între toate fenomenele astea. Deci problema asta e veșnică în neurologia funcțională. Mergem mai departe. Dumnezeu a scris o carte la tema asta, migrena cronică și sistemul nervos vegetativ. Acum mai departe. Deci, doamna Galina Corcea, stările sincopale la pacienții cu migrenă, studiu clinic și neurofiziologic. Deci, foarte interesantă temă, când pacienții, următorul slide, se făcea tilt testul și se determina cum acționează tilt testul asupra, de exemplu, provocării sau modificării durerilor de cap, migrene. Mergem mai departe. Deci, Lilia Rotaru a avut o temă foarte interesantă, migrena cronică și asimetrie ventriculară cerebrală. Asta a fost o idee foarte interesantă și a lucrat foarte intens la tema asta și să vedeți următoarea imagine. Deci, asimetria ventriculelor. Erau diferite grad de pronunție. Interesant că asimetria asta totuși avea anumită influență asupra tabloului clinic. Da, mergem mai departe. Deci a fost împreună cu domnul academician Lăcustă lucrări foarte minuțioase, de nivel foarte înalt și teza ei s-a bucurat de un succes foarte mare, cum și la celelalte colegii de noastre ulterior. Mergem mai departe. Deci și iubita noastră, Oxana Grosu, aspecte clinice neurofiziologice ale cefaleei cronice asociate cu hipertensiune arterială. Deci, împreună cu domnul Grosu, el era consultant. Deci, tema asta e interesantă prin mai multe nuanțe. Mergem mai departe, Oxana? Așa. Încă. Deci, înapoi. Deci, migrena și hipertensiunea arterială. Deci, hipertensiunea arterială amplifică efectul migrenii asupra peretelui vascular și duce la creșterea disfuncției endoteliare a vaselor cerebrale. Am lucrat foarte mult. Publicațiile ei și publicațiile noastre, într-un fel, au avut rezonanță în diferite spații. Mergem mai departe. Violeta Maticiuc. Deci, migrena ca potențial factor de risc în accidente vasculare ischemice, cerebrale și coronariene. Deci, mai departe. Deci, mecanismele presupuse care pot induce un proces ischemic, după cum vedeți, este disfuncția endotelială, disecția arterială, embolismul, depresia corticală răspândită, vazospasmul și alte fenomene. Deci, tema a fost una pionierească, nouă, fiindcă în perioada aceea au început să constate lucrurile că pacienții care au migrenă mai frecvent au anumite forme de migrenă, dacă au ischemie. Mergem mai departe. Deci, înapoi. Ecranul. Așa, bine, au fost Tatiana Lozan a făcut la fel o lucrare, cu părere de rău n-am avut timp să la adolescență, o lucrare foarte importantă, sub conducerea doamnei Ludovescu, și lucrul ăsta a fost foarte interesant și are succes foarte mare în problema asta și competența ei ca medic neurolog pentru copii este cunoscută în Republica Moldova. Caracteristicile de bază metodei SET. Deci stimularea transcraniană electrică. Noi utilizăm, stimularea transcraniană electrică. Mai departe. Am făcut cercetări în domeniul ăsta, am avut foarte mulți pacienți la care au fost stimulați și am găsit, sigur că am găsit efect, dar noi știm că stimularea transcraniană, dar transcraniană este mai eficientă, ceea ce se lucrează la domnul academician Gropa. Următoarea. Acum, câteva cuvinte despre ședința mea. Zic că am avut un jumătate de an în clinica Mayo, Arizona, în Headache Center. Deci, și vreau să vă zic că problema asta este la fel de neurologie funcțională în vedere, la fel de actuală și în clinica Mayo. Lucrul ăsta este permanent și ei sunt foarte interesați de tematica respectivă, fiind acolo, evident că am lucrat și eu în direcție este, noi cu domnul, mergem mai departe, cu David Dodic, eu a fost adus, el e un specialist foarte renumit în toată lumea, chiar am scris împreună și cu doamna Udovescu o carte așa groasă de vreo aproape 400 de pagini, deci el e unul din autori. Deci, vreau să vă zic că în Statele Unite lucrurile sunt puse la nivel foarte înalt, bine, ei sunt foarte bogați, fac cercetări enorm de multe, medicamentele le studiază în anumite etape, cum se cere, foarte minuțios, el era responsabil, domnul Davidodic, de 3 aluri de este. Mergem mai departe. Acum o să vorbim un pic despre circuitele cerebrale, care tema asta o să vorbească mai departe domnul Victor Vovc, dar circuitele cerebrale, deci, într-un fel, pot să ne ajute să înțelegem totuși cum se întâmplă că unii pacienți au anumite stări disfuncționale, au probleme, dureri de cap și doriți și, practic, la investigație nu găsim ceva fundamental și convingător. Următorul slide. Deci, următorul. Deci, dumneavoastră vedeți aici două creiere și anumite săgeți care merg de la o structură la altă structură. Deci săgeți de astea ar putea fi cu mult mai multe și cred că în viitor apropiat o să fie o formulă, găsit o formulă cum de vizualizat lucrurile astea, dar vreau să vă zic că deja explică un pic că nu este așa pur și simplu organic și funcțional, dar este un organic și un continuum între aceste două elemente, enigmatice deocamdată, neclare, dar eu cred că în următorii 10 ani va fi o explozie fundamentală în acest domeniu. Mai departe, următorul. Deci aici, pe scurt, monografiile care au fost făcute, noi vă zic, și vă zic capitole manuale. Mai departe. Deci eu sunt conducător la 17, adică conducător și consultant la 17 teze care au fost și altele 4 ne așteaptă. Da, având în vedere și doamna Lozan, Tatiana, deci avem împreună deja 18 teze. Mai departe. Vă mulțumesc. Vă mulțumesc pentru atenție.
Domnul profesor Vovc vorbește.
Da.
Bună ziua, dragi colegi! Se aude?
Da, da.
Merge și sunetul merge bine, da? Într-adevăr, istoria care a prezentat-o pe scurt, a început și domnul Gropa, într-adevăr, erau toți concentrați atunci în Institutul actual de Migrant și s-a văzut încercările și nu numai încercările, dar și încercările foarte ceva, cum să-mi spune noi, pe atunci foarte nou, foarte neobișnuit, da? În conceptul acesta de neurologie funcțională, eu vreau să prezint se vede?
Da.
Este partea, da. Deci, foarte pe scurt, domnul Moldovanu, cu lux de amănunte și cu scheme, a demonstrat că conceptul de neurologie funcțională a fost viabil 30 de ani în urmă și este și viabil acum, trecând prin anumite etape de dezvoltare, de mai puțină dezvoltare și dezvoltare. Deci, la momentul acela, conceptul neurologie funcțională, în articolul care l-a arătat și domnul Moldovanu, Possible Paradigm of Functional Neurology, a fost publicat, n-a menționat nimeni, dar în revista Functional Neurology din Roma, revistă cu specific de a prezenta abordări noi, așa și scrie acolo, în dereglări adaptive și comportamentale. Deja era, slavă Domnului, 1998, dar revista ieșea înainte de asta, vreo 10 ani, deja se contura conceptul acesta, nu era formulat, nu era prezentat, dar în formularea acestui concept, domn profesor Moldovanu s-a bazat pe mai multe repere și anume, într-adevăr, deja a discutat aceasta un pic, am anunțat. Prima, în favoarea formulării conceptului s-au folosit analize teoretice, dar și observații clinice, dar mai mult și teoretice. Anume, controversată această discuție funcțional-organic, structural-morfologic, care, într-adevăr, acei părtașii teorii organice nu înțelegeau de unde apare și nu, adică cereau dovezi, că nu există dovezi morfologice, înseamnă că nu este așa ceva. După ce, într-adevăr, a fost arătată și fotografia domnului profesor, domnul academician Vein, care a formulat un concept de activare non-specifică a creierului. Deci, nivelurile de activitate a creierului determină comportamentul și apariția unor simptome și așa mai departe. Toate acestea au fost stratificate de către domnul Vein, domnul profesor Vein, la 4-5 chiar nivele. Următorul concept pe care s-a bazat domnul Moldovanu în formulare este analiza specifică a funcției concrete. Apropo, peste 30 de ani, acum să vedeți în unele slide-uri următoare mele, într-adevăr, analiza specifică a funcției concrete și discuția cu pacientul. Discuția pacientului este foarte important în a evidenția simptomele acestea, în a evidenția funcția sau circuite sau constructe din circuite care au fost afectate. Teoria sistemului funcționale, asta e a noastră, fiziologică, de Piotr Kuzmici Anohin. Într-adevăr, funcția de la Piotr Kuzmici Anohin a dezvoltat teoria reflexă lui Pavlov, care era mai mult sau mai puțin localizaționistă. Deci este centrul nervos, el reglează anumit reflex și așa mai departe. S-a văzut și s-a arătat și până acum catedra care pe urmă a moștenit-o academicianul Sudakov și acum funcționează, deci catedra la Universitatea Sechenov de Medicină din Moscova. Continuă, chiar teoria aceasta a fost dezvoltată în teoria cuantificării sistemelor funcționale, cuantificării funcționale. Și s-a arătat, într-adevăr, că nu putem vorbi de un centru anumit, care funcția aceasta o dirigează și o controlează, dar de o constelație, după, acum să spomenesc despre constelațiile lui Uhtomski. Deci, teoria sistemelor funcționale, într-adevăr, era un suport, să zic așa, de bază fundamental, fiziologic, pentru conceptul neurologiei funcționale. Și analiza relațiilor voluntar-involuntar, în cadrul funcției și dereglării ei. Aici, într-adevăr, să zicem așa, bine, poate și-au fost pomenite chestii, dar în Moldova, pe pioneratul, într-adevăr, a domnului profesor Moldovanu, voluntar-involuntar, este, nu că dilema, dar este problema dualistă de mai mulți ani, mai mulți secole, în mai multe domenii, dar mai ales în ceea ce privește funcțiile care sunt dintr-o parte dirijate fiziologic, din altă parte psihologic, neuropsihologic sau chiar biopsihosocial. Asta e o abordare absolut nouă, adică cum absolut nouă? Formulată și arătată influența sa și importanța sa absolut nouă. Bazele fiziologice ale conceptului erau dominanta lui Uhtomski, mai mult de un secol, de când a fost emisă teoria aceasta de dominantei și paralel cu această dominantă, dezvoltând, tot Uhtomski a propus teoria constelațiilor centrelor nervoși în reglarea funcțiilor. Deci nu un centru, constelația. S-a schimbat până și în prelegerile pentru studenți s-a schimbat conceptul acesta și a fost revăzută definiția centrului nervos în sens îngust și sens larg a cuvântului. Adică ce înseamnă? Multietajarea reglării poate fi, da și mai departe, și domeniile psihologic, psihosocial, psihobiologic și așa mai departe. Și totodată teoria sistemelor funcționale pe care am pomenit al lui Anohin. Deci, din punct de vedere fiziologic și mai departe se va vedea și pathofiziologic, este până acum, nu că până acum, era până acum tot cercetată, dar nu cu așa amploare cum s-a văzut în ultimii, mai ales 20 de ani. Tulburarea neurologică funcțională. Ce să subînțelege? Deci, tulburarea fiziologică sau functional neurological disorder, yeah, this is there. Aceasta este, da, tulburarea neurologică funcțională, cum este acum formulată, dar nu neurologie funcțională în general, dar mai ales implicând funcția, nu că funcție concretă, sau simptomologie concretă, sau acuzele concrete, deci stabilirea la bolnav care este etiologia, care este patofiziologie și respectiv și tratamentul. Deci tulburarea neurologică funcțională este o afecțiune frecventă și invalidizantă la intersecția dintre neurologie și psihiatrie, a formulat Daniel, acest autor, până pe curând a fost în mare măsură neglijată de comunitatea de neuroștiințe clinice. A făcut o revistă amplă, deci o meta-analiză. Acest autor, Daniel, vedeți, domnul Daniel, recent, 2021. În ultimele 2 decenii, menționează numelui, s-a făcut progrese semnificative în înțelegerea fiziopatologiei acestei afecțiuni, dezvăluind dovezi ale mecanismelor neuronale care stau la baza dezvoltării simptomelor neurologice funcționale. Tulburarea neuronală funcțională, obținerea unei mai bune înțelegeri a fiziopatologiei care generează simptomele, este deosebit de valoroasă atunci când se discută diagnosticul cu pacienții. Ceea ce, să zicem, nu era chiar la ordinea zilei în diagnosticul precedent. Creierul funcționează în circuite neuronale pe care le-a arătat cu lux de amănunte domn profesor Moldovanu, iar simptomele din diferite tulburări pot fi înțelese ca o cartografiere a unor modificări în interiorul și de-a lungul acestei circuite. Diferite simptome ale tulburării neurologice funcționale apar de la una sau o combinație de constructe anormale specifice. Constructe. Ei, vorbeam de circuite, să știe că de circuite de mult se vorbea, dar constructele se mai fac din mai multe circuite, din mai multe domenii. Să știm sigur că o funcție psihică nu se observă nici la remedieni, nici la... Dar ea se implică în ceea ce este de bază circuite neuronale plus constructul acesta. Deci toate constructele acestea împreună luate și circuitele se cer analizate. De exemplu, mișcările funcționale paroxistice sunt percepute ca fiind involuntare de către pacient din cauza unor anomalii în circuitul constructului de agenție. Agenție, deci bolnavul își închipuie că el este agentul acela care poate schimba, poate modifica anumite chestii și din punctul acesta de vedere se implică cu voluntar ori involuntar, cu evitare sau cu anumite ritualuri și așa mai departe, care țin deja de comportament și psihologie. Alte construcții în tulburări neurologice funcționale includ deficiențe în procesarea emoțiilor, atenție, introcepția, foarte important moment, chiar am discutat cu domnul profesor Moldovanu de mai mulți ani, cum am putea intra în aceasta. Sigur că pentru a studia foarte profund despre tot ce vorbim, este necesar de un aparataj foarte modern și chiar ceva nou, revoluționar, care încă nu s-a nici inventat, nici nu s-a propus. Procesarea sau inferența predictivă și interacțiunea acestora. Constructele normale pot fi cartografiate pe circuite cerebrale specifice, dar ele sunt foarte multe. A prezentat domnul Moldovanu câteva, dar într-adevăr liniile de interacțiune, acele o sumedenie, dacă nu sunt cu miile și poate și mai multe. Prima ce au specificat lucrările acestea în domeniul tulburării neurologice funcționale este procesarea emoțiilor. Deficiențe de procesare a emoțiilor sunt caracteristice de bază la unii pacienți cu tulburări neurologice funcționale. Dovezile susțin o reactivitate emoțională crescută, o stare de nervozitate și evitare sporită, toți clinicienii știu chestia asta, o afectare a reglării emoțiilor de sus în jos, amplificarea simptomelor neurologice funcționale în timpul stărilor de dispoziții cu valențe negative sau amenințătoare din punct de vedere psihologic, de exemplu, panică, rușine, deficite în conștientizarea emoțională, de exemplu, excitarea fiziologică în absența excitației emoționale, alexithymie, procesarea aberantă a salienței și activarea eronată a răspunsurilor defensive învățate sau născute. Cam complicat din primul moment, dar într-adevăr toate acestea se află în momentul atunci când se discută cu bolnavul, când se analizează paralel, implicând pathofiziologia. Eu, nefiind clinicist, dar având anumite tangențe și cu dereglări de somn, apropo, datorită, dacă spunem așa că creierii laboratorului de neurologie funcțională, a fost posibil deschiderea în 2013 a laboratorului de somnologie oficial prin ordinul ministrului, avem acest laborator în cadrul o dezvoltare a conceptului și laboratorului de neurologie funcțională. Plus la aceasta trebuie să vă spun că și laboratorul de fiziologie tot a fost în anumit mod reprofilat pentru studierea deci tulburării neurologie funcțională prin implicarea analizei paternului respirator și avem tot publicații multe concomitent cu domnul profesor Moldovanu. Mai sunt și alte momente, cum este agenția, atenția. Eu de acum îmi dau seama că termină timpul meu, da, gata. Atenție, interocepție, foarte importantă, dar nu avem pur și simplu timp pentru asta. Și această interocepție, inferența, da, prin procesarea predictivă, toate acestea sunt concepte pathofiziologice și de etiologie a momente de unde am vorbit mai rapid, unde am vorbit nu prea clar. La revedere!
Mulțumesc foarte mult, domn profesor, pentru aceste completări exhaustive și foarte interesante. Sunt 30 de ani de istorie comună, de cercetări la nivel neurofiziologic, psihophysiologic, la nivel neurologic. Mulțumim foarte mult, ținând cont că dumneavoastră sunteți acum departe, în Germania, că ați găsit timp și v-ați conectat și ați completat atât de frumos raportul domnului profesor Moldovanu. So many thanks to all the honorary guests who welcomed our conference. And
I'm sorry. We have to close the session.
Yes, but
and then open another one.
Yes, I understand. But I have to thank the honorary guest who welcomed our conference and wished it much success. Thank you very much. And now you are ready to move to the second session, to the scientific session. We can open now. Oksana?
Wait a little bit. Stop sharing, Professor Bob.
Stop sharing, yes. Just a moment. Just a moment. I don't know where. Just a moment. Just a moment. Okay.
Yes, is okay, but is Professor? Yes, the first one is Professor Tasorelli.
Okay, done.
Okay, this first session is dedicated to the topic of chronic headaches. Here I would like to thank sincerely the International Headache Society for supporting this scientific and educational event, so important for neurologists and for physicians from the Republic of Moldova. As you know, International Headache Society has an international constituency and bear the responsibility to disseminate scientific advances in as many countries in the world as possible. One of the most important beliefs of the International Headache Society is good science improves the lives of many people and contributes to creating better nations without violence, obscurantism, and propaganda. In the first session, international opinion leaders in the field of headache and pain, very well-known scientists such as Professor Christina Tasorelli from Italy, Professor Riklund Jensen from Denmark, Professor Arne May from Germany, Assistant Professor Saita Shina from the US, and Dr. Oved Daniel from Israel will give us their presentations. They are representative of a strong team of world-class headache specialists. We are very grateful for their readiness, kindness, willingness to come to us with the up-to-date information and with the latest advances in the diagnostic and treatment of chronic headaches. And now it's my honor and my pleasure to present Christina Tasorelli, who is the current president of the International Headache Society. Christina Tasorelli is professor and chair of neurology, director of neurology residency program, director of Department of Brain and Behavioral Sciences in the University of Pavia from Italy. Professor Tasorelli is the director of the Headache Science and Neurorehabilitation Center at the Mondino Foundation from the University of Pavia. Dr. Tasorelli has more than 360 publications and is co-author of several books and chapters. In fact, Professor Tasorelli visited once the Republic of Moldova 7 years ago during our 5th National Congress of Neurology and presented a very nice lecture on the medication overuse headache. Now her presentation will be dedicated to the chronic migraine, the pathophysiological mechanisms, risk factors, and clinical manifestation. I am pleased to invite Professor Christina Tasorelli. Christina, the floor is yours.
Thank you, Stella. Thank you very much for inviting me. You remember correctly, it has been 7 years ago that I visited you, and it was wonderful because I met great colleagues and friends. So it's really my honor to be here with you today. Too bad we cannot be in person, but I feel close to you, and I have to say that the talk of the person that just presented, Professor Boch, reminded me of how close is also our language, because circuiti cerebrali specifici is just the same we say in Italian. So I was wondering, maybe I should give the presentation in Italian. No, don't worry, don't worry. Thank you again. I'm going to start to share my screen. And I have to apologize with Oksana and Stella, because I gave you a hard time during these days, but we had just closed the first regional meeting of the IHS that we had in Argentina, in Buenos Aires, and so I had to stay there for almost 1 week. But it was very successful, and it was a first edition, and I think that it is something that IHS will repeat, and hopefully in the future there will be a regional IHS meeting organized by IHS together with you in Chisinau. And then when I came back, correctly you said, Stella, that I have all this appointment, but I had to take another one. So as of this week, I'm Dean of the Faculty of Medicine at the University of Padua, so I was completely flooded by appointments, requests, and everything. So forgive me for not being responsive all the time, but I was following what was going to happen, and I was reserving this morning for you. So let me turn to my presentation. It's chronic migraine. And my focus will be introduction, pathophysiology, and clinical manifestations. Here you can see my potential conflicts of interest. Actually, I have none as regards these presentations because I will not talk about drugs. I apologize beforehand if there is any problem with my connection because I'm using my cell phone because I'm not in my place. If it just the connection will be interrupted, just be patient and I will connect again. So what is chronic migraine? Chronic migraine is the term that the International Classification of Headache Disorders uses to describe a patient with frequent headaches, mostly migraine, believed to be biologically migrainous. From the historical point of view, the concept, the classification, and the names that we use for chronic migraine have evolved in the literature, especially in the last 2 decades. In the first classification, International Classification of Headache, there was not such a term as chronic migraine, but now we all use this term, chronic migraine, and the term chronic migraine has completely replaced earlier terminology such as chronic daily headache and transformed migraine. And this is important because it creates a lot of clarity in the field. So going through a little bit of history, you see here in 2004, the criteria of the second classification, international classification, introduced the idea of chronic migraine as a complication of migraine. And the diagnostic criteria was quite simply headache fulfilling criteria C and D for migraine without aura on at least 15 days per month for 3 months and not attributed to another disorder. So it could be classified, diagnosed in patient with migraine without aura on 15 or more days per month during the last 3 months, in the absence of medication overuse. But this definition was judged to be very restrictive because, as we will see when we are going to talk about the clinical presentations, chronic migraine may be a little bit different than episodic migraine. And so some patients who have chronic migraine, maybe they don't have 15 days of migraine, of actual migraine attacks over the month. So there was a revision of the criteria. And so you can see here the criteria, they became a little bit more complicated, but this was a necessary step. So in this case, the first criterion is headache, tension type, and or migraine on at least 15 days per month, occurring in a patient fulfilling criteria for migraine without aura, but in 8 of these days that were to be the criteria for migraine. So the patient has at least 2 of unilateral location, pulsating quality, moderate or severe pain intensity, pain aggravated by activity, and nausea and or vomiting, and photophobia and phonophobia. Also, it was introduced the idea that a diagnostic criterion could be the response to specific acute treatment of migraine, such as triptans or ergot. So basically, these were the three pillars of the new classification: headaches on more than 15 days per month for at least 3 months, migraine features, migraine diagnosis on at least 8 of these monthly headache days, and no medication overuse. Now we have the third classification, international classification of headache. It was preceded by the beta form, and then it ended up with the final form in 2018. And we have chronic migraine. Chronic migraine, in this case, is a standing alone subchapter of the group of migraine. You can see 1.3. And it is no longer part of the complications of migraine. And here you can see the final criteria. We have headache, tension type, and or migraine-like on at least 15 days. So this was kept for at least 3 months. Criterion B, and here there is a novelty, because you see that it occurs in a patient who has at least 5 attacks fulfilling criteria for migraine without aura, or fulfilling criteria for migraine with aura. So there is also chronic migraine evolving from migraine with aura. Criterion C kept the idea that on at least 8 days, this type of headache should have migraine features. So criteria C and D for 1.1 migraine without aura, criteria B and C for 1.1 migraine with aura. And again, which is also important, it is believed by the patient to be migraine at onset, or it is relieved by a triptan or an ergot derivative. Criterion D, of course, is not better accounted by another diagnosis. And here is just criterion 1.1 for migraine without aura. And on the lower part, you can see the criteria B and C for migraine with aura. So once we have defined the criteria, the diagnostic criteria, and the classification of chronic migraine, what are we talking about? Are we talking about something that is very rare? No. We are talking about a disease that in the general population affects from 0 to 5.1% of people. There is, you see, quite a wide variation, and this is probably is reflecting some leftover of the different definitions, but probably there are also differences among populations. The prevalence of chronic migraine, we know that it can be present during the adolescence, but it increases throughout the adolescence, and it peaks in midlife and then declines after the age of 50. But the highest prevalence you can see from the picture, it is in the ages 40, 49, in both sexes, but you can see that the chronic migraine is more prevalent in women. Like migraine, also chronic migraine has a preference for women. So if we enter now in the clinical aspect, what we see usually in our patient, we see patient with episodic headache, usually an episodic migraine, 70–80% of the population reported in the study, in the literature, it happens like that. And the chronification is usually a gradual, sometimes over decades. And of course, there are different factors. We are going to see them a little bit later during this presentation. But of course, there are risk factors for the evolution from episodic to chronic migraine. One, and probably the most important, is the increased frequency of migraine attacks, so an increased severity of the disease. Then there is a genetic susceptibility, and also an important factor is played by risk factors and comorbidity. And basically, we know that risk factors may be very important, and they have been classified into two groups, modifiable and non-modifiable. So on the non-modifiable, there is not much that we can do, but on the modifiable, there definitely is something that we can do. So this is what usually we see that happens in our patient. If we dig deep, And we ask them, they will tell, yes, it started maybe during the adolescence or during the primary school, and there were occasional attacks. Maybe they were not so intense. Then over the years, the frequency of attacks increased. The duration of attacks tended to increase. The response to acute medication tended to become less strong. It attenuated or it went away. And then after a while, as I said, years or decades, you can find this situation when, and you can see that in the lower part of the slides, where there is a background headache. Some patients, they tell me, my head is never free. I always have something. And on this background headache that can be of low intensity, maybe 2, 3, 4 on a NRS scale, there are the actual attacks. And here is another way to see the evolution. And what I'm telling you is about chronic migraine, but it could be the same also for tension type headache. You have a patient with an episodic disease, isolated attacks, then there is a tendency of these attacks to become maybe more close to one another. And in between them, the patient does not recover the complete wellness, the complete well-being, but there is always a background of disturbance, of background of annoyance, a background of headache. So you see there is episodic migraine, there is a threshold when something starts to change. There is a migraine transformation, and then you get to chronic migraine. And I said the factors, I spoke about the factors, and of course there are some factors that have been identified. Here I'm reporting a study by Zaza Katsarava. It's quite old, but it's still one of the most important that we have to analyze the chronification, the process of chronification from episodic migraine to chronic migraine. And you can see that I have circled in red the most important factor, the most strong factors that are involved in the chronification. Headache frequency from 5 to 9 days per month. And it seems Laplacian, but it is not. Headache medication overuse, and so intake of acute headache medication on at least 10 days per month. That is a threshold that really should be used as a red flag to be more aggressive on that patient, because that patient is at high risk to become chronic. And then again, headache frequency, when it increases and it goes above 10, so between 10 and 4 days per month. You can see that the diamond is close to 25 times the increased risk of an episodic migraine to become chronic when these conditions are present. And I mentioned before the factors that can be non-modifiable. Female sex, well, to a certain extent it is modifiable, but let it sit in the non-modifiable factors. Older age, definitely we cannot modify that one. Low educational level, maybe we could do something there with awareness activities. Low income, genetic factors, Caucasian ethnicity. And then there are the modifiable factors. High frequency of attacks, so episodic migraine. So let's be more aggressive when we treat patients with episodic migraine. Let's not wait, it becomes chronic. Anxiety, depression, so this type of comorbidity. Stressful life events are risk factors for chronic migraine. And of course, in some cases, they are not modifiable, but they can be managed at least. Obesity, heavy caffeine intake, tobacco use, overuse of acute medication for the treatment of migraine. So going back again from episodic to chronic migraine, what do we see in the everyday practice in my headache centers and probably in your practice? We see a patient with an episodic migraine, and this patient is taking care of episodic migraine with acute medications. And over time, these acute medications start to fail. The frequency of the headache, of course, is increasing because you don't have the possibility to stop the attack. So instead of lasting 2-3 hours, it lasts 2-3 days. So the number of days increases. And so we end up in, as I said, weeks, years, sometimes decades, with a chronic headache that is present at more than 10 days per month. And it is a chronic headache that is less responsive to treatment. So the patients start to say, okay, I could live with this if it only lasted 1 or 2 hours and if it responded to acute medication, but the acute medication are not helping me. So basically my days is spent trying to deal with this nasty pain. What also happens is sensitization, but we will see this later when we talk about pathophysiology. And so we have a bunch of people, which can be quite large. Every year we hospitalize more than 400 patients with chronic migraine and medication overuse, and we see more than 2,000 patients with chronic migraine. So 77% of them evolve from an episodic migraine. They are mostly women. There are also some men, but they are mostly women, mostly young women with a family, a job, a lot of activity to keep going. And so during the active phases of life. So as my colleague before was talking about, it is a functional disease. There is nothing wrong in the brain of this patient if we go and evaluate them with a normal MRI. There is nothing wrong if we go and open the brain, but nonetheless, these patients are highly disabled. So it's one of the most disabling diseases. And what we see with our patients is sometimes they can have different lifetime trajectories. So there are patients that I call the blue line, the remitting. They start as an episodic migraine, they go for a period into chronic migraine, so they have an increase in the frequency of headache, but then there is a remission due to the appropriate treatment, due to the changes in life, due to many things, but these are the good ones. There are patients who suffer from episodic migraine and they remain stable across their life. There are patients that I call them fluctuating because they have some relatively good periods when they are not chronic, so they don't have more than 15 days per month. And then there are bad periods lasting weeks, months, years when they are chronic, and sometimes they go up to 30 days of headache per month. And then there are the patients who are progressing. They start again as episodic migraine, and over time, sometimes because they do not look for help, appropriate help with the right specialist. Sometimes because no matter what you do, this patient, they do not respond to anything. We have it's the type of patient we call refractory migraine. They fail. It's not that they fail, it's the drug that fails them. Each type of drug fails them, and so there is nothing that seems to interrupt this very strongly progressive type of disease. And I'm showing you an example. This is one of my patients. She was 47 years old when I saw her. And of course, typically, her migraine onset was during the adolescence when she was 11 years old. And you can see across a lifetime what happened to her. And the blue line represents the number of headache days per month. So over 2-3 decades, she became chronic. And particularly, this started when she was 23, because she started to work, then she married, so her life changed completely. And she experienced a progressive worsening, a progressive ineffectiveness of acute medication, and increased use of acute medication. At 35 years old, she was chronic at that point, because you see that she passed the 15 days per month threshold. And at that point, she had already tried flunarizine, but that didn't work much and increased her body weight of 5 kilograms. She had tried amitriptyline for 2 months and she put up 4 more kilograms. Topiramate, it was completely ineffective, and it also induced sedation, side effects that she could not tolerate. She went over multiple detoxification from acute medication. They worked, they were effective for maybe at least 2-3 months, but then she went back to the same pattern. She tried onabotulinum toxin A. She had a minimal improvement in the sense of a very small reduction of headache days per month, and also a very small reduction in the intensity of the attacks. No wonder that, of course, this patient, she developed depression. And the response to acute medication was only partial. And this was the diary. This is the headache diary that we use in Pavia Center. You can see in vertical the days, And in horizontal, on the axis, you can see the hours of the days. The dark blue means very intense pain. The patient is not able to do anything but lying in bed. And then you have the two types of shaded areas, and one represents moderate pain. The patient is able to do something, but not the most requiring activity, the most requiring tasks like working or studying. Or you have the lieve, mild intensity. The patient says that the head is not free from pain, but he or she can function normally. You can see that this patient, she had only 4 days who were headache-free over a month. She had a lot of blue, which means that she was bound to stay in bed. And if you look in the lower part, you can see the number of acute medication that she took. Every day she took at least 1, in some cases 2. In one case, she took 3. She had to do something very important that day, so she just took pill, just to be able to stand up and walk and do something of her life. So this is why it's very disabling. This I show to you because it's a type of patient that it happens to me, and it has a name in the United States. It is called the roller coaster subtype. So the patient who fluctuates a lot, so they move from being episodic migraine to being chronic migraine. And whatever it is, the roller coaster or the patient with the chronic migraine, like the one that I showed you before, what we know is that chronic migraine, even when it fluctuates between being chronic migraine or high-frequency migraine, it is associated to high disability. This is a study that I'm showing from the Spanish group of Torre Ferrus and Patricia Pozorosic, and you can see on the left the disability represented by the MIDA score, and you can see that the patient with the severe disability, the light blue, are a relatively small percentage, 25% in the case of low-frequency episodic migraine, LFEM. The disability, the severe disability increases to almost 50% of the patient with high-frequency migraine, and it touches 60% of the patient with chronic migraine. The same picture we have if we use IT6. It's a scale that it's informative about the impact of migraine on everyday life. And you can see, again, if we just focus on the patient with severe impact, we can see that already an important percentage of patients with a low-frequency migraine, they report severe impact in their life because of migraine. But you can see that if we move to the right, high-frequency migraine and chronic migraine, the impact is severe in the majority of the patient. And as you can see, there is not so much difference between high-frequency migraine and chronic migraine. I'm going to talk to you about the pathophysiology. I'm going to skip all the discussion about the pathophysiology of episodic migraine because probably we won't have time to go through it. Just what it is that we know for sure that is happening in episodic migraine is that we have the neurogenic inflammation taking place in the meninges, because you know that the brain does not have nociceptors. So we feel pain in the head area because there is an activation of the trigeminovascular system in the meninges. And this trigeminovascular system is releasing vasoactive neuropeptides that induce vasodilation, that releases substances that induce the activation of, for instance, you can see here the mast cells. So we have there calcitonin gene-related peptide, we have substance P, we have bradykinin, we have nitric oxide, and all this is this activation of the trigeminovascular system here is relied back then to the center, to the nucleus trigeminalis caudalis, where we have the second order neuron. And then it is processed in the thalamus, and ultimately it reaches the cerebral cortex, where and when we feel the pain, we feel that something is going bad in our day. So we know that vasoactive neuropeptides are important. In particular, you know, all of you know about calcitonin gene-related peptide now, And calcitonin gene-related peptide concentration were reportedly higher in patients with chronic migraine than those in episodic migraine. And so there are some study groups that are suggesting to use CGRP as a potential biomarker of chronic migraine. But let me say that the mechanisms that are basically subserving the transformation from episodic to chronic migraine are not fully understood. But we know that they are likely multifactorial and they involve more than one level of the CNS. So I just show you the periphery, the meninges, but you have seen that there are many stations along the circuit, as there are the ascending circuit. Excuse me 1 second, that my dog is giving me a hard time, sorry. Okay, sorry. So unless you wanted to hear me barking along with my dog, I had to let her out. So we know that there are different processes at play here. Atypical pain processing, central sensitization, cortical hyperexcitability, and of course, we have seen neurogenic inflammation. All of them, they probably play a role in the transformation. We know so that the entire picture can be, in a simplified vision, seen like this. There are risk factors. We have seen some of them: female sex, depression, stressful life events, genetic predisposition, obesity. And there is an evolution from decreased threshold for generation of migraine attacks. So it starts as episodic migraine, low frequency migraine. Then there is an increase in
Professor Tasorelli, are you with us? I think we have some technical problems. We will wait for Professor Tasorelli a little bit. Okay.
I am back. Sorry, I knew this was going to happen. Was not my dog's fault. It is just a bad connection. Sorry. So I will restart from where I left.
Thanks.
And so, as I was saying, how can migraine become chronic? This is another way to see a little bit more complex. I'm starting from something that is more simple, but it's not simple what we are talking about. So we have predisposing factors, we have precipitating factors, we have perpetuating factors. And so we have triggers, we had accident in our life, we have menopause, stress, disease. And so we have an episodic migraine that evolves toward a more aggressive type of migraine. Maybe there are also sleep problems. I mentioned psychological comorbidities, but sleep is also very important. And maybe there is a not perfect use of caffeine, because too much caffeine, then we stop caffeine, there is a rebound headache. And of course, there is the problem of medication overuse, that we are going to dedicate a few slides to that. Weight gain, obesity is another problem, muscle tension, and we end up with a patient with chronic migraine. So I mentioned sensitization. Sensitization is important in episodic migraine, but it is also important in chronic migraine, because we know that there are two neurons, peripheral and center neuron, in a very simplified vision. of pain transmission. And we know this in the perivascular areas of the meninges is going to activate the peripheral neurons, which is sensitized. And so these neurons releases neurotransmitters that activate the central neuron. This is what happens in episodic migraine. But in chronic migraine, what we have, or in repeated episodic migraine, we have that the peripheral sensitization, so the repeated peripheral sensitization is leading to central sensitization. And so what happens is that maybe when the peripheral neurons is not stimulated by the neurogenic inflammation in the meninges, there is always some type of activity going on in the central neuron. So the system, the engine of migraine actually in some patients starts to never be stopped. It's always turned on. And this is a problem because in this case, it's more easy that an attack takes place and it becomes devastating. Another actor of the chronification of migraine can be identified in the descending central pain control system. We know that there are, I mentioned the ascending part of the brain process of the brain messages, but we know that there is also descending control of pain. And one is good. I've identified here in green is the cingulate cortex, is the amygdala, is the periaqueductal gray, it is the dorsolateral pontine tegmentus, is the ventromedial rostral bulbar area. Here we have opiates, we have GABA, we have noradrenaline, we have serotonin, and this neurotransmitter, they reduce the pain. But on the left side, we have another area in the bulbar area, the ventromedial rostral part of the medulla. And here the neurotransmitters that are released are glutamate, aspartate, and again serotonin. And in this case, this neurotransmitter, they can act as facilitators of the pain. So you can see that serotonin can both attenuate the pain or increase the pain. And so one of the hypotheses is that there is definitely a reduction of central pain control. For instance, some authors have suggestions that there is some sort of subclinical hypoxia during migraine attacks, and this is leading to abnormal deposition of iron. And iron catalyzed the free radical injury in the brain. Or another hypothesis, and of course here we are more in the field of the hypothesis than in the evidence-based, hypofunction of lateral descending pain modulatory circuits, the decreased activation of some nucleus, in particular the nucleus cuneiforms, which accounts for descending facilitation of nociception or impairment of descending inhibition pathways. So you see that the picture starts to get more and more complex. But just to summarize, we mentioned about the peripheral mechanism, external triggers, evokes activation of trigeminovascular afferents, which terminate in the lower brainstem, the nucleus trigeminalis caudalis. But then there are other mechanisms then that enter in play. There is the increased tone of ascending pathways inhibited, or decreased tones of ascending pathways. And so in one case, if there is an increased tone in ascending pathways and this is inhibited, we have no migraine. If there is a decreased tone in ascending pathway and excited, we have migraine. So it is a quite complex situation. And I try to make it simple, but it's difficult because actually we need to be, if we want to be faithful to what we know that is happening in the brain, in the periphery during chronic migraine, you see that the picture is definitely bigger, because on the left we have the risk factor, we are familiar with them. Then you see that in the center there is the top-down modulation, the cortex. I will not show you the data that we have on the cortex, but there are a lot of functional neuroimaging and neurophysiology data that shows that the cortex of the patient with chronic migraine is not functioning in the same way as the patient with the healthy control or the patient with episodic migraine. So there is the cortex, there is the limbic system, the insula, the hypothalamus, the hippocampus, the amygdala, and more that are involved. Of course, there is the brainstem, the periaqueductal gray. And you see that on the right, there is this trigeminal nociceptive pathway where we have the trigeminovascular input, the spinal trigeminal nucleus, the thalamus, and the sensory cortex. All this is acting together. When everything is acting perfectly, we have a healthy person. When something is not acting perfectly, maybe we have a patient with episodic migraine. When something is definitely wrong, we have a patient with chronic migraine. And let me tell you a few words about acute medication overuse, because we know that the risk of developing chronic migraine depends also on the frequency with which abortive drugs are used and the type of drug used. Too much use of acute medication may lead to medication overuse headache, a condition that is characterized by chronic headache and overuse of different acute medication. So the definition of the International Classification of Headache, of medication overuse, is a headache occurring on at least 15 days per month for at least 3 months. And this is developing as a consequence of regular use, overuse of acute or symptomatic headache medication on 10 or more or 15 or more days per month, depending on the medication, non-steroid anti-inflammatory drugs or triptans, for more than 3 months. It usually, but not invariably, resolves after the overuse is stopped. And what do we have to do with this patient? We have to give the two diagnoses, because most of the patients with medication overuse headache, they are also patients satisfying, qualifying for the criteria for chronic migraine. So we have to use both diagnoses, chronic migraine and medication overuse headache. And we know that we don't know much about what is really happening when the patient overuse acute medication, but we have some pretty good insights from basic studies. For instance, this is a study that was published more than 10 years ago by Milena De Felice. She was working with Frank Porreca at that time, and in the animal, she administered to this animal sumatriptan for several days, and she went to evaluate the periorbital withdrawal threshold. So she went to evaluate the trigeminal activity in the rat exposed to the sumatriptan. And as you can see, over the days, there was a decrease in the threshold of response to the periorbital stimulation. So this means that this animal exposed to sumatriptan had a nociceptive system that was deranged with a lower nociceptive threshold. And we have more recent data from other groups that were published in Brain a few years ago, showing that you expose animals to the chronic treatment with, you can see that name LY344864 is lasmiditan, is another drug that has been already marketed for the acute treatment of migraine in the United States. It will probably arrive soon also in Europe. And you can see that you expose chronically the animal to lasmiditan, and what you see, there is an increased expression of calcitonin-related peptide in the caudal trigeminal nucleus. We have more data of this sort. In this case, again, animals were exposed chronically to sumatriptan and lasmiditan, and you can see that, again, we see that in both cases there is a decrease in the periorbital mechanical threshold, but there is also something else, because they become more sensitive to bright light stress, which is the same symptom that our patient endure, and they also have a reduction of the threshold when they are exposed to nitric oxide. So these three conditions, they are experimental conditions, but they clearly mimic allodynia and latent sensitization, which is what we see in our patients every day. 2 slides on the endocannabinoid system. So you might probably know that we have been working a lot in my laboratory, but not only our group, also other groups have been working on the endocannabinoid system. The endocannabinoid systems is very important for the maintenance of the homeostasis of our body. It is not only important in for the brain, other for other organs of our body. I'm showing you this complicated slide just for you to focus on two names that I'm going to use in the next slide, because you can see that basically we have the main endocannabinoids are represented by anandamide on the left and 2-acylglycerol, 2-AG on the right. And 2-AG, for instance, is synthesized using this enzyme that is called the DAGL. And then it is degraded using this enzyme that is called MAGL, because endocannabinoids, they are not stored in the vesicles. They are synthesized on demand. There is a need for them, and you have DAGL acting to produce 2-acylglycerol, and then they are removed. So MAGL is active there to remove the unnecessary 2-AG. And we have evaluated these two enzymes, DAGL and MAGL, in patients with episodic migraine, chronic migraine. And you can see here that there is a spectrum. So you can see that, for instance, the DAGL, let's start with DAGL, the enzyme that is synthesizing the endocannabinoid. You can see that it is much more increased as compared to control, but also increased as compared to episodic migraine in the patient with chronic migraine. Then we detoxify the patient and look what happens. There is a decrease of the enzyme. If you look on the left is the DAGL, the MAGL, again, we have the more or less the specular picture. So there is a much more marked increase in chronic migraine medication overuse, and this goes down after the detoxification. It means that this system is hyperactive. The system is creating more endocannabinoid, and then it is destroying this additional cannabinoid that is produced. So another concept, and this will be the last concept that I'm giving you today, is about the allostatic load, because we have mentioned genetics. I did not mention what we have about genetics because it is an entirely different argument, but we have some data about the importance of some genes in medication overuse headache. We have epigenetic modulation. When we talk about stress, of course, we are talking about epigenetic modulation. Then there are, of course, comorbidities and gene dysfunction, but we also have the two possibilities. There is an increased allostatic load or a decreased allostatic load. And the allostatic load is defined as the cost of chronic exposure to elevated or fluctuating neural responses resulting from chronic or repeated challenges. And so you have a decrease in allostatic load. And in that case, you have a patient with a stable episodic migraine or with an episodic migraine that is resolving over years. On the other side, you have the patient with an increasing allostatic load, and in that case, you may end up with migraine chronification. At that point, I gave you some information. Diagnosis is quite easy. There are the criteria of the classification. Of course, it is important to collect an adequate, a careful, a thorough headache history. This is the first step, and it is very important to rule out secondary headaches. So always be aware of the red flags, because it may be chronic migraine, it may be chronic migraine medication overuse headache, but it could also be something else. So be sure that you have collected an accurate headache history and you have performed a neurological examination. And here I'm listing the red flags, but probably you are aware of all of them. So I think I've used the time that I had. I'm going to close with this: stop the insanity. Stop the insanity, maybe not only in our field in chronic migraine, because there are other types of insanity we have been living in the last 2 or 3 years, but those are more difficult. Chronic migraine maybe is more simple to tackle. It's more simple to just to prevent it to become chronic migraine. We have the possibility to do that. So this is my last figure I'm showing. I gave you a lot of information. I hope it was not too much. You probably have questions. I'm here to answer your question. Thank you.
Thank you so much, Professor Tasorelli. There is a question in the chat, but I think you can answer them writing there. It's
okay.
It's about prevalence in teenage girls. And I think Professor Odobescu would agree that we have to move on to the next presentation, that Dr. Oved is already waiting. So we give the floor to the next moderator, is Dr. Adina Roceanu and Dr. Tatiana Lazan.
Only 2 words. Thank you very much, dear Christina Tasorelli, for this comprehensive lecture, as usual, with high-level scientific and with practical connotations. And chronic migraine is a real challenge even for headache specialists. And we say sometimes that chronic migraine causes headache to the headache specialist. And
that's true, Stella.
I'm very sorry we have no time for discussion because I have a lot of
problem.
questions.
Just stay safe.
Thank you.
Bye-bye.
Maybe next time. Thank you very much.
Bye-bye.
Bye-bye. I only would like to present Adina Roceanu. She is a representative of Romania in the International Headache Society, and very big and very good specialist in headache field in Romania. Hello.
Please.
Hello, everyone from Bucharest, Romania. Thank you very much for inviting me here. Thank you very much, Professor Tasorelli, for this exquisite presentation. It's wow. And it's the lifetime experience with all these difficult patients you're sharing with us. I have the big pleasure to present you Dr. Oved Daniel. Dr. Oved is the president of the Israeli Headache Association, is member of International Headache Society, of American Headache Society. He is clinician, but also a headache specialist, and was primary investigation in many pivotal trials regarding treatment of migraine and cluster headache. And continuing the subject of chronic migraine, Professor Oved Daniel, we will talk about management of chronic migraine. Dr. Oved, you have the floor.
Hi, so let me see if I'm muted or not. I don't, okay, yeah, okay. Wait, yeah, so thank you very much, Adina, for the introduction, and thank you, Christina, for this very insightful presentation. I'm looking forward to meet you in person in Israel in about 3 weeks. And thank you, Dr. Oksana, for inviting me to talk about chronic migraine, which causes a major headache for most headache specialists. And in this presentation, we'll discuss about the management of patients with chronic migraine, which means how to choose the right acute and prophylactic therapy while trying to limit the use of acute headache medications that have been said associated with medication overuse headache. These are my disclosures. A migraine is, we all know, it's very common, and the prevalence is about 15%. In some countries, it's even higher, more in women, and it is ranked as the second most disabling disease amongst all diseases globally in terms of years lost due to disability, and it is associated with significant morbidity and considerable negative impact on quality of life. And we all know what migraine is: recurrent headache attacks that last 4 to 72 hours, typically a unilateral location, pulsating quality, moderate to severe pain intensity, and sometimes it's aggravated by physical activity, and that the most common associated symptoms are photophobia, phonophobia, nausea, and vomiting, which are usually defined as the most bothersome symptoms. Chronic migraine is defined as more than 15 headache days per month for more than 3 months, and a fulfillment of ICHD-3 criteria for migraine on more than 8 days per month. So, some of the migraine patients use abortive drugs to relieve pain, and their life goes on. But in some patients, because of frequency, more than 4 monthly headache days, severity and impact on quality of life, or adverse event with acute treatment, a preventive treatment is required. So basically, the main goals of preventive treatments are first to reduce attack frequency, severity, and the duration, to improve the responsiveness to treatment of acute attacks, to improve function and to reduce disability, and to prevent progression or transformation of episodic migraine to chronic migraine. And based on the level of evidence for efficacy, we have oral treatments that have established efficacy for migraine prevention, the anti-epileptic drugs, the valproic sodium, the topiramate. We have the beta blockers, metoprolol, propranolol, timolol. We have the fluvotriptan for short-term preventive treatment of menstrual migraine. And we have parental treatments such as Botox and CGRP monoclonal antibodies. In the probable effective group, we have the amitriptyline, the venlafaxine, and certain beta blockers, and memantine, which we are rarely use. I don't know why amitriptyline is probably effective, as I can say from my personal experience that it's as effective as the drugs in the established efficacy group, if not more, but this is how it is. Now, how do we choose the right treatment? So in patients with hypertension who are non-smokers and younger than 60 years old, reasonable options include the beta blockers, metoprolol, propranolol, or timolol, of course, in the absence of contraindications to beta blockers. But in patients with hypertension who are smokers or are older than 60 years old of age, beta blockers should be avoided because they may be associated with higher rate of stroke and other cardiovascular events compared with the other hypertensive drugs such as verapamil or flunarizine. For patients with depression or mood disorders, reasonable options include amitriptyline, venlafaxine, and we will try to avoid in these patients topiramate, which may worsen anxiety and depression. For patients with epilepsy, of course, the reasonable options include valproic or topiramate. For patients with insomnia, we'll choose amitriptyline. For patients with obesity or with high intracranial pressure, topiramate is a reasonable option. And a very important tip, opioids should not be used for the acute or preventive treatment of migraine. Opioid use can contribute to the development of chronic daily headache and can interfere with other preventive therapies. If there is no response to treatment after 8 weeks at an optimal therapeutic dose, of course, we usually switch to a different preventive medication, either in the same class or different class. But unfortunately, we know that 50% responder rate for most of the oral preventive medications is only 45%. In other words, only 45% of people will have a 50% and more decrease in migraine headache days a month. And we must wait at least 4 to 6 weeks on an optimal dose after titration to get any relief. So we have many problems. We have a problem of efficacy, a problem of lack of specificity, because these drugs were not developed initially for migraine. We have adverse events, and mostly a problem of adherence, as we know that 83% are off this medication in 1 year. We also have comorbidities that limit the possibility of using oral prophylactic drugs in some patients. As for now, there are 5, I call it injectable preventive therapies for migraine: botulinum toxin, Botox, 3 monoclonal antibodies targeting calcitonin gene-related peptide, the CGRP, the fremanezumab, the galcanezumab, and the actinezumab, and 1 targeting the CGRP receptor, erenumab. Botulinum toxin A, Botox, is approved for chronic migraine, and erenumab, fremanezumab, and galcanezumab are approved for episodic as well as chronic migraine. The major advantages that all the injectable preventive therapies have in common is that there is no need for gradual dose titration, relatively rapid onset of actions within days, a week, or 2 weeks, and a great tolerability and adherence. What are the indications for initiating treatment with monoclonal antibodies to CGRP peptide or its receptor, according to the American Headache Society positioning statement and the European Headache Federation guideline from 2018, because these are the latest guidelines that we have for the treatment of chronic migraine. And it actually reflects what we usually do for the past 3 years since these drugs were approved by the FDA and other health authorities. So patients with low frequency episodic migraine with 4 to 7 monthly headache days must have both of the following: inability to tolerate due to side effects, or inadequate response to a 6-week trial of at least 2 oral preventive drugs, and at least moderate disability, MIDA score more than 11, HIT6 score more than 15. Patients with high frequency episodic migraine with 8 to 14 monthly headache days only have to prove inability to tolerate due to side effect or inadequate response to at least 2 oral preventive drugs, no functional disability. They could have functional disability, they probably have, but they don't have to prove it. Patients with chronic migraine must demonstrate either inability to tolerate due to side effects or inadequate response to at least 2 oral preventive drugs, or intolerability or inadequate response to Botox. How do we define a success of these or biologic treatments, the monoclonal antibodies to CGRP? So we must have, we must show 3 months of outcome data for patients receiving these treatments, using a headache diary that shows a reduction of at least 50% in headache days compared to their situation before starting the treatment, or clinically meaningful improvement in MIDAS or HIT6, which estimate functional disability with regard to work and to home and social life. In patients with chronic migraine, we asked if preventive treatment with CGRP monoclonal antibodies as compared to placebo effective and safe. So we already know that based on clinical trials and real-world data from all over the world, all the 4 monoclonal antibodies were found effective and safe for the prevention of episodic migraine and chronic migraine. How effective? It seems that all the monoclonal antibodies decreases headache days per month, 1.5 to 3 days per month more than placebo. And another way to look at it is that about 40% of chronic patients achieved more than 50% reduction in monthly headache, in monthly migraine days from baseline to week 12, which means that the 50% responder rate of, for example, from anezumab in chronic migraine, it's quite similar to what we have seen with all the other drugs, is about 40%. Hundreds of trials from around the world in a real-world setting showed even much greater efficacy and no change in the safety profile that were demonstrated in the randomized controlled trials. And based on this excellent efficacy and safety that were demonstrated over 7 years now, 3 years since they're approved by the FDA, and 4 years since they're approved by the FDA, and 3 more years of research, the European Headache Federation has published an update to its guidelines on the Journal of Headache and Pain very recently, a few months ago, that there are actually no reason on clinical grounds to postpone the initiation of these treatments, and that postponing the initiation of CGRP monoclonal antibodies may favor disease progression and chronicity. And they suggested that in individuals with migraine who require preventive treatment, monoclonal antibodies targeting the CGRP pathway should be included as a first-line treatment option. How should other preventive treatments, mainly oral preventive treatment, be managed when using CGRP monoclonal antibodies in patients with migraine? The EHF recommendation, European Headache Federation, recommend stopping oral preventives before initiating CGRP monoclonal antibodies in episodic migraine, but in chronic migraine patients, we should not stop. We should add CGRP monoclonal antibodies to oral preventives and then assess the need for withdrawal. Regarding to Botox, Botox should be stopped anyway prior to use of CGRP monoclonal antibodies, according to the guideline. And the reason for that is that in the randomized clinical trials, treatment with Botox was not allowed. And the other issue is, user is requesting remote control of your screen. You can regain control at any time. Okay, approve, whatever. And the reason for this, treatment with Botox was not allowed in the randomized control trial. And the other issue is that both drugs, the biologic drugs and Botox, are very expensive. But we know now, based on some reports, that's the combination of treatment with Botox with the CGRP mAbs might even offer a synergistic effect or benefit. So in many headache centers, mainly in the US, I think that in Europe as well, they actually do both treatment with Botox and CGRP monoclonal antibodies. The AHS points out that the risk of drug to monoclonal antibodies interactions is minimal because the mechanism is quite specific. And they suggest adding CGRP monoclonal antibody to the existing regimen and assess efficacy before making further changes. But many physicians, including myself, don't like polypharmacy in chronic migraine patients, and specifically those who consume lots of acute medications and are diagnosed with medication overuse headache. On the other hand, we now have evidence from topiramate, Botox, and monoclonal antibodies studies that medication overuse declines and patients get better even without withdrawing them from acute medications. And that's what I do. I don't withdraw my patients from medications, acute medications, before I start with CGRP monoclonal antibodies. Erenumab, for example, reduced migraine frequency and acute medication treatment days in patients with chronic migraine and medication overuse headache, and improved disability and quality of life. When should treatment with monoclonal antibodies be stopped in patients with migraine? Because these drugs are very expensive. So according to the AHS, American Headache Society positioning paper, benefits of CGRP monoclonal antibodies should be assessed after 3 months, and we have to prove a reduction of at least 50% in headache days compared to baseline, or we have to show clinically meaningful improvement in MIDAS or HEAT-6. According to the European Headache Federation, we should consider monoclonal antibodies discontinuation after 6 to 12 months, because there is evidence that sometimes we get a benefit only after 6 months of treatment. Should overuse medication be withdrawn before offering CGRP monoclonal antibodies to patients with chronic migraine? We discussed about this. Both the American Headache Society and the European Headache Federation agree that CGRP monoclonal antibodies can be used before or after the withdrawal of acute medications, as we discussed before. In patients, in which patients should CGRP monoclonal antibodies not be used? So it is not recommended to use these drugs in pregnant or nursing women because the safety was not tested yet. In patients with alcohol or drug abusers, we must be very cautious in patients with cerebral or cardiovascular disease. And having said that, I'm aware of the research that has been done in Erenumab, with Erenumab in patients with angina pectoris, but we still have to be very cautious because we know that CGRP inhibitors actually they inhibit the vasodilation of blood vessels, and that may lead to vasoconstriction. So it's theoretically, but we still have to be cautious. And all of these contraindications are based on the exclusion criteria of the randomized controlled trial rather than real evidence data. What should we do for partial responders? So the EHF has suggested to add an oral preventive medication, and the American Headache Society doesn't have any recommendation. What are the options? So the options are to add preventive oral medication or switch to a different monoclonal antibody if we want to avoid polypharmacy. And we have some evidence now that switching between MABs, even between ligand MAB and to a different ligand MAB, may lead to a totally different response. And we also experience this in our practice. Sometimes I give a certain monoclonal antibodies to a patient, there is no response at all. But when I switch to a different monoclonal antibody, I get even headaches free. So we know that, for example, we have experience with treatments, and we know that patients who respond to one treatment may not respond at all to a different treatment, and we think that the same management should be adopted with CGRP monoclonal antibodies. Now we'll talk about acute treatment. I started my discussion talking about the preventive treatments, which are most important in the management of chronic migraine. But of course, we have to discuss about acute treatments as well, because patients with migraine who consume these acute treatments should be managed as well. And the goals of the acute treatments of patients include, if I had to develop an acute or abortive treatment, the goals would be rapid and consistent freedom from pain and freedom from associated symptoms, especially the most bothersome symptoms, without recurrence. To restore ability to function as fast as we can, to minimize the need for repeat dosing or rescue medications, to get an optimal self-care. The patients must feel that he controls the disease and not the opposite. The disease controls him. And to reduce the subsequent use of resources, such as emergency room visits, diagnostic imaging, ambulatory infusion center, and etc. And we hope that we won't get any side effects or minimal side effects. And of course, we have the cost considerations, because some of these acute treatments are quite expensive. These are the acute treatments with evidence of efficacy in migraine. We have the non-steroidal anti-inflammatory drugs, NSAIDs. We have the non-opioid analgesic, the acetaminophen, or caffeinated analgesic combinations such as aspirin, acetaminophen, and caffeine. And we give these drugs for mild to moderate attacks. And we have migraine-specific agents such as triptans, DHA, and a small molecule CGRP receptor antagonist, the JAPANs. We have the selective serotonin 5-HT1F receptor, the DITANs. That we're going to talk about these drugs specifically in the next slides. But I'm sure that we all know the adverse events that may come up with each of these drugs. NSAIDs can cause serious gastrointestinal, intestinal, and cardiovascular side effects. Triptans and ergot should be avoided or used with caution in patients with coronary artery disease, peripheral vascular disease, in uncontrolled hypertension, and other vascular risk factors. And we have evidence that should suggest that about 30% of patients who were treated with triptans have an insufficient response or a rebound headache. And some patients say that triptans stop their headaches, but make them exhausted and not functional after taking them. So we have two major issues: contraindication to coronary heart disease, cardiovascular disease, and rebound/medication overuse headache. Patients with migraine who need to use acute treatments on a regular basis should be instructed to limit medication use to an average of 2 headache days per month, 2 headache days per week, or up to 9 days per month. And patients who exceed this limit should be offered a preventive treatment. Patients who continue to overuse acute medications while receiving preventive therapy may require a higher dose of preventive medication or adding a second preventive treatment in these patients. We know that medication overuse headache has been found to make headaches less responsive to acute medications, as well as less responsive to preventive treatments for migraine. The newer medications, by the way, the CGRP receptor antagonists and the neuromodulations that we're going to talk about it in the next slides, do not appear to be associated with medication overuse headache, and we'll discuss about this shortly. So the FDA has recently approved or cleared 5 therapies, acute therapies for migraine: the celecoxib, the lasmiditan, the remote electrical neurostimulation, or Nerivio, the rimagepant, and the ubrogepant. We all know the celecoxib, which has been used to treat acute pain since 1998 and is approved now for the acute treatment of migraine. It's an oral solution, and as with other non-steroidal anti-inflammatory drugs, it carries a box warning about the risk of serious cardiovascular thrombotic event, myocardial infarction, and stroke, and is contraindicated in the setting of coronary artery bypass graft surgery. Other safety concerns with celecoxib include an elevated risk of spontaneous bleeding, ulceration and perforation of stomach or intestine, particularly among elderly patients. We have to be very careful, and those with a history of peptic ulcer disease and gastrointestinal bleeding. Lasmiditan is a diton that activates the 5-HT1F receptor, as opposed to 1B and 1D receptors with the older triptan, the elatriptan, the rizatriptan, etc. The most common adverse event of these drugs were dizziness, fatigue, paresthesia, sedation, nausea, and vomiting, and muscle weakness. And lasmiditan has been associated with driving impairment and sleepiness. So patients given a prescription for lasmiditan should be cautioned not to drive within 8 hours after taking their medications. And also, since it's a kind of triptan, it may potentially cause medication overuse headache, as with the older triptans. Lasmiditan was approved as effective as triptans based on positive results from 2 randomized controlled trials, clinical trials, that were evaluating lasmiditan doses of 50, 110, and 200 milligrams. Ubrogepant, Ubrelvy, the first drug in the Japan class to receive FDA approval for the acute treatment of migraine, has shown efficacy in 2 doses, 50 milligrams and 100 milligrams in randomized controlled trials, with an excellent safety and tolerability, as with all the CGRP monoclonal antibodies drugs. What is agepant? It is a small CGRP molecule receptor antagonist. The most common adverse event were nausea, somnolence, and dry mouth, but in very small percentage of the patients, there was no evidence of medication overuse headache or a rebound headache, which is very important. There was no evidence of hepatotoxicity, like with the drugs that were developed before for the abortive treatment of migraine. And the half-life is only 5 to 7 hours, which is great because after 2 days or 3 days, there is no medications in the blood anymore. Pain freedom in 2 hours was achieved in 21% of patients who were treated with the 100 milligrams, and 37% of patients achieved most bothersome symptom freedom. And the most bothersome symptom freedom, I remind you, is nausea, vomiting, photophobia, and photophobia. And 37% of these patients were most bothersome symptoms freedom in 2 hours. The rimagepant, the Nurtec ODT, has demonstrated efficacy and tolerability that was quite similar to Obrelvi, but has a longer life, a longer half-life of 11 hours, and thus is also indicated for prevention in episodic migraine patients and not only for acute abortive treatment. So in one tablet, we get abortive treatment and preventive treatment. Rimagepant, like ubragepant and lasmiditan, does not constrict blood vessels and may have a role in patients with cardiovascular contraindications to treatment. And repeated acute treatment with rimagepant does not appear to be associated with medication overuse headache and rebound, which makes it similar to obrogepant and may distinguish it from lasmiditan, who may cause medication overuse headache. We can also see in this slide that pain freedom was increasing over time from baseline in up to 56% of patients within 8 hours. This is very important. Nerivio is a remote neuromodulation device that was developed in Israel, actually very close to where I live. We put it on the arm, and it stimulates the arm with electricity, in various amplitudes and various frequencies. It achieved therapeutic effects by delivering this transcutaneous electrical stimulation, which induces conditioned pain modulation that activates a descending endogenous analgesia. It was approved by the FDA for the acute treatment of migraine and in adults based on the positive results in randomized controlled trial. It was cleared for the acute treatment of migraine and chronic migraine in patients over 12 years old and older patients, based on data from an open-label single-arm multi-center studies. As with many non-drug therapeutic options, Nerivio has shown good tolerability and safety in clinical trials. Only paresthesia in the arm of the device. This was the most common side effects, and pain freedom was achieved in 37% of the patients after 2 hours versus 18% in a control group. And Nerivio may also reduce the use of medications and the risk for medication overuse headache. And finally, I would like to invite you all to the headache conference that I'm organizing in Tel Aviv every year Professor Christina Tasorelli and Professor Said Ashina, who was also speakers in this conference, are going to be there. Also, Professor Masoud Ashina, the past president of the International Headache Society, Professor Rami Burstein from Harvard, Professor of Neuroscience in Harvard Medical School, Professor Alan Rappaport, past president of the International Headache Society from UCLA, Professor Alexander Moskop, who is the director of the New York Headache Center, Professor Patricia Pozo, who is a professor of neurology in Spain, in Barcelona, and Professor Piero Barbanti, who is a professor of neurology from Rome. And this conference is endorsed by the International Headache Society as well, and I invite you all to join us and to meet in person. Thank you very much.
Thank you very much, Professor Oved, for an excellent presentation. We all learn a lot of it, and of course we have questions. The first questions is about change from baseline for migraine medication using eranumab, and it shows that there are no significant differences between use of 70 and 140 milligrams. How do you decide on the starting dose in your patients?
Yes, so this is a good question. Some of my colleagues start directly from the 140 milligrams because it showed a higher efficacy, but I personally prefer to start with the 70 milligrams for at least a couple of months to see that I don't get any side effects. You know, I prefer to start with the lower dose first to see that there is no side effects before I increase to the 140 milligrams.
Thank you. And if you mentioned about side effects, can you tell some words about what are the most frequent side effects of anti-Cdrp monoclonal antibodies?
So the most bothersome, I would say, side effect from eranumab is the constipation. We have to be very cautious about this. It's very specific, I guess, to blocking the receptor of the CGRP. We don't see that as frequent as it is with the eranumab with the other mAbs, like with frenemanezumab and with galcanezumab, but still we have to be very cautious. Other side effects may be muscle pain, weakness, site reactions like redness and swellowness at the site of the injections. But we know that these drugs are quite safe over 7 years of experience. And we haven't seen red flags that should warn us from using these medications.
Thank you.
Dr. Oved, thank you very much for your presentation. It was wonderful. I want to ask you if you consider these new monoclonal antibodies could be something like disease-modifying drugs, like in parallel with MS. These drugs, if administered early as first line and not a third line, could prevent chronification of migraine. Do you think they could have this value?
Sure, thank you very much for this wonderful questions. I'm not sure if it has neuromodulating effect, but we know that it stops the chronicity. It prevents the transformation of episodic migraine to become chronic migraine. So this is a very important fact for us. And actually, this was the reason why the European Headache Federation has just published an update for the guidelines from 2018, saying that we have to consider these drugs as a first line, to prevent this chronicity to a chronic state. I don't know if there is a neuromodulating effects of these drugs. There is no evidence for that.
Thank you very much.
One question. Thank you very much for your presentation. It seems to me now the last 5 years, we see a revolution in the treatment of migraine, even more revolutionary as the discovery of triptans in 1980s. And this was due to studies in provocation models and biomarkers, blood biomarker studies, with discovery of CGRP, amylin, adrenomedulin, and so on. One question about the association of chronic migraine with white matter lesions that is very frequent in the practice. Is it contraindicated, the administration of MABs? And second situation is chronic migraine is associated with other autonomic disease like Hashimoto thyroid disease, Crohn's disease, rheumatoid arthritis, and so on, lupus. Is it possible to treat with MAB or not? Thanks.
Thanks. So, thank you very much for this question. Very important question, actually. So, regarding the first question, non-specific lesions on the white matter are not contraindicated for the use of these monoclonal antibodies. We don't have evidence that it shows really a problem because there are non-specific lesions. Even in the trials that were made in these monoclonal antibodies, even on patients with angina pectoris and cerebral vascular disease, who were, by the way, not included in the randomized control trial, still in a specific trials that these monoclonal antibodies were tested on angina pectoris and unstable angina pectoris. There was no problem at all to use this CGRP monoclonal antibodies, but I still would be very cautious about using these monoclonal antibodies, because theoretically, CGRP, we all know, CGRP is responsible for the vasodilation of blood vessels. And if we block CGRP, it may cause a constriction of the blood vessels, and that's why theoretically we have to be cautious. But in the clinical trials, we haven't seen any problem with this. Regarding the second questions, since these monoclonal antibodies are very specific, very selective to CGRP, we don't think that there are interactions between other drugs that are also biologic, that are treated in other autonomic disease. The biologic treatments that are used in other autonomic, like in rheumatoid arthritis or rheumatologic disease, are very specific to components of the immune system. And here, these monoclonal antibodies are very selective to a protein, the CGRP, and there is no reason why we get drug interactions between them. So I don't.
They will do well, better result in the second autoimmune disease, maybe. There is no papers.
If you ask the pharmaceutical companies, they will say that there is no data between combining between these biologic treatments, but it makes sense that there is no drug interactions between them, because MABs are very selective to a component. So, and especially that it's not related anyway to the immune system, the drugs that we use in migraine.
Okay, thank you very much.
Okay, you're welcome.
If we have time, I would like to address one more question. I'm pediatric neurologist. And
I'm sorry, we don't have time. Please close the session.
Sorry, I will write it in the chat if it's possible. And we must close our very interesting session. Thank you, Professor Ovid. And I invite next moderators, Professor Moldovano and Professor Lilia Rotaru, to moderate another session.
Dear colleagues, I'm happy to invite you to welcome you to the subcompartment tension type headache as a part of chronic headache compartment within our international conference. As the guest speaker for this subject, we have Professor Said Ashina, and I'd like to introduce him. Said Ashina is an assistant professor of neurology and anesthesia at Harvard Medical School. He is a director of the Comprehensive Headache Center at Beth Israel Diakonis Medical Center affiliated with Harvard Medical School. He is board certified in neurology by the American Board of Psychiatry and Neurology and in headache medicine by United Council for Neurological Subspecialties. Also, he is a member of the Education Committee of International Headache Society and serves as a member of the Classification Subcommittee for the latest edition of International Classification of Headache Disorders. He is training, mentoring, and educating students, residents, and fellows at the Harvard Medical School, and he is the recipient of Enrico GP Award for Excellence in Headache Research. He is actively involved in the research and he has numerous publications, and his research interests include the epidemiology of headache and chronic pain, quantitative sensory testing, human pain models, brain imaging and structural brain lesions in migraine, migraine and vestibular dysfunction, the implication of photophobia in pathophysiology and treatment of migraine, and he is investigator of clinical trials in trigeminal neuralgia and migraine, including clinical trials involving novel treatment in migraine. Today's lecture is entitled Chronic Tension Type Headaches, Classification, Diagnosis, and Management, and we have this lesson in the form of pre-registration. Anyway, the questions that will arise on this report can be addressed live or in chat. They will be answered by Mr. Ashina's research colleague, Mrs. Rigmor Jensen. So our next lecture is Chronic Tension Type Headaches, Classification, Diagnosis, and Management.
Good morning. My name is Said Ashina. I am the Director of Headache Center at BIDMC in Boston, Massachusetts. I'm also Assistant Professor of Neurology and Anesthesia at Harvard Medical School. I would like to thank the organizers of this conference for this great opportunity to give the lecture on the chronic tension type headaches, classification, diagnosis, and management. Here are my disclosures. I would like to start with a few facts about the tension type headache. What do we know about tension type headache? We know that it is the most common type of primary headaches, and we also know that in its chronic form, it is one of the most difficult to treat. Unfortunately, tension type headache has been previously neglected, but lately, in the last few decades, there's been increased interest and improved knowledge about this primary headache disorder. Today, I'm going to be talking about epidemiology of tension type headache. I'm also going to discuss diagnostic criteria and classification, pathophysiology, and treatment of this primary headache disorder. Let's start with epidemiology. Here you see 1-year period prevalence for 3 most common primary headache disorders. These data are based on a population studies, and the most common primary headache disorder here is tension type headache, with a prevalence ranging from 38 to 74%, followed by migraine and cluster headache. Chronic tension type headache accounts for 3% of population. So in other words, 3% of population suffer from chronic tension type headache. On this slide, you see the data from a longitudinal 12-year follow-up study conducted in Denmark by Lundberg and her colleagues, demonstrating that the prevalence of tension type headache increases. you can see that the increase is significant, and it is more pronounced for patients with chronic and frequent episodic tension type headache. In this population study, Lundberg has also shown that among subjects with frequent tension type headache in 1989, 45% had remission when they were evaluated in 2001. 39 had unchanged headaches, and 60% had poor outcome. In other words, they had chronic tension type headache or headache on more than 15 days per month. Now, later we showed also that there are predictors for the poor outcome. So what are these predictors? Chronic tension type headache is a predictor. Coexisting migraine, not being married, sleeping problems, attack duration of more than 72 hours, unilateral headache, and nausea. So these are the predictors for the poor outcome of tension type headache, defined as continuous chronic tension type headache or transformation from episodic to chronic tension type headache. The epidemiological data also show that tension type headache is more common in females than males, very similar to migraine, but less pronounced, with a ratio of 1.2/1. Epidemiological studies teach us that the prevalence of frequent tension type headache is increasing, and the frequent episodic tension type headache has a favorable prognosis, but chronic tension type headache and coexistent migraine predict poor outcome. Let's take a look at diagnostic criteria for tension type headache. It is important to note that diagnosis of tension type headache based on the history, on what the patient is telling you. It is not based on specific imaging findings or specific blood tests, because we don't have a biomarkers for tension type headache. These tests are only being made for ruling out secondary causes of headaches, such as tumors, subdural hematomas, etc. As you see here on the slide, there are two types of tension type headache. Episodic division is made by the number of days per month. So if a person has headaches on 15 or more days per month, then that person is getting diagnosis of chronic tension type headache. If the person has headaches on 15 or less days per month, then this person is getting diagnosis of episodic tension type headache. In order to fulfill criteria for tension type headache, patients must fill the following criteria, two of the following criteria: bilateral location of headache, pressing or tightening quality of pain, mild or moderate intensity of the headache, and the headache must not aggravate by routine physical activities. And both of the following criteria must be met: no nausea or vomiting, mild nausea is allowed in chronic tension type headache, and no more than one of photophobia or phonophobia. A lot of mistakes are being made in practice when we see patients, and patients may be having tension type headache but misdiagnosed with migraine and vice versa. Migraine is a very different headache. It is usually associated with significant nausea, vomiting, photophobia, and phonophobia, and the migraine can be aggravated by routine physical activity. So remember this diagnostic criteria when you're trying to make diagnosis of tension type headache. Here are the potential pathophysiological mechanisms of tension type headache, which involve possible genetic factors. It can involve peripheral and central mechanisms. Peripheral mechanisms include myofascial and, to a lesser degree, vascular factors. They may lead to peripheral sensitization of nociceptors. The central mechanisms involve central sensitization of nociceptive pathways and altered descending pain modulations. Let's start with the concept of referred pain. You may be familiar with acceptable terms of myofascial pain and myofascial trigger points. Dr. Janet Travel, who is next to the President Kennedy on this photo, was an American medical doctor and a personal rheumatologist to the US President John F. Kennedy. She was the first to propose the term of myofascial trigger point in 1942. In 1960, Dr. Travel teamed up with Dr. David Simons to further explore the realm of trigger points and myofascial pain syndrome. In 1983, they both published their work entitled Myofascial Pain and Dysfunction, Trigger Point Manual. This book was a breakthrough in the world of rheumatology, orthopedics, physiotherapy, and neurology. It changed the understanding and treatment approach towards the chronic pain. Since 1983, thousands of physical therapists, doctors, chiropractors, massage therapists, and other health professionals worldwide applied trigger point therapy in their practice. The pathophysiology of trigger points remains an enigma, but a study by Simons and his colleagues have claimed that abnormal electrical activity in focal points, so-called trigger points, may be the problem. And the trigger points may not be painful other than to direct pressure. When the pressure is applied, they may refer to pain elsewhere, as you see on these photos, to adjacent or remote areas. The origin of pain and the area where it manifests can be different. Here are the examples of the referred pain patterns from trigger points in upper trapezius, sternocleidomastoideus muscles, and splenius capitis and cervical muscles. The active myofascial trigger points were found in muscles innervated by trigeminal nerve, such as temporalis, masseter, extraocular muscles, and the muscles innervated by C1, C3 segments, such as sternocleidomastoid, suboccipital, and upper trapezius. Also, patients with chronic tension type headache have more myofascial trigger points than healthy subjects, which may be suggestive of the role of these trigger points in the pathophysiology of tension type headache. Here is an interesting study looking at the pain pattern in individual pericranial muscles. Experimental muscle pain was induced by the standardized infusions of 0.2 milliliter 1 molar hypertonic saline in the 6 craniofacial muscles: masseter, anterior temporalis, posterior temporalis, trapezius, splenius capitis, and sternocleidomastoid muscle in 20 healthy subjects. And here you see the illustration of the subject-based and superimposed drawings of the perceived pain following the infusion of the hypertonic saline into the 6 pericranial muscles. The aim of this study, which was conducted by Schmidt-Hansen at the Danish Headache Center, was investigation of the pain sensitivity of pericranial muscles in patients with tension type headache. The experimental muscle pain was induced by standardized infusions of 0.5 milliliters of 1 molar hypertonic saline into 2 craniofacial muscles, anterior temporalis and masseter muscles. Subjects with frequent episodic and chronic tension type headache drew their habitual pain on the standard anatomical maps. The results from the entire group of subjects are superimposed on the standard drawing and shown here. There was no difference between the episodic and chronic tension type headache patients in the habitual headache pain intensity scores on the VAS. The drawings of the habitual pain demonstrated a pattern of pain localized over the entire visceral cranium, predominantly localized to the frontal and neck regions in the both frequent episodic tension type headache and chronic tension type headache, with no difference in the area of habitual pain between the two groups. Evaluation of tenderness by palpation is an important part of the clinical examination in many patients. In addition, evaluation of tenderness is an important tool in the myofascial pain research and can be part of the quantitative sensory testing. On this figure, you can see that the local tenderness score, which is the mean of right plus left sides, recorded by manual palpation at 8 pericranial regions. The data are presented as a means here. Patients with tension type headache, which are the red bars, were significantly more tender than controls, which are the darker bars. at all locations. The front indicates frontal muscle, MAST indicates mastoid process, which is the insertion of the sternocleidomastoid muscle. MAS indicates masseter muscle, temporal muscle, coronoid process, sternocleidoid muscle, neck muscle inserters, and trapezius muscles. Triple asterisks indicate significant results. The study demonstrated that the increased tenderness in patients with tension type headache cannot be ascribed to certain locations or to certain myofascial tissues, but may be considered general for the pericranial region. Mean total tenderness scores in men and women according to the different headache disorders are shown in this figure. Both in men and in women, significant difference in tenderness between the headache diagnosis was found. In women, tenderness was significantly increased in chronic tension type headache, frequent episodic tension type headache, and in migraine compared with subjects without headache. In men, significant difference was only found between frequent episodic tension type headache and in subjects without headache. Women had significantly higher total tenderness scores than men, and the younger age group, which is not shown in the slide, had a higher total tenderness score than the older age group. The trapezius, neck insertions, and the lateral tigroid muscles were the most tender muscles. This is not shown in this slide. So if we summarize the importance of peripheral factors in tension type headache, we know that muscle tenderness and hardness is increased. Degree of muscle tenderness is significantly related to the headache frequency, intensity, and treatment outcome. Increased muscle tenderness in response to thigh exercise has been shown in patients with tension type headache. Experimental muscle tenderness precedes the headache. Decreased blood flow and muscle flow during the exercise has been shown in patients with tension type headache. To study central mechanisms of tension type headache, Lars Benson and colleagues from Danish Headache Center studied pressure pain detection thresholds, pressure pain tolerance thresholds, and cutaneous electrical pain thresholds. Pressure pain thresholds, as well as tolerance thresholds recorded in the finger, were significantly lower in patients than in controls. A non-significant similar trend was observed in the temple. The relative electrical pain threshold recorded at the labial commissure was significantly decreased in the patients compared with controls. Altogether, these findings of the general hypersensitivity to pain stimuli in the chronic tension type headache indicated that central factors played an important role in the pathogenesis of chronic tension type headache. To better understand the intramuscular and cutaneous pain sensitivity in patients with tension type headache, the intramuscular and cutaneous electrical pain thresholds were assessed by needle electrodes by 3 methods of testing: single pulse, 2 Hz, and 100 Hz in the trapezius muscle and extracephalic muscle, anterior tibial muscle, in 20 patients with chronic tension type headache and 20 healthy controls. P-value is from the 3-way repeated measures ANOVA and post-hoc least squares differences test. The pain thresholds to 3 types of electrical stimulation, so single pulse, 2 Hz, and 100 Hz, were significantly lower in patients than in controls in trapezius muscle and in the skin overlying the trapezius muscle, while the electrical pain thresholds did not differ between the groups in the anterior tibial muscle and skin. So this study demonstrated that the increased sensitivity in nociceptive pathways from the cephalic region may be of more importance in the pathophysiology of chronic tension type headache and could be reflective of the segmental central sensitization. It has been suggested that superthreshold testing might be more sensitive than the threshold measurements in evaluation of central hyperexcitability in pain conditions. Subjective pain ratings measured by visual analog scale to both single and repetitive electrical stimulation with intensity of 1.5 times the individual pain thresholds were assessed in chronic tension type headache patients in this study. The pain ratings to both single and repetitive supraterrestrial electrical stimulations were significantly higher in patients than in controls in the temporal, trapezius, and anterior tibial muscles. In skin, there were also significantly higher pain ratings to both single and repetitive supraterrestrial electrical stimulation in patients than in controls in the temporal, trapezius, and anterior tibial regions. This study provides the evidence for the generalized increased pain sensitivity or hyperalgesia in chronic tension type headache, and strongly suggests that the pain processing in the central nervous system is abnormal in this disorder. There are also imaging studies demonstrating that central sensitization is of importance in patients with tension type headache. In this study, which compared chronic tension type headaches to controls, decrease in the gray matter in the anterior and posterior cingulate cortex, insulae, brainstem, precuneus, and parahippocampus was shown. Decrease in gray matter was correlating positively to headache duration in years. These results indicate that most likely the findings are a consequence of central sensitization. To summarize all this, it has been suggested that the continuous painful input from the pericranial myofascial tissues may induce and maintain the central sensitization such that normally innocuous stimuli become painful, and we have a conversion from episodic to chronic tension type headache. This figure, which is published in the review on tension type headache in the Nature Review Disease Primers, shows the proposed mechanisms of the chronification of tension type headache. You see here that abnormal input from the myofascial structures in the head and neck, and to a lesser degree from vascular structures, results in the sensitization of the peripheral nociceptors. This increased nociceptive input leads to the sensitization of the second order neurons in the spinal trigeminal nucleus and the dorsal horns of the spinal cord at the level of C1 to C4. A beta fibers, which normally only respond to innocuous stimuli, become pronociceptive and pain stimulatory. Dysfunction of the ascending modulatory pain pathways results in decreased inhibition and increased facilitation of nociceptive transmission. This leads to the increased nociceptive input to the thalamus and sensitization of the third order neurons, which set impulses to the cortex. The result is the increased pain perception and chronification of tension type headache. The last part of this presentation will be on the treatment of tension type headache. Treatment of tension type headache can be divided in patient education, non-pharmacological treatment, acute pharmacological treatment, and prophylactic pharmacological treatment. Patient education is a form of non-pharmacological management. It includes information and reassurance about the disease state, information about the treatments, setting realistic expectations when you talk about the treatments and the prognosis, avoidance of trigger factors such as stress, poor sleep, irregular meals, caffeine intake, or too much caffeine, reduced physical activity. Identification and treatment of comorbid disorders such as migraine, depression, anxiety is very important. Physical therapies are probably effective. Relaxation, exercise programs, improvement of posture can be recommended to patients. A biofeedback, relaxation therapy, cognitive behavioral therapy has been shown to be effective. As a matter of fact, that if you combine biofeedback, cognitive behavioral therapy with medical management, it seems to be more effective. Physical therapies which are probably not effective include hot or cold packs, ultrasound, spinal manipulations, and it is questionable whether oromandibular treatments are effective in patients with tension type headache. Acupuncture may be effective for the treatment of the frequent episodic and chronic tension type headache. Psychological therapies offered at our headache center include cognitive behavioral therapy, biofeedback, relaxation training, meditation, psychotherapy, The main aims of these therapies include to reduce headache, to develop coping strategies, to increase quality of life. In summary, non-drug management should always be considered. Information, reassurance, and identification of trigger factors may be rewarding and helpful. IMG biofeedback has a documented effect. Cognitive behavioral therapy and relaxation training are most likely effective. More recently, mindfulness techniques have been implemented in the management of the headaches. Physical therapy and acupuncture may be valuable. Here is the list of acute drug treatments. Drugs with documented effects include ibuprofen, ketoprofen, aspirin, naproxen, diclofenac, paracetamol, and caffeine combination drugs. The questions always come when and which drug to start. It is most likely, but not proven, that ibuprofen 400 milligrams, aspirin 1000 milligrams, ketoprofen 25 milligrams are more effective than paracetamol. The rates for being pain-free 2 hours after treatment are approximately 30%. Ibuprofen and aspirin are recommended as drugs of first choice. So in summary, simple analgesics and NSAIDs are a drug of first choice for the management of acute tension-type headache. Combination analgesics such as containing caffeine are drugs of second choice. Triptans, muscle relaxants, and opioids should not be used. It is very important to avoid frequent use of analgesics, including the caffeine-containing drugs, to prevent medication overuse headaches and the caffeine withdrawal headaches, respectively. Prophylactic drug treatment should be offered or considered in patients with frequent episodic or chronic tension-type headache. Drug of first choice for the management of tension-type headache or chronic tension-type headache is amitriptyline. Drugs of second choice are mirtazapine and venlafaxine. So how to use amitriptyline? How to start this treatment in patients with chronic tension-type headache? It is recommended to start with information about the mechanisms and the side effects of the medication. It is very important to tell the patient that it is not related to depression and that you are not treating the depression and you're treating the pain, the headache. Start low, go slow. Start with 10 or 25 milligrams before bedtime because it can cause drowsiness, but it may also improve the sleep in patients with tension-type headache. Increase with 10 to 25 milligrams per week to 10 to 100 milligrams daily. Usual maintenance dose is anywhere between 30 and 75 milligrams daily. Whole dose should be taken before the bedtime, as I mentioned before. Assess the efficacy with a calendar. Discontinue after 1 month of ineffective treatment. Consider mirtazapine or venlafaxine as the next choice. If effective, consider to taper off every 6 to 12 months. Here, I would like to give you some take-home messages about the treatment of tension-type headache. The correct diagnosis of tension-type headache is very important before starting the treatment, because the treatments of migraine, medication overuse headache, and depression may differ. Non-pharmacological treatments include avoidance of triggers, EMG biofeedback, cognitive behavioral therapy and relaxation training, physical therapy, and acupuncture. Pharmacological treatment include acute treatments, which are the simple analgesics and NSAIDs, and prophylactic treatment, which include antidepressants such as tricyclic antidepressants like amitriptyline or mirtazapine or venlafaxine. Thank you for your attention. I'll be happy to answer to your questions also by email. You can also follow us by Twitter at BIDMC headache.
Please unmute yourself.
Okay, I'd like to thank Ms. Ashina for a comprehensive and useful presentation. And you may move on to question if Rigmor Jansen is present. Or if no, I'd like to make a commentary about epidemiology of tension type headache. Even in the last publication on this topic by Mr. Said Ashina in 2021, I noticed a big difference between the prevalence in China and even USA versus Europe and Denmark. For example, China 10%, Jordan 38%, USA 38%, and European countries more than 80%. And the question is if there is the problem in accuracy or in the design of study. This question arose from the fact that some years ago we conducted the epidemiological study of headaches in Republic of Moldova, and we found the prevalence of tension type headache of about 18%. This is a low figure compared to European ones. Then we interpreted it by the possible high tolerability to pain in our population, population that is subject of historical, political, and social sufferings, so that mild and moderate pain is not recognized as a medical problem. We discovered the phenomenon of denying the fact that one suffers from headache, and at the same time, same person evoking that there are some headaches, like everyone else has, as if having a headache were something natural. We do not exclude that there were also other causes for such a result, or maybe it's a specific of ours. We have a little time for questions.
Yes, but we don't have questions in the question and answer box in the chat. So I think we can save some time and go on. Thank you.
Okay. To the luck, yes, I suggest asking question in the chat if there will be. And I'd like to thank the speaker for presentation and to all participants in this session. And I'd like to pass the baton to the next moderators, Professor Stella Odobescu and Dr. Oksana Grosso. Thank you.
Okay, now we have to move on to Germany, another area from the US, and to another primary headaches, very interesting, fascinating, enigmatic headache with circannual and circadian evolution, cluster headache. And the presenter will be Arne May, a very well-known specialist in the field of headache. He is a professor of neurology at the Department of Systems Neuroscience at the University of Hamburg and head of the headache outpatient clinic on this university. This is the main headache clinic in Germany. His major research interests are the basic mechanism of head pain, the chronification of pain, and human brain plasticity. Human imaging studies in primary headache, including functional MRI studies, as well as experimental studies of trigeminal-vascular nociception, with the aim of understanding how to modulate headache syndrome and chronicity of pain. Arne May published over 300 original and review articles, and since 2016, he is editor-in-chief for Cephalalgia. We can now, Oksana, begin the pre-recorded presentation of Arne May because he is not with us now.
please pin the window to see it bigger.
Okay.
Hello, good morning. This is Arne May speaking from Hamburg. I thank Oksana Grozu and this scientific board of this virtual congress to put cluster headache and related syndromes in particular in such a prominent position. In the next 30 minutes, 30 plus minutes, I hope to achieve three things. To convince you that cluster headache and indeed all TACs are easy to diagnose. Secondly, the fact that whatever pain specialization you are working in, it is really highly probable that you will see such patients. And thirdly, to highlight shortly some pathophysiological aspects of a fascinating disease, and also to focus on how TACs are treated, including new and sometimes very new data. I try now to show you my slides. And I do hope that you can see them and also see here this little duck. No, it's not a duck, it's a canoe. That's Hamburg, actually. Because if you see the canoe, then my pointer is working. I will find out in half an hour. Here you can see where I'm based. That is Hamburg in Germany. Hamburg is perhaps the most, I think, beautiful city in Germany. Based in the very north and next to the sea. It has a huge harbor and beautiful buildings. On the right upper corner, you see the here from the city landmark, the so-called the symphony, the Elb Symphony, and here you see the university where I'm based and working. Let me start with introducing my group. I'm very proud of these young people. I even have some dentists working with me since I'm lately becoming very interested in facial pain. I have some corporations. Since I'm a scientist, I'm funded by national and international groups. And since I will talk about medications, it's very important to point out that I have no conflicts of interest. Since I'm the editor of Cephalalgia and Cephalalgia Reports, I'm requested for transparency reasons not to give lectures or consulting to any pharmaceutical company. This is the UKE, University Clinic Hamburg-Eppendorf. If you walk in here and then down here and then up the corner, they will find the headache special outpatient clinics. We see 1,000 to 2,000 to 1,200 patients per year. We are the largest German headache clinic at the moment. We have a specific even outpatient clinic for trigeminal autonomic clinics patients and also for facial patients. I find, and this is why I nicked this picture from the internet, that cluster headache is an absolutely remarkable disease. It's a headache that strongly differentiates between days and nights and will come up at night. A headache where 23% of patients get one or more teeth extracted before the correct diagnosis. So a lot of them go to the dentist before they see you or me, and none of these teeth extractions, of course, have an effect. A headache that knows exactly when summer is, and then it stops because it's mostly there in autumn and in spring. If you cure this headache locally, then it may change sides, but a headache, when it's there, when it's decided, never changes sides. So you have a headache which is so-called side-locked, only on one side, and you should never in medicine say never, but it's so rare that it does change sides that it's nearly okay to say it does not switch sides. If you, however, cure it locally using stimulation or something like that, then it may switch sides, and that's not uncommon to hear. Here I bring you a clinical case, really absolutely typical. It's a male patient, typical as well, 43 years old, with a facial pain and headache since 6 years. It's episodic. The episodes last for 3 to 4 months. The headache-like pain starts in the upper jaw and then spreads to the eye and sometimes to the temporal region up here. Always one-sided, it never changed side, so side-locked. The pain quality is absolutely extreme, 10 out of 10. Rather exploding, lasts up to 2 to 3 hours, and the patient notes some tearing of the eye, but also a blocked nose, but only on the side. He's not crying, it's really on the side where the pain is. He presented himself at 3 different dentists, one ophthalmologist, 2 neurologists, and had then got teeth extractions twice and new glasses. When he saw us, the clinical examination is absolutely normal neuroimaging, and the medical history is unremarkable, but for a known depression. This kind of disease, really absolutely classic, has been not always been termed cluster headache, but erythroprosopalgia comes from the Greece, red face and pain. So the combination of those was thought to be this kind of headache. People who, medical doctors who really clearly described the disease for the first time in completeness were Robert Bing from Switzerland and Beate Horton from America. And here you see the original publication in German where they, from Bing, where he described these erythroprosopalgie. And really, he put down what we say nowadays is a cluster headache. That's the International Classification of Headache Disorders, of course, and it's an absolutely severe headache. It's around the eye. It goes up to the temple. It lasts 15 minutes, 280 minutes, and it can be 1 attack every other day or up to 8 attacks a day. When these people have this kind of pain, then they have either an autonomic symptom on the side of the pain or a sense of restlessness, or most of them have it both at the same time. Here you see quite nicely how the autonomic symptoms look like. That would be outside of the attack, inside of the attack. You see there is a redness here. Looks like an inflammation. It's a tearing on that side. This guy has an miosis and ptosis, so an Horner syndrome, and the eye was, nose was running as well. This is a very recent study published 1 or 2 months ago in Headache, 1 or 2 months ago and a year ago in Headache, which describes in more than 100 patients just how severe this type of headache is. And you see here that in 1,000 patients asked between 0 and 10, how worse is this kind of pain, that it was nearly always a 9 or a 10. They didn't even start below 7. Now they then compared this type of pain to other pains. And so a large organ biopsy, no one of us wants to have that, would be around 4. A myocardial infarction is around 5. If you break your bone, it's about a 5 again. Migraine attack would be around a 5. Gunshot wound, 6. Nephrolithiasis, really extreme pain, 7. Cluster headache, nearly 10. So it's an absolutely enormous, it's a devastating pain attack. And this is another rather recent study published 2 years ago, 1.5 years ago, which investigated now the diagnostic delay in cluster headache. That means how long does it take between the first symptoms and the correct diagnosis? And although this type of pain is unbearably dreadful, there is still a diagnostic delay of cluster headache. In the 50s, here, it took up to 40 years, and even in the last decade, it was around 4 years. Diagnostic delay was reduced for every decade investigated. And it needs to be pointed out, however, of course, that if there are some atypical cluster headache features, such like length of attacks, side change, aura, and so on, that would obviously play into a prolonged diagnostic delay. Still, one has to say it's very easy to diagnose. Attacks on the same side, really severe, not lasting longer than 2 or 3 hours, and ipsilateral autonomic symptoms. It's as easy as that. Still, the diagnostic delay is years, and that is shameful for doctors, I think. Here you see that cluster headache comes up usually in episodes, and that's why it's called cluster. So if you have 1 year, then most of the year it's free of attacks, and then these clusters, the attacks cluster around one point, and then they stop, and then they cluster around another point, and that's why it's called cluster headache. Most of the patients are episodic. Episodic defined as there is at least in 1 year a attack-free time of 3 months. If it's less than 3 months, it's chronic. And here you can see that some patients never had a episodic-like type, but start with a chronic type, so they never have really medication-free times where they don't have attacks. And it can start episodic and then later secondary become chronic. This is rather older study published 2010. That was just a case report of one man who had a chronic cluster headache and really meticulously put down each single attack, how long it lasted, what kind of medication did he take, what was the moon cycle, what did he eat beforehand, and so on and so on. And he managed in 10 years to nearly document 5,500 attacks. And you can see that in these 5,500 attacks, there was still a clear-cut circadian rhythm. So this is 0, this is 24 hours. You can see that at night, these attacks, they could happen all over the day, but at night, they were significantly more so. And if we put that into a equation for the whole year, you see 0 to 12 months. You see quite nicely that there is a biphasic increase, which was significant again, meaning that the episodic cluster headaches, which are usually the episodes are at specific years of time, so autumn and spring, that even in cluster headache, chronic cluster headache patients, this kind of circannual rhythm, this oscillating over the year, still happens, meaning that in such a patient, he might tell you here that his medication is not working. That is not completely true. It doesn't mean that you have to now switch all kinds of medications. It means he needs, perhaps because the headache cycles and is more severe here in spring, that he may need more medication here, and the usual medication down here. This, I think, is an absolutely remarkable study, and the results still puzzle me. It has been done here by Kuan-Po Peng, who is from Taiwan and works in my group since several years now, fortunately for me. Tsubasa Takisawa, who is from Japan, and Miji Lee, who is from Korea. And they compared the clinical phenotype of cluster headache patients between Caucasian and Asian populations. And there were several smaller differences, but the most striking for me is the fact that chronic cluster headache is rather rare in Asian countries. There is also a stronger male predominance, and the clinical presentation of restlessness was not as common in Asian as it was in European and North American countries. This study means that regional differences in the presentation of cluster headache exist. The authors concluded that greater awareness for cluster headache should be raised in Asian regions, and there is no question that further studies are warranted, I think, to elucidate the mechanisms behind these observed differences. Fascinating, really. There are secondary causes for cluster headache known. Here you see just 2 examples of a macroprolactinoma and another case of pituitary adenoma. Other causes have been described, and it needs to be pointed out that the dissection of the carotid artery can mimic cluster headache and should always be excluded. What is interesting, I think, is the fact that if intracranial pathologies exist, a tumor, a prolactinoma, anything like that, and that causes the cluster headache, that these pathologies can in principle be everywhere in the brain, so really from the top to the bottom, back to front. However, they are more likely to be somewhere in the midline, and no one knows why that is the case. Here you see Peter Goldsby, a younger Peter Goldsby, who 1997, together with Richard Lipton, published in Brain a whole group of patients where what they then coined trigeminal autonomic cephalalgia, and that's where the word TAC comes from. And he just put together that not just cluster headache is such a TAC, but others are as well. And they have all in common that they are strictly half-sided, that they come in attacks, that these attacks are short, and that there are autonomic symptoms at the same side. And so just to follow up on this, TACs, here you see the different ones, and you see they there are different things, but however, the most important one is really the duration of the attacks. So cluster headache up to 180 minutes, paroxysmal hemicrania up to 45 minutes, SUNK syndrome in seconds, and hemicrania continua like ongoing. Hypnic headache is only at night up to 120 minutes. You can see that here is an overlap. So if you have someone within like 15 minutes, 20 minutes, 30 minutes attacks, it could be a cluster headache or it could be a paroxysmal hemicrania. In such cases, it's important to know that indomethacin works in paroxysmal hemicrania and it works in hemicrania continua. And that's the definition at the moment. They always work in 100%. I personally think that's not true. There are patients with paroxysmal hemicrania where they are indomethacin insensitive, but in most patients, that is probably true. Indomethacin does not work in cluster headache, per what people say. I do know that in some cluster patients they do work. So it's not. Of course, medicine is not absolute, and of course, this is not like robotics. But in general, that's true. Cluster headache would not react to indomethacin, whereas paroxysmal hemicrania and hemicrania continua work rather nicely to very small doses of indomethacin. So if you have a patient who is in between these two borders, why not try indomethacin and see whether it works? Starting with three times 25 milligram and then increasing 25 milligrams per day up to 3 times 75 milligrams. You would work then for cluster headache with verapamil. The same holds true for hypnic headache, and for the SUNK syndrome looks like an trigeminal neuralgia, but here really only on one side, always above the eye, and with the tearing and blocked nose. Then you should try then perhaps lamotrigine. So obviously they are all one bunch of syndromes which have the same syndromal pathophysiological background, but because they are distinct in terms of clinics, as you can see here, they are distinct in terms of how you treat them as well. So in summary, clinical part, there are some key symptoms in cluster headache. It's the attack length, it's the pain localization, side locked, it's the autonomic symptoms on the side of the pain. There is a circadian rhythmicity, and these people are restless. They rock or they run around. This really is a how to say that, a spot diagnosis. That's a 32-year-old man with extreme, strictly left-sided headaches with stinging character, fluctuating intensity since 20 hours, and ipsilateral autonomic symptoms. Rather nicely, a Horner syndrome on that side, redness of the eye, tearing of the eye, and this redness here as well. But that it was not a cluster headache. There is a red flag up here, and the red flag would be since 20 hours. We have talked about cluster headache. Cluster headache is the longest 3 hours, usually 1 hour or 2 hours, maybe up to 3 hours, but not 20 hours. So something is wrong. Of course, you need to do an image there, and then write quite nicely a dissection of the carotid, of the internal carotid, could be shown. That would be the spot diagnosis. It looks like a cluster headache. It's a differential diagnosis. However, it's another kind of disease. That would be the most important differential diagnosis in acute attacks that never happened before. This is a study which was, I think, important to know. Here, Charlie Gaul and Stefan Evers asked cluster headache patients to draw on a map where it hurts most. And you can see the more reddish it is, the more it hurt on that side. So really around, on the temple, around the eye. But there are people who say it goes down here into the face, remember the dentist, and it goes down here into the neck, meaning this is what you expect, but it could happen somewhere else. And rather rarely, I oversee now 3 to 4 patients who have a cluster headache only in the back and not in the front. It seems that these patients have no or little autonomic symptoms when it's only in the back. This study I found rather interesting as well. It's a bit older, 2007, and here 9 patients with cluster headache were looked after, and you see that in these patients, the autonomic symptoms were on the side of the headache, ipsilateral. However, it was a little bit on the other side as well. So it looks as if the autonomic symptoms, if you look closely enough in these autonomic attacks on both sides, but they're more prominent on the side of the headache attack. So maybe it's a bilateral disease which is just prompted to be on one side, so the other side is somehow compressed, it does not come out. Now, if you treat it locally, it could well be that it comes out on the other side as well. That would explain why it then shifts sides. This study is just to point out that these autonomic symptoms can also occur in migraine patients and may be presented in up to 40% of patients with migraine. This is not to make you confused. It just shows that the presence of autonomic symptoms alone does not allow for the diagnosis of a trigeminal autonomic headache. The length of the attack is very, very important. If you have autonomic symptoms in a patient who has an attack that takes 24 hours, then it's a migraine with autonomic symptoms. If you have these autonomic symptoms in the patient where the attacks are just 1 hour, then it's more likely to be a cluster headache. So only really the combination of attack length and autonomic symptoms on the same side allows the diagnosis after secondary causes, of course, have been excluded. Now pathophysiology. Cluster headache, the why and the where. We have to explain, if we want to explain cluster headache, we have to explain why it's a trigeminal pain only, not somewhere else in the body, why it's more in the first division. It may spread to the face, remember the dentist, but it's more really likely behind the eye and up to the temple. And then we have to explain the autonomic activation on the same side, which is not there in only 3% of patients. We have to explain then the circadian rhythmicity, and we have to explain the good response to high flow oxygen. And please allow me here to cite Peter Goldsby, who said, it is, so some of you could think, why do I want to know where it really comes from? It's enough if I can diagnose it and then treat. And Peter Goldsby said, it is in principle, really always in principle, useful to understand as much as one can about the basis of a disorder, because cluster headache patients are remarkably well informed. They can also be remarkably assertive about the way they're well informed. It's not a bad idea to know something about what you're talking about. It's a very good idea that if you don't know what you're talking about, maybe it's best to say, not very much really, because the patient may know and read a lot. Is there any kind of trigger? Yeah, there is. Triggers are alcohol and triggers are histamine, and they would make in controls a slight immediate headache, histamine, nitroglycerin, for example. In migraine, they would give you a migraine-like headache, but after some time, sometimes up to several hours until the cluster headache comes up. In cluster headache, it's completely different. A cluster headache, if you drink alcohol, in the next 20 minutes, they will have the full-blown attack. However, only in the bout. Outside of the bout, they can drink as much alcohol as they want. Bout would be the active period when they can have these attacks. So outside of the bout, when they are episodic, then they can drink alcohol, but inside the bout, it's a catastrophe if they do. This means that there is not a human model that can mimic cluster headache. So it's not that we can somehow in humans or animals mimic these kind of diseases, but you can mimic it at the very moment the pathophysiology is involved. So if someone has a cluster headache attack and you give them histamine or alcohol, these attacks come up. And you cannot evoke attacks when between bouts. Why do I talk about this? This is important to know because you can prevent attacks, as you might know, and as I tell you in a minute, if you use a prophylactic like verapamil. But verapamil, however, can prevent attacks, but it cannot prevent active episodes, meaning, as I tell my patients, you have somewhere in the brain like a switch. And if the switch goes on, then you are able to get attacks. If you then drink alcohol, you will get an attack, and the attacks come in spontaneous as well. Now, if we give you verapamil, then that means that we do not interfere with the switch. We cannot do that. What we can do is we can, in the periphery, help you that these attacks don't break through. Meaning, the very moment we take away verapamil, and if the switch is still on, then the attacks come up again. Now, if the switch itself goes off by itself, and we can't change that, and we cannot make it happen, But if it's off, then obviously, and now comes the consequence of all of that, that means that patients need verapamil not when they're off, when the switch is off. And that means, and I see a lot of patients still who take verapamil for the whole year, although they have only 2 months of attacks. It means here to explain to the patient what happens in terms of central switches, and that we can only work in the periphery, and then that they themselves have to find out when these headache attacks go down again and when the episode stops. And then they can stop verapamil and they don't have to take it for the rest of their life. This was one of the early ideas why this kind of headache comes up. This is a carotid artery, and with the carotid artery come up some trigeminal trigeminal fibers. And these fibers go then here with the carotid artery through the cavernous sinus. And that is very narrow, and there's a bony canal. And if there's an inflammation here, then they would have that the trigeminal nerves are pressed to the bony canal. And that would give a pain on the same side. And at the same time, here, some through the cavernous sinus, some autonomic fibers go through. And because if you have the pain on the same side, at the same time, you get then the autonomic symptoms of tearing of the eye and a blocked nose or running nose. However, we cannot, with this idea, explain why it's strictly half-sided. We cannot explain why it comes in attacks and oscillating attacks, if you want so. We cannot explain the circadian rhythmicity or the annual rhythmicity. And this was a rather old study now where cluster patients went into the scanner and were asked to lay completely still and have an attack after nitroglycerin. And you can see that when they do there are some activations in the brain here in yellow. And this is just the so-called pain matrix, meaning they have pain while lying in the scanner. This here was new. This was not seen in other pain studies, like here in healthy controls. This is next to the hypothalamus and explains why these patients have these kind of attacks. And here quite nicely see that this one study was then replicated by several times, really, and always in these kind of headache syndromes, this activation here in the hypothalamus comes up, meaning that hemicrania continua, Parkinson's hemicrania, Sunk syndrome, they all are really one class of headaches, but remember, they are one class. They have one reason, so one cause, how to come up, a generator in the brain next to the hypothalamus, which turns on the attacks and turns off the attacks, but they are slightly different. We don't know really why they are different, and they're differently treated. Still, it's really reassuring that this one study here was replicated so many times. And this is, all of this was really, most of this was PET studies. This is now an fMRI study. And we could show that this activation here in the hypothalamus is in the inactive cluster most activated, in the active cluster less, and in the healthy controls it wasn't. Meaning there seems to be an oscillating activation in this region, and this oscillating activation explains why some patients go in and outside of the bout. Now there is so much evidence now that the hypothalamus, this is the third ventricle, that the hypothalamus here is activated in these attacks, that an Italian group, Francini et al., did a deep brain stimulation like in Parkinson's disease in exactly this region here. And they could show here, this is an older study and some, but with the same result, that really around 50% of patients have a good response with less attacks, and that, or even no attacks anymore. Meaning you can switch on and switch off if you hit the right spot in the hypothalamus. This is a rather newer study here in meta-analysis of other studies and among 40 patients from 4 different cohorts that represents about 50% of all previously published cases. The authors here found and described a significant reduction in headache attack frequency over a mean follow-up of 44 months, with an overall response rate of 75%. This is really solid. Positive outcome, however, was not associated with clinical baseline covariates, so you couldn't beforehand say who will have an effect. And they identified 2 hotspots of stimulation covering the midbrain ventral and retrorubral tegmentum. Here, if you hit really in these spots, then it's most likely that you can stop these attacks in these patients. So summary, pathophysiology, the major players of the pathophysiology background, you can see here, it's the trigeminal ganglion, it's the trigeminal nuclei, it's the, and the information would come in here, then go up to the hypothalamus and thalamus. You see the cavernous sinus that we talked about. You see the sympathetic fibers going through the cavernous sinus. You see the parasympathetic fibers here connected to the SSN. So, and a functional connectivity between the trigeminal nuclei and the SSN. So an information coming in here would then be relayed through TNC and C1 and C2, then goes up to the thalamus, but also goes up to the SSN and has a parasympathetic output through the ganglion pterygopalatine. The underlying pathomechanism is characterized by a synchronized abnormal activity, what we believe now here in the hypothalamus, and the trigeminal vascular and the autonomic nervous system. And based on all what I told you and the clinical neuroimaging data and also the findings of neuromodulation techniques, a fundamental role of the hypothalamus in the initiation of an episode and the generation of an attack seems likely, whereas an activation of the peripheral nerve system may be required for the occurrence of the this kind of pain. So this is probably the generator. It doesn't mean that the nociceptor is here. The pain is not generated here. Something is generated that disturbs the whole system, and that gives then these kind of attacks. Now we come up to the last part, and that is treatment. And when we first talk about acute or abortive treatment, that it needs to be mentioned that by and large, cluster headache is the only headache that responds to inhalation of oxygen, of pure 100% oxygen. There are several well-done placebo-controlled RCTs now published, and if you prescribe oxygen, you should always insist on 7 to 12 liters and 100% high-flow oxygen delivered via a rebreathing or a demand valve, rebreathing mask or demand valve. So if a patient tells you oxygen does not work, then ask him how did she take the oxygen. And if it's less than 7 liters, then you don't know whether oxygen works or not. If it's 12 liters and it didn't work using a rebreathing mask, then they are one of the 30 to 40% of patients where oxygen does not work. But you should insist on to try out 100% oxygen, 7 to 12 liters. Triptans, all the triptans do work, and actually we know that in all these medications, the triptans in terms of tablets also do work. However, they take too long. So the attacks are very short, so you don't want to just take a tablet and wait for 40 minutes until these kind of attacks go away. This means that sumatriptan subcut or a nasal spray is the medication of choice. And we know that a lot of patients with the zolmitriptan nasal spray have a very good response in the next 5 to 8 minutes. One could try lidocaine. If you try lidocaine, you should give it ipsilateral to the pain. Not ipsilateral to, lidocaine, that's the point. You need to put ipsilateral to the pain. So the patient needs to lie down, and then when the attack is on the right-hand side, put the lidocaine into the right-hand side and spray it really deep into the nose. What you want to then have is that there's a numbness here between the eyes. Then it's more likely that it works. If you use, however, a triptan spray, then you wanted to use it on the other side where the pain is not. Remember, you have autonomic symptoms, the nose is blocked or running, and if you then put the nasal spray on the same side, it can't work. So you need to do the sumatriptan, the triptan spray, on the contralateral side. If you use lidocaine, you have to put it on the ipsilateral side. Here you see the preventative medications, and verapamil really is our working horse, and we start with 3 times 80 milligrams. It's very important to use ECGs as well. And this is a study published 2021, a multi-center study that showed that oral prednisolone, if you give it in a short-term preventative therapy in this population of patients, then you have a positive effect, meaning cortisone does work rather nicely. Cortisone has a problem of huge side effects. So you give it in the beginning, 100 milligram for a week, and then you go 20 milligrams down and taper it out. Because you want to use verapamil. Verapamil you can't put in so fast. And to bridge the thing until the time until verapamil does work, there is now a good study telling you that it would be a good idea to use prednisolone for 5 days. So that would be the working horse. Never forget the ECG. Then we know that lithium works rather nicely, either in combination or alone, and with topiramate it's the same. These two have more side effects. This is why we usually start with verapamil, going up to 500-600 milligrams, then going down to 400 if it doesn't work into monotherapy, and then add on lithium or add on topiramate. Then the big question now, of course, is whether the medications that work in migraine and are thought to be medications that have a specific effect on the trigeminal nerve, the medications that involve CGRP, and here the CGRP antibodies, whether they do work. And here you see studies published that galcanezumab has shown to be efficacious. It reduced the frequency of attacks in episodic cluster headache, but not in chronic cluster headache. While fremanezumab failed its primary endpoint in episodic cluster headache, and both fremanezumab and galcanezumab trials in chronic were terminated because it didn't work. This means that CGRP antibodies are recommended only for episodic cluster headache patients. And if so, then galcanezumab is more likely to be given. It's approved in America by the FDA, but it's not approved by the EMA, so the European authorities, meaning that it can be prescribed in the US, but it cannot be prescribed in Europe. That having said, here you see open trials. Now we know that the double-blind studies failed. In open studies here, more and more case series are published that CGRP antibodies are effective in some cluster headache patients. And here's this recent publication about it. I find it important to say that we need more data and studies, and should still now consider to treat patients if all other medications fail. Then you should go to the insurance company and say, look, everything fails. We should try in these patients before we start to operate. What else can you do? Here you see that there are some possibilities, most of them not well studied, certainly not double-blind studies. This I find very important. A diagnostic and therapeutic blockade. It's very easy. You cannot do much wrong. And it's effective in a lot of headache patients, actually, and also in cluster headache patients. So what you do is you go to the back of the head, interestingly. So they have the headache here. Still, if you block the occipital nerve here, which is a purely sensory nerve, you can have an effect on the trigeminal nerve. So what you do is you put your thumb here on the back of your head, and that's the occiput. And then you put your index finger here on the mastoid. So you go otherwise this way, and then with your thumb you go from the mastoid down, from the occiput down to the mastoid. So in this trajectory, I show it here. In this trajectory, go down and you just press. When you do that, then the patient will say at some point, that's different. Here is something different. Maybe it's more problematic on the side where they have the cluster headache and on the other side. Then you know where the GON, the greater occipital nerve, goes around the bone here and then goes up as a sensory nerve to the back of the head. You could then take 4 milliliter of lidocaine and 4 milligram dexamethasone and then inject it in here. Not much you can do wrong. And we do have patients who are then for a week or even 2 weeks, some for a month, completely medication free. So that this is really easy to do, less side effects, and it's really a practical tip to try out. We even do it in trigeminal neuralgia, and it does work in patients who have, for example, MS. And you know, if the combination of multiple sclerosis and trigeminal neuralgia is very hard to treat, and then it's a trick to do this kind of thing and help a lot of these patients. And I do have patients who come only every 3 months, get an injection, and are nearly pain-free and medication-free for the next 3 months. There's just one other possibility. There is the transcutaneous stimulation of the vagus nerve using the gamma core device, which looks like this. And that has been shown to be effective in episodic cluster headache in 2 randomized sham-controlled trials, so really robust evidence. And here are just 2 case series who have shown that it may also be effective in acetac, which in future is certainly interesting for patients who are unable to tolerate indomethacin. We talked about indomethacin, and if that doesn't work, you either try gabapentin. So you have someone where you think it must be a TAC. It is probably because it's 40-minute attacks, paroxysmal hemicrania. And if then indomethacin doesn't work, then don't let everything let your heart sink. What you do is you try gabapentin, starting with 300 milligrams per day and then tapering up to 1,900 or 2,400 milligrams. And you have very good possibility that you can help these patients. The other possibility would be to describe this one here, and patients can use it themselves. There's a little battery in here, and these patients may have less cluster headache attacks, and it does work in patients where indomethacin worked as well. There are several of these possibilities that you can use. We talked about the pathophysiology, and if you interfere here in the hypothalamus and stop the hypothalamus, then the attacks go away. If you interfere with the occipital gon block here, then a lot of these patients have less attacks. If you interfere here with the ganglion ptericopalatinum, and there is a stimulator used or has been tried and showed in 2 double-blind studies that it does work, then cluster headache goes away. So we can modulate cluster headache on different sides and TACs as well. And we just have to work out in which patients, which kind of stimulation, in combination perhaps with medications, has the biggest opportunity to work. And what I just showed here is the gamma core that would then work as a vagal stimulation. So that would be HOPSA, that would be this here, and you stimulate the vagal nerve on that one side. And here would be the block, here would be stimulation. And I talked about this one, and I talked about this one. So in summary, I'm pretty sure I talked too long already. Cluster headache has some key features: unilateral orbitotemporal pain. It has autonomic symptoms on the same side, and it has a circadian and circadian rhythmicity. The hypothalamus, I hoped I could demonstrate, is a central modulator of that, and it shows next to and this has been like underpinned by neuroimaging, really, but not only neuroimaging, but there are some blunted hormonal rhythms, and they are blunted because the hypothalamus isn't working so well. And don't forget, if we do hypothalamic DBS, we can stop these attacks in 75% of patients. Treatment attacks, oxygen would be in cluster headache would be really efficacious, but not in the other attacks. Triptans are efficacious in cluster headache, not necessarily in the other attacks. If you give triptans, then subcut or intranasal. Verapamil is the medication of choice, and then additive if that is not working alone, to pyrimid or lithium. And if all that fails, probably CGRP antibodies, and there cortisone you can use to bridge. We talked about the gon block, and we didn't talk about this one, but invasive procedures. Intranasal capsaicin, that's just capsaicin like a chili, and if you put that into your nose as a medication. So ask the apothecary to give you capsaicin, 0.01% into the nose on the side of the pain 3 times a day is really painful, but a lot of patients have then less attacks later on. This would be, because it's so painful, like third way medication. This is what first choice medication, what you should try, of course. And if you do all that, then it's rather likely that you can help. And with this, I thank you very much for your attention. And I hope that I talked about what you wanted to hear. And I wish you a nice ongoing Congress. Bye.
Thank you very much, dear Professor Arne May. This is really the most brilliant presentation that I ever have seen before, with many, many practical tricks and tricks for our neurologists. Very useful in the clinical practice. Only some comments, especially regarding the long diagnostic delay. The same situation in Moldova and the same situation with sometimes teeth extraction. That is a bad experience, and I don't believe that in Germany it's possible, this bad experience. But this experience is international. And I would like to let you know some situation in our headache center when patients with migraine come with typical manifestation of migraine and with autonomic unilateral features. In this case, the differential diagnostic between migraine and cluster headache arises, and the duration of attack is the important. So for migraine, more than 4 hours, for cluster headache, no more than 3 hours. And it is important to rule out some secondary causes of headache. We have some situation with prolactinomas and pituitary adenoma with like a secondary cause of headache. And it is very useful and necessary to perform indomethacin test when you are in between chronic paroxysmal hemicrania or cluster headache. Concerning this device, vagal nerve stimulation device, a very nice treatment, a very new treatment, a little bit costly for Republic of Moldova. The price is between $10,000 and up to $25,000. But it is useful in migraine, in chronic migraine, and in cluster headache. Thank you very much.
I think now it's time to move on. So the next moderator will be Dr. Adina Roceanu and Dr. Adrian Lupșor. And we welcome, warm welcome to Professor Rigmor Jensen.
Me? Can you hear me?
Oui, yes.
Yeah. Hello, good afternoon, everybody. It's such a great pleasure to give this talk. I would love to be with you. I was there some years ago, and it was a wonderful experience. And I highly appreciate and admire your dedication to the headache world and or for organizing this Congress in these difficult times. I hope you all are safe and your families as well. So let me share the screen.
Professor Rigmor Jensen, we have like a short presentation, please.
Yeah. Okay. So I have it here. Yes. And I will go it like we start. Here we are. Okay. And I'm happy to. Can you see my screen?
Yes, we can.
Good.
Can you put?
Yeah. It's in mode, yeah, and I'm also happy to help with Said Ashina's question about tension type headache if he didn't make it. So these are my potential conflicts of interest. So classification on the non-migraine headaches, and most of the headaches that we deal with are. Can you hear me? Yeah, are with the non-migraine headache, but I would talk about the secondary headaches and mostly on the non-vascular intracranial disorder, high and low, and also to medication overuse. So these are my topics today, but we could take a whole Congress about the secondary headaches because they are really interesting and we can learn so much. So as you know, that it is the leading cause of years lived with disability. We don't die from headache, but we live many, many years. And these are the global burden disease studies that we have. And that here in the green colors here, it is migraine and tension type headache that are affecting so many people all over the world are living with disability. And migraine, including medication overuse, is the second largest cause of years lost to disability, and in young females also number one. So there's a lot to do with medication overuse, and we really have to work on that because it's a secondary headache. So it's a migraine and a medication overuse. It's the tension type headache and a medication overuse. But again, the correct diagnosis, as I heard in cluster headache, is absolutely mandatory to give the right treatment. And we see many patients that have both migraine and cluster headache and are misdiagnosed, especially women. So it's extremely important. And so there are 8 most important questions. Do we have one or several? Take one by one and describe them. And that's where we see these that have both my normal migraines and my severe ones. And what are the severe ones? They often cluster headache as well. And it could be medication overuse. How long does it last? Very important question and easy to get. How frequent are they? Once a month or daily? What do you do? Again, do it like in a dark room, very quiet, and or you pace around. Then you have already the diagnosis of a cluster headache. What is the intensity? Where is the pain located? Are there any associated symptoms? And do you take medication? And yes, how much and how frequent? Extremely important. And here we have the most important questions. It's simple. We can teach our students to do it. We can teach our GPs to do it. And so with this instrument, it's not so difficult to diagnose headache disorders. So very important. And also the red flags are here. If you have a new type of headache, it's different from a migraine, you have to be alert. It could be a secondary headache. It could be a red flag for something more serious. So, and the question number 2, how long does it last? Is a second, trigeminal neuralgia, CPH in minutes, cluster headache half an hour, or 2 hours, 3 hours, migraines, tension type headache if it's a chronic one. And if it is there all the time, it could be a medication overuse or chronic migraine or a combination of these things. So, and we also have to remember, if you sit in a very level 3 high specialist center and a very advanced, then you see the most severely affected patients. You see the most complicated patient. But if you sit in a private practice, see other kind of patient. Or if you sit in GPs, so it is the more tension type headache. It is more normal migraines and not the chronic one. So there is a different distribution where you are, and you have to adjust your education, your interest. Where are you sitting? Because it's not necessarily reflecting all the headaches that you see. You see the most difficult one, the complicated ones, maybe with comorbidity. So the typical chronic headache patient, it is 2 to 8%. I know that you have a lot of medication overuse, much chronic headache in Moldova, more females than males. They come with a daily headache. They have fatigue, they have GI problems, they have poor sleep. They may even have fertility because I will come back to that. They have anxiety and depression, and maybe also cognitive problems, and they are afraid of that. Of course, if you don't sleep, you feel tired, you feel exhausted, and you can't remember anything. Maybe you have a migraine-like headache sometimes, and then you have the normal background headache. It is a mix, and it makes it more complicated. But if you give them a diary, you can probably get a lot of information there, because most patients cannot describe it. I have it every day, doctor. It's there from morning to late night, and it's this and this. Sometimes it's bad, sometimes it's not that bad, but I have to take medication every day. So it's a mix, but you have to take it out. So we give them a simple calendar. It could be electronic, it could be a paper one. We use both because some patients prefer this and others. And you can see that they have 3 crosses, a migraine, a severe one. This is more an attention type headache, but very, very simple, that there's headache every day, different intensities. And the letters here indicate that they take triptans or paracetamol or drugs all every day. So simple. 1 month, 2 months, you can have it. It's a daily headache, no surprise. Daily intake of painkillers. It looks like there is a diet of tablets because they are desperate, and it's classified as a chronic migraine and a medication use. So you have a primary and you have a secondary. It's important also to have a treatment plan. So the characteristics are that you have the red ones, the normal migraines, but at some point it become more and more frequent, and it more and more intense, and you are never down to baseline. And there's frequency, severe intensity, long attacks. It could also be attention type headache. It's not restricted to migraine. It could also be a post-traumatic headache that you take too much medication for. So the secondary headaches can also have a component of medication overuse. It's very important to even cluster headache can have it. So and a diary and a calendar gives so much information. There's a reduced effect of acute medication, and they take more and more. And they, of course, because they are depressed and anxiety, disability is poor and low quality because it's difficult to take care of the family and the job and everything. So they become depressed. So definition, simple analgesics, 15 days or more per month, not the number of analgesics that we had in old days. If it is triptans, opioids, or combination, it's only 10 days or more per month. So we have a simple saying that 2 days per week, it's enough to trigger a medication overuse. But it should have lasted for 3 months or more, not for 1 week, not for 1 month where you have surgery or something else. But headache patients are much more prone to this, and that's an interesting thing. So again, 1 to 2% prevalence vary across countries, and you have a higher one in Moldova. More women, high cost because they are desperate. These patients, they have it. Everything is there, and usually it's migraine or tension type headache that is there, but it can also be in other types of headaches. So always have that in mind. If there's a progression, there's a more daily intake of medication. So it's a vicious circle. They have their migraine, they become more and more dependent on medication. They have relief, but it comes back, and it's only hours and hours, and then we are increasing the number of tablets. They always have tablets on them, in their bags, in the drawer, in the desk. They have medication everywhere. That's really a sign of this. So they take more. What is the mechanism behind that? Very interesting, because we don't see it in many other patients with pain disorders in the same way, or we haven't identified in patients with arthritis or arthrosis that can take it. But patients that have an underlying headache, genetics or pathophysiology, they are much more prone to this, and it is a central sensitization. They have lowered pain threshold, lower concentration of the cannabinoid system, serotonin, and we can see that there's changes in the scannings. We can't do much with genetics, but there is a genetic component, probably also a genetic component. We have seen that in recent studies. And the psychological mechanism, they are more dependent on their drugs. They are desperate if they don't have it. But interesting piece. So it has been discussed a lot whether it's substance related or is it iatrogen, because we prescribe more and more medication to a patient. So it's also a thing that we as doctors has to acknowledge that we should be careful about these things. We see the whole complex mechanism of CDRP. I'm sure you have seen that as already, but if you take morphine and triptans, they upregulate your receptors, cyclic AMP. You have increased CDRP expression and release, and then you increase your migraines, and it become a chronic migraine. Even paracetamol can you see increase of spreading depression, and also the NSAIDs are giving something if you take it every day, and recently we have also documented that simple painkillers and simple NSAIDs, they can also affect your sex hormones. So females, they have more problems with getting pregnant, and males have lower testosterone. So there's also something there. It's not, there's no free ride here. So paracetamol and NSAIDs and opioids, they are drugs, and it's very important to acknowledge that. And in animal studies, these are, if you give a rat a triptan or paracetamol, and here is sumatriptan and naratriptan, for only 6 days, you can see there's an uprate. In the beginning, there is here, I can see whether you can see the mouse here, there is an increased threshold. That means a better pain sensitivity here, but after 6 days it goes the other way around. There's this hyperalgesia, that they are more sensitive. They don't get medication, but it takes up to 3 weeks before they're normal. And the same, oops, here we are, and it is the same with, if you copy that in opioids, in paracetamol, it takes so long time. And if you re-expose them to drug here, again after 21 days, they immediately switch back. And we can understand that because we can look at the tridimensional and see what upregulating here is, that the CDRP and substance P are upregulated already after 6 days. But it continues to be upregulated after 21 days. And it's exactly the same that we see in patients, that they are much more prone, as they have had medication overuse once, they can be prone to it again. So treatment, education, 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 also doctors' education, not only the patient, but okay, and whether we should do this preventive medication before, or is prevent withdrawal necessary? This is the treatment path that we wrote some years ago with Hans-Christoph Diener, that the education and counseling, very important, because many of them don't know that. They think they have to take painkillers, but they are not interested in prophylactics. They have to take it out for at least 2 weeks, 4 weeks. We say 8 weeks here. In Netherlands, they say 12 weeks. And give them prevention. And I will come back to, and cognitive, that stress management and biofeedback. Those that are really severely affected with opioids, barbiturate, benzos, we usually consider inpatient treatment because they are difficult to work with. But prevention, 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 that they do not come to overuse opioids or barbiturate. This is a study from Latin America and Europe, 5 countries in Europe, here, como estas, and we see the frequency of headaches before medication overuse and withdrawal plus preventive. It was the old drugs, beta blockers, whatever we had at that time. And it was extremely useful just after 1 month, and very few of these preventives had the same effect. And it has also a significant effect on medication, pain intensity, cost, quality of life, depression, and anxiety. We didn't do anything for the depression, anxiety, but it was a function of the headache. And 78% reverted to episodic headache. And we don't see that with all the expensive antibodies or very expensive drugs that we have now to chronic migraine. So it is really cost effective, and it is very useful for the patient that they can come back to that. And it is also cost effective for the healthcare cost. You can see here, it's either medication, visits. A lot of investigations have been used in these patients before because they're chronic headache. They want scans and x-rays and all these things that are not necessary here. So you can treat their medication overuse. You can also reduce the cost. So it's cost effective. So should we take the medication completely or after? We did that study that it was restricted and that, and took so-called cold turkey without any medication in 2 months, except for little sedatives in the first day, and antiemetics. It was allowed, but it was more effective with complete than reduced intake. Very important. And also we asked them after 12 months, was it difficult to do a complete withdrawal, or was it not so difficult? It was. And to our surprise, we saw that those blue with a complete withdrawal, they found it much more easy than those that had restricted 2 days a week, because they always had to argue whether they should take it today or tomorrow or save them to the next day. So I always compare it with quit smoking, and it's also difficult to do two cigarettes a day instead of 20 cigarettes a day. Better to stop completely, but it's easy to say. It's not so easy always to do. So complete withdrawal. We also about the preventive medication, we discussed that, and whether it was complete withdrawal, a Danish model here in 2 months, prevention alone here in the orange dots, or withdrawal plus prevention. And we saw that it was more effective with withdrawal plus preventive at the same time, and it was the highest chance to be episodic and also faster than it was. But and we followed them for 12 months and saw that as well. So it was so now our strategy is to withdraw them completely from the beginning and put them on preventives. So because it was in favor of that quality of life and dependent score as well. So, but it is always a discussion with the patient. Where are they? And but we as doctors has to think about it. So, existing strategies here is education and education, primary prevention, extremely important. We had an awareness campaign to general population, and the sooner the better, because it's really important to give this awareness that drugs are drugs and they should not be taken every day. Withdrawal and then preventives, and it's indicate a proper use of healthcare resources, proper use of the acute treatments, and education and withdrawal are effective. And start with migraine. It could be beta blocker, candacetan, calcium blocker, what you have in your armamentarium, not necessarily the expensive ones, because they haven't had a head-to-head comparison by now. But beta blockers, they're simple and easy to use as well. So then I'll say a few words about the high pressure headaches. They are rare. They were rare in old days, but with increasing obesity that we see idiopathic intracranial hypertension, we see more and more, and we have about 400 in our clinic now with high intracranial pressure, more females than males, and they have the headache, a different headache. It may look like a migraine, look like attention diabetic, but it doesn't respond to anything. They have papilledema and they are at risk of losing their vision. They have pulsating tinnitus, like that. You have to ask them because they don't say it. They are obese, you can see that, and they have a high pressure, ICP. They have also these emotional symptoms as other chronic headache patients, but they have also clear cognitive symptoms. The concentration, memory, they are slow. They're slow cerebrated. They are encephalopathic. They come late and say, why are you coming so late? You are losing your vision, my dear girl. But they think it's just a headache, but it's not just a headache. So they have blurred vision. They may have visual loss, but it comes gradually over time. And if you don't look for it, you don't see the papilledema. And the patient we have lost patients with this vision, and they're completely blind now. It's irreversible. So they are obese, you can see that. And you have the headache that's different, and we work on mechanisms. So it's closely related to obesity. And as you know, as neurologists, that there is this balance between production and drainage of CSF. We know very little actually about this, also in normal conditions. We know that we have high ICP, the high pressure things, and it's the same here. It's not a tumor. In old days, we called it soda tumor, but it is, we don't know exactly what is going on here. And the criteria are based on expert opinions, papilledema, normal exam, normal imaging, normal CSF, and high pressure. But there is a gray zone here about this, because some of them are in here in between, and in obese individuals, it can be difficult to be relaxed. So up to 40% of our patients have a wrong diagnosis. They are overdiagnosed and few are underdiagnosed. So it is a difficult diagnosis to give and extremely important. A simple thing, how do you position your patient during a lumbar puncture? Because if you have bent knees and bent neck, then you can increase your pressure with up to 10 centimeter. So it's extremely important that they are extended, they are relaxed as much as you can with a needle in your back. But it is extremely important because you can modify the pressure so much, and then you come to wrong decision and wrong diagnosis. We try to work on non-invasive ICP measurements. We do, because it's a snapshot with an LP. And I don't know whether you do it. Many countries, it's the anesthesiologists that do the lumbar puncture. Here we do it ourselves. The MRIs are not specific. Many have empty cellar or party empty cellar because you are young and you are obese. So it's not a diagnostic criteria in itself. We do ultrasound of the optic nerve and compared to the lumbar puncture. And there is a very close correlation to the optic nerve sheet diameter here. You can see it here. And you can see the optic disc elevation. If you're not good at the direct ophthalmoscopy, it can be difficult, but you can visualize it here. And it is very closely related to the opening pressure of the ICP. And it's atraumatic. It takes 10 minutes and fairly easy to learn. And you are probably familiar with ultrasound. So here you have the patient before. They have the diameter of 0.7, but after the lumbar puncture, just half an hour, it's reduced with 14%, very dynamic, whereas the optic disc elevation is more stable. And here we have a normal person that also have lumbar puncture, and you can see it's much smaller. So an easy way to do it, and you can do it again and again. The headache is very difficult to manage. It doesn't respond to the usually triptans and usual drugs. It looks like other ICP headaches and chronic migraine like. They have also medication overuse, and it's still present after the pressure is normalized after 1 year in half a patient. So it's a trigger. What is the mechanism? Topiramate can be used, but again, you know, topiramate has all the cognitive side effects, and these patients are cognitively impaired in already. So Another thing that we work on is the common link between obesity, migraine, and IIH, systemic inflammation, CDRP release, and increase CSD, photophobia, and these animals. So we needed an animal model, and we have developed that with fat rats, diet-induced rats, and we can monitor the intracranial pressure for up to 50 days, 2 months. And yes, they are higher ICP all the time. Here, the red dots, and it is closely related to the abdominal fat. So it's the abdominal fat that is the trigger here. It's not the BMI in itself. And they have also a lower threshold, so they are more pain sensitive. So it could be a trigger for both migraine and IIH and other headache types with the obesity. And we can also see that they have papilledema, these rats, and they have atrophy of the optic nerve, you see here. So it's also closely related to the ICP. So, and we look at trigeminal ganglion, we can see the gene expression, that they have also increased expression of CDRP and TRP1. So it is interesting. It's a new model for brain water production and regulation, but it could also be a model for drug testing and chronic migraine. So it's an exciting field. And we also have to look to the what is going on in the general physiology about brain water. I have learned that the CSF come out of the villi acnoidalis in the sagittal sinus, but that's probably not correct. So it could only be in the pathological stages, whereas the physiological, less than half of the CSF, the half liter that we produce every day, goes that way. It runs out through the nose, it runs out to the other cranial nerves, it runs out here to the basal foramina. So there are perineural spaces, that are perivascular spaces that it goes out in. So very, very interesting. Also with the glymphatic system that has been described, they are running. So it's much more in general physiology that we don't know. And can we understand that, we may also understand some of the headaches. So here is from Norwegian group that have scanned with a tracer IIH patient versus a reference group and compared them. You see the tracer is very restricted outflow of it, whereas in reference group in more healthy subjects that you get rid of the tracer very quickly, but they don't do it in IIH. The glymphatic system is impaired in IIH, and they can quantify it in different areas. It's the fourth ventricle, lateral ventricle, and third, and it makes sense, but it's a difficult study to do. And lastly, but not least, the low pressure headaches. They are very interesting, and there's new things going on there as well. They have also chronic headache. They have low ICP. They have tinnitus and impaired hearing, and they can even come with cognitive impairment and dementia. And they have an orthostatic headache. You know it from post-lumbar puncture headaches. As soon as they come up, they have a severe headache and vomit, and when they lie down, they are okay. But it looks like a new daily persistent headache after some months, after some years, and very difficult to. So every patient that you have with a chronic headache, chronic daily headache, or new daily persistent headache, ask them, how did it start? How did it start? Did it start from one day to another? Then you have to go into this history, even years after. You know it from the, if they have a spinal anesthesia, they have a spinal tap or something like that, the low pressure. Don't use this to measure that, because it's usually normal, and we have to work on these criteria because they're not good, and you give them another trauma with a new LP. But it has developed in temporal relation to this, so it's sudden onset, usually sudden onset and that's very important to work on. And look at the brain imaging with gadolinium. They have sagging or Pachymenon enhancement. Then you look for a defect in dura. These are signs and symptoms from a large study from London. Autostatic headache is the key element here, the key sign, and then a lot of very different one, even cognitive symptoms here. I had a patient that was diagnosed with frontotemporal dementia, and she turned up to have this autostatic headache, a spontaneous. We identify a leak, and she is healthy now. So but she presented with a dementia. So it's really, really tricky one, but wonderful to work with because you can cure them. They present with a headache, but miming chronic migraine, a new daily persistent over time. In their study, it was from 1 day to 20 years. Again, history. And leaks are different described. Be a spur, a bone spore. It could be a diverticulum. It could be a fistula, and it could be unknown. And we have a series now of 60 patients, and we see more and more fistula here, but it's tricky to work with. And again, look, when you do lumbar puncture, use the atraumatic needle because they have much less post-dural puncture. But even after post-dural puncture, it works to give them a blood patch in the lumbar region, and that's what we do. And if it doesn't work with blood patch, non-targeted, we go for try to identify the spur where it is, and the surgery or blood patch, targeted blood patch. But it's complicated, it's time demanding, and need a specialist. So the take-home message: have many phases, coexist, exciting mechanisms. The secondary can be challenging, extremely important to identify them. It's a symptom of something else, and they can have more than one. They can have migraine and a secondary one, and it's important to find them. So we run the master's program in University of Copenhagen, and it's very exciting, and we have students from all over the world. It's really exciting to run, and it's so rewarding to have headache specialists. So I invite you from Eastern Europe as well, from Moldova, and you're more than welcome. We had many good, excellent students that has graduated, and we start a new group again. So thank you so much.
Thank you very much, Professor Rigmor, for this marvelous presentation. Professor Rigmor is the co-founder of Danish Headache Center since 2001 and director of this Danish Headache Center from 2011, and was awarded as Global Excellence in Health. Professor Rigmor, it's dedicated to education, and we all thanks to Professor Rigmor. She had more than 500 scientific papers, more than 28 PhD theses, and more than 50 postgraduate master projects. And since 2016, this international academic master education in headache disorders in Copenhagen University gave us new possibility. We saw that education is very important for patients and for doctors equally. And thank you very much for this exquisite presentation. Because you represent for us the Mecca in headache research, I want to ask you, with new class of monoclonal antibodies, Anti-Cdrp, usually, we think that will be reserved to most severe patients with chronic migraine and also with drug-induced headache, migraine medication overuse headache. In your experience, it is important to have first the detoxification identification of the patient, or we could start directly with monoclonal antibodies.
In our program, thanks a lot, Adina. In our program, we always require that they are out of medication overuse before we start them. With that's a restriction they should have. We are only allowed to give patients with chronic migraine these new drugs if they do not have medication overuse, if they have tried beta blocker, antihypertensive, and at least one of the antiepileptics without success. So we detoxify them, withdraw them for the overuse first, and then we see what's left. And as you saw, the majority they go back to episodic headache afterwards, and so there's no need to give them the expensive drugs on top of all the others. But of course, there can be difficult patients that cannot withdraw, but we really prioritize it as number one. But of course, the antibodies also work in those with medication overuse. But you use a lot of resources on a thing that could be treated less expensive and also better for the patient. But I know in US they don't care about medication overuse, and it is nearly a bad word because they all have medication overuse, all their chronic migraine patients. Yes. So, and they're afraid to say to the patient that they should withdraw, because then they are sued or drawn into court. But that's a tradition we have in Scandinavia, and it's also in many places in Northern Europe, that try to take the trigger away first. Yeah, and then you can treat it afterwards when you see what's left. And you also have to remember that it is really good with antibodies, but it's not a miracle. It is not only half of the patient responds to it. So I would love to go into this and see whether those with medication overuse could do even better if they were withdrawn with antibodies, because that's also how should you spend your money. We are all short of money and in most countries. So how can we give most of our patients the best treatment and with less drugs? They're still drugs. So that's my opinion. I know that it is different opinion, different countries, but at least information is extremely important.
Yes, thank you very much. And
yeah,
of course, education is very important for the patient.
Absolutely, absolutely. And
I'm sorry. Thank you very much for your very useful, interesting, and great presentation. And speaking about trigger factors, just now being returned from European Sleep Research Society that have been in Athena, so they are speaking a lot about circadian rhythms, disruptions, sleep disorders, and here you have mentioned about the glymphatic system and hypertension, and also this is important factor, trigger factor. So what do you think about circadian rhythm disruptions, sleep disruptions, and headache? Because, for example, the same glymphatic system is very dependent, and actually it takes place more during the night.
Excellent question, and the short answer, I don't know, because I don't know enough about the glymphatic system in patients, and most of the evidence that is there is in animals, and I'm about to set it up in my animal model, and I would love to do it, but it's difficult to study in humans, but extremely exciting mechanism, and it makes sense. And probably you agree when you have heard about all the sleep investigations that is going on, and sleep is a good thing for many migraine patients because it is relieve their headaches, but it is also a trigger for others, and we have obstructive sleep apnea, we have the sleep disorders that give headaches, and so there's a close connection here, but still it's in the early days, and I would love to know much more about these things. But exciting field. Many scientists, they still don't believe in the glymphatic system, but I do, and it makes so much sense for our headache patients.
One more question about sleep apnea and morning headache. You have mentioned as a symptom morning headache in patients with intracranial hypertension. So how we would make the difference between a morning headache because of a sleep apnea syndrome and the morning headache because of intracranial hypertension?
I can't. I do if I'm in doubt. I can't do it clinically, but I have access for a sleep lab. So I do this, but I recently had a case, a 52-year-old woman. She was a woman. She was overweight, and I did a sleep investigation. I did a LP, and she had fulfilled all the criteria, both for mild sleep apnea and IIH. She had a gastric band operation. She lost 40 kilos. She still had sleep problems because she couldn't lie down. And then we did a ICP investigation, and she has completely normal pressure during the day, but during the night she had B waves all the time, boop, 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 and very high pressure. And she had lost weight, she had been on a medication, she has done everything. So there's something wrong in her glymphatic system there. So she had slept in a sitting position for last 5-6 years, actually. That's exciting, and what is going on, we don't know. But yeah. I'm happy to take questions about tension type headache if you don't have the time with Saida Sheena. He texted me. Have you had?
Yes,
yeah.
We have sometimes.
Yeah,
and
okay.
I think I will address a question about tension type headache. Do you know why in Denmark there are so many tension type headache and so few in Moldova?
Yeah, probably because we record it. Because we ask, do you have one or more types of headache? And what we did in our epidemiological study was that we asked, have you ever had headache? This and this is this type. And many other studies, do you suffer from headache? And that's another thing, because if you have one tension type headache once a month or once a year, they have had it, they have the experience, and have a 1 year prevalence or lifetime prevalence, but they never suffer from it. They never go to a GP for it. So that was my point also with the, they don't go to GPs with a tension type headache. They don't go to you as a specialist, Oksana, with a tension type headache. They come for their migraine, their chronic daily headache, whatever that is. But if you ask them, most of the migraine patients have their normal headaches, their background headaches, and their migraines. So what is this normal headache? And it could be a medication overuse again, but it could also be a tension type headache. And the exciting, interesting things is that we record all the types of headache in the headache center and see that most of them have tension type headache as well. Give them diagnosis of migraine, cluster, tension type headache, and medication. So we can give them up 4 or 5 diagnoses and not only one. And when the antibodies now used, please notice in the publications that the migraine days go down. The moderate to severe headache days go down, but they're mild headaches, they are the same. So what is this? They don't know, they don't record it, and they don't like tension type headache. But if we had a good drug to tension type headache, it would be a bestseller. But we don't see them in the specialized clinics in the same way as they do in GPs. And go to a school, go to a gymnasium. I asked my students the other day, there were 2 out of 20 that had migraines. And but there were 16 of them that had tension type headache when they don't sleep, if they have exams and so on. but they have never gone to a GP for that. So they have it, but it's not a big issue in the specialized clinic where you see the severe ones. But ask them, but they're not necessarily that they suffer from it. So it's a simple question: do you have it, or have you had it, or have you suffered from it?
Thank you, Professor Jensen. So Dr. Adina Rocianu will close the session, and we will move on.
I wish you all the best and hope to see you soon again.
Thank you very much, Professor Rigmor, for this presentation and for all the things you do to improve education in a headache field. And I think this session is closed, and will be a break until the next session in 2:30. Thank you. Have a good lunch. Thank you.
Thanks to all speakers for the first session.
Atunci când te doare capul, e ca și când cu Fasconal acționezi împotriva durerii de cap.
Acesta este un medicament. Citiți cu atenție prospectul. Dacă apar manifestări neplăcute, adresați-vă medicului sau farmacistului.
Fasconal pune capac durerii de cap.
Among this material, we find a comparison between mexazolam and alprazolam, the summary from a poster presented at the 32nd ECNP Congress, held in Copenhagen in September 2019, the abstract of which is published as a supplement in the December 2019 issue of the journal European Neuropsychopharmacology. Are all benzodiazepines the same? In clinical terms, the choice of a specific benzodiazepine should take into account its pharmacodynamic and pharmacokinetic properties. This study focuses on pharmacodynamics, reflecting the affinity of benzodiazepines for different subunits of the GABA-A receptor. We know that benzodiazepine-sensitive GABA-A receptors play a critical role in mediating inhibitory neurotransmission. We also know that not all GABA-A receptors in the central nervous system function the same way. While benzodiazepines with higher affinity for receptors containing alpha-1 subunits may be more important for regulating sleep, benzodiazepines with higher affinity for receptors containing the alpha-2 and/or alpha-3 subunits may be more important for regulating anxiety. Here we share the results of a study conducted to determine the affinity of chloranor-diazepam, the main plasma-active metabolite of mexazolam, to different GABA-A receptor subtypes. The affinity of alprazolam for the different GABA-A receptor subtypes was determined for the purposes of comparison and justification of the clinical benefit of mexazolam. The manual patch clamp technique, an electrophysiological technique used to measure ionic currents, was used to perform this experiment. Cell lines were prepared with stable expressions of human GABA-A receptors with the subunits alpha-1, alpha-2, alpha-3, or alpha-5. All GABA-A receptor subtypes prepared were stimulated by GABA in the presence or absence of successive increasing and cumulative concentrations of the molecule being tested. In this case, the active metabolite of mexazolam, chloranor-diazepam. The same technique was then applied with the comparator alprazolam. For both molecules, the effect on peak current amplitude, which is a proxy for the therapeutic effect of the drug, was assessed, as well as the effect on current decay time, which is thought to be related to the time required for the receptor to return to its basal state in order to be stimulated again. Chloranor-diazepam, the main active metabolite of mexazolam, showed effects on peak current amplitude mostly with GABA-A receptors containing the alpha-2 and alpha-3 subunits, with a small effect on alpha-5 and no effect on alpha-1. The observed effect on GABA-A current decay time was different from the peak current amplitude, with chloranor-diazepam showing a greater effect on GABA-A receptors containing the alpha-1 subunit and a less marked effect on alpha-2, alpha-3, and alpha-5. By increasing the recovery time from activation of GABA-A receptors containing the alpha-1 subunit, chloranor-diazepam may decrease the frequency of activation of this receptor's subtype. Alprazolam showed an effect on the peak current amplitude only in GABA-A receptors containing alpha-1 and alpha-3 subunits, with no effect on alpha-2 or alpha-5. For current decay time, there was no differentiation between GABA-A receptors containing alpha-1, alpha-2, and alpha-3 subunits, and a lower effect on receptors containing the alpha-5 subunit in comparison to the other subunits. In conclusion, the absence of effect of chloranor-diazepam on the peak current amplitude for alpha-1, together with its greater effect on current decay time in this subunit, may be related to a lower frequency of activation of these receptors and, consequently, less sedation. Furthermore, the fact that chloranor-diazepam exhibited an effect on GABA-A receptors containing both the alpha-2 and alpha-3 subunits, which have been more associated with the anxiolytic effects of benzodiazepines, may give mexazolam a more effective anxiolytic action compared with alprazolam, which showed no action on alpha-2 subunits of GABA-A receptors. The effect of alprazolam on the peak current amplitude of GABA-A receptors containing the alpha-1 subunit may explain why alprazolam is more likely than chloranor-diazepam to induce sedative adverse events and may potentially be associated with a greater interference on psychomotor performance. We thus conclude that mexazolam shows a greater anxiolytic effect, where alprazolam shows a greater sedative effect. Although this is a non-clinical study, the information obtained provides a potential explanation for the results obtained from previous clinical trials involving mexazolam. The electrophysiological studies described in this paper were carried out by a company independent of BIAL. Thank you for your attention.
Atunci când te doare capul, e ca și când... Cu Fasconal acționezi împotriva durerii de cap.
Acesta este un medicament. Citiți cu atenție prospectul. Dacă apar manifestări neplăcute, adresați-vă medicului sau farmacistului.
Fasconal pune capac durerii de cap.
Among this material, we find a comparison between mexazolam and alprazolam, the summary from a poster presented at the 32nd ECNP Congress, held in Copenhagen in September 2019, the abstract of which is published as a supplement in the December 2019 issue of the journal European Neuropsychopharmacology. Are all benzodiazepines the same? In clinical terms, the choice of a specific benzodiazepine should take into account its pharmacodynamic and pharmacokinetic properties. This study focuses on pharmacodynamics, reflecting the affinity of benzodiazepines for different subunits of the GABA-A receptor. We know that benzodiazepine-sensitive GABA-A receptors play a critical role in mediating inhibitory neurotransmission. We also know that not all GABA-A receptors in the central nervous system function the same way. While benzodiazepines with higher affinity for receptors containing alpha-1 subunits may be more important for regulating sleep, benzodiazepines with higher affinity for receptors containing the alpha-2 and/or alpha-3 subunits may be more important for regulating anxiety. Here we share the results of a study conducted to determine the affinity of chloranor-diazepam, the main plasma-active metabolite of mexazolam, to different GABA-A receptor subtypes. The affinity of alprazolam for the different GABA-A receptor subtypes was determined for the purposes of comparison and justification of the clinical benefit of mexazolam. The manual patch clamp technique, an electrophysiological technique used to measure ionic currents, was used to perform this experiment. Cell lines were prepared with stable expressions of human GABA-A receptors with the subunits alpha-1, alpha-2, alpha-3, or alpha-5. All GABA-A receptor subtypes prepared were stimulated by GABA in the presence or absence of successive increasing and cumulative concentrations of the molecule being tested. In this case, the active metabolite of mexazolam, chloranor-diazepam. The same technique was then applied with the comparator alprazolam. For both molecules, the effect on peak current amplitude, which is a proxy for the therapeutic effect of the drug, was assessed, as well as the effect on current decay time, which is thought to be related to the time required for the receptor to return to its basal state in order to be stimulated again. Chloranor-diazepam, the main active metabolite of mexazolam, showed effects on peak current amplitude mostly with GABA-A receptors containing the alpha-2 and alpha-3 subunits, with a small effect on alpha-5 and no effect on alpha-1. The observed effect on GABA-A current decay time was different from the peak current amplitude, with chloranor-diazepam showing a greater effect on GABA-A receptors containing the alpha-1 subunit and a less marked effect on alpha-2, alpha-3, and alpha-5. By increasing the recovery time from activation of GABA-A receptors containing the alpha-1 subunit, chloranor-diazepam may decrease the frequency of activation of this receptor subtype. Alprazolam showed an effect on the peak current amplitude only in GABA-A receptors containing alpha-1 and alpha-3 subunits, with no effect on alpha-2 or alpha-5. For current decay time, there was no differentiation between GABA-A receptors containing alpha-1, alpha-2, and alpha-3 subunits, and a lower effect on receptors containing the alpha-5 subunit in comparison to the other subunits. In conclusion, the absence of effect of chloranor-diazepam on the peak current amplitude for alpha-1, together with its greater effect on current decay time in this subunit, may be related to a lower frequency of activation of these receptors and, consequently, less sedation. Furthermore, the fact that chloranor-diazepam exhibited an effect on GABA-A receptors containing both the alpha-2 and alpha-3 subunits, which have been more associated with the anxiolytic effects of benzodiazepines, may give mexazolam a more effective anxiolytic action compared with alprazolam, which showed no action on alpha-2 subunits of GABA-A receptors. The effect of alprazolam on the peak current amplitude of GABA-A receptors containing the alpha-1 subunit may explain why alprazolam is more likely than chloranor-diazepam to induce sedative adverse events and may potentially be associated with a greater interference on psychomotor performance. We thus conclude that mexazolam shows a greater anxiolytic effect, where alprazolam shows a greater sedative effect. Although this is a non-clinical study, the information obtained provides a potential explanation for the results obtained from previous clinical trials involving mexazolam. The electrophysiological studies described in this paper were carried out by a company independent of BL. Thank you for your attention.
Atunci când te doare capul, e ca și când... Cu Fasconal acționezi împotriva durerii de cap.
Acesta este un medicament. Citiți cu atenție prospectul. Dacă apar manifestări neplăcute, adresați-vă medicului sau farmacistului.
Fasconal. Pune capac durerii de cap.
we find a comparison between mexazolam and alprazolam. The summary from a poster presented at the 32nd ECNP Congress, held in Copenhagen in September 2019, the abstract of which is published as a supplement in the December 2019 issue of the journal European Neuropsychopharmacology. Are all benzodiazepines the same? In clinical terms, the choice of a specific benzodiazepine should take into account its pharmacodynamic and pharmacokinetic properties. This study focuses on pharmacodynamics, reflecting the affinity of benzodiazepines for different subunits of the GABA-A receptor. We know that benzodiazepine-sensitive GABA-A receptors play a critical role in mediating inhibitory neurotransmission. We also know that not all GABA-A receptors in the central nervous system function the same way. While benzodiazepines with higher affinity for receptors containing alpha-1 subunits may be more important for regulating sleep, benzodiazepines with higher affinity for receptors containing the alpha-2 and/or alpha-3 subunits may be more important for regulating anxiety. Here we share the results of a study conducted to determine the affinity of chloranor-diazepam, the main plasma-active metabolite of mexazolam, to different GABA-A receptor subtypes. The affinity of alprazolam for the different GABA-A receptor subtypes was determined for the purposes of comparison and justification of the clinical benefit of mexazolam. The manual patch clamp technique, an electrophysiological technique used to measure ionic currents, was used to perform this experiment. Cell lines were prepared with stable expressions of human GABA-A receptors with the subunits alpha-1, alpha-2, alpha-3, or alpha-5. All GABA-A receptor subtypes prepared were stimulated by GABA in the presence or absence of successive increasing and cumulative concentrations of the molecule being tested. In this case, the active metabolite of mexazolam, chloranor-diazepam. The same technique was then applied with the comparator alprazolam. For both molecules, the effect on peak current amplitude, which is a proxy for the therapeutic effect of the drug, was assessed, as well as the effect on current decay time, which is thought to be related to the time required for the receptor to return to its basal state in order to be stimulated again. Chloranor-diazepam, the main active metabolite of mexazolam, showed effects on peak current amplitude mostly with GABA-A receptors containing the alpha-2 and alpha-3 subunits, with a small effect on alpha-5 and no effect on alpha-1. The observed effect on GABA-A current decay time was different from the peak current amplitude, with chloranor-diazepam showing a greater effect on GABA-A receptors containing the alpha-1 subunit and a less marked effect on alpha-2, alpha-3, and alpha-5. By increasing the recovery time from activation of GABA-A receptors containing the alpha-1 subunit, chloranor-diazepam may decrease the frequency of activation of this receptor's subtype. Alprazolam showed an effect on the peak current amplitude only in GABA-A receptors containing alpha-1 and alpha-3 subunits, with no effect on alpha-2 or alpha-5. For current decay time, there was no differentiation between GABA-A receptors containing alpha-1, alpha-2, and alpha-3 subunits, and a lower effect on receptors containing the alpha-5 subunit in comparison to the other subunits. In conclusion, the absence of effect of chloranor-diazepam on the peak current amplitude for alpha-1, together with its greater effect on current decay time in this subunit, may be related to a lower frequency of activation of these receptors and, consequently, less sedation. Furthermore, the fact that chloranor-diazepam exhibited an effect on GABA-A receptors containing both the alpha-2 and alpha-3 subunits, which have been more associated with the anxiolytic effects of benzodiazepines, may give mexazolam a more effective anxiolytic action compared with alprazolam, which showed no action on alpha-2 subunits of GABA-A receptors. The effect of alprazolam on the peak current amplitude of GABA-A receptors containing the alpha-1 subunit may explain why alprazolam is more likely than chloranor-diazepam to induce sedative adverse events and may potentially be associated with a greater interference on psychomotor performance. We thus conclude that mexazolam shows a greater anxiolytic effect, where alprazolam shows a greater sedative effect. Although this is a non-clinical study, the information obtained provides a potential explanation for the results obtained from previous clinical trials involving mexazolam. The electrophysiological studies described in this paper were carried out by a company independent of BIAL. Thank you for your attention.
So, dear colleagues, good afternoon. We continue the next part of our pain congress. And now I would like to introduce Professor Rolf Ditlev Treed. Before to invite Mr. Professor to give his speech, I would like to say some word to our auditory to be more informed about the personality of our guest. So Professor Rolf Ditlev Treed is professor in neurophysiology and deputy managing director of the Mannheim Center for Translational Neuroscience of the Ruprecht Karls University, Heidelberg in Mannheim, Germany. And also Professor Treed is the president of German Association of Scientific Medical Societies and past president of the German Physiological Society, and also past president of International Association for the Study of Pain, and the past chair of Special Interest Group on Neuropathic Pain. He is co-authored and author of more than 450 publications in journals and books. So now is the presentation of a wide and complicated work about classification of chronic pain syndromes. And Mr. Professor, you have the tour to present your speech.
Oh, thank you very much, Adrian Belil, and also to Oksana Grosso for inviting me. And now I have to see, I see a button where I can allow the presentation. And this changes appearance on my screen. And hopefully you can see what I'm doing. And maybe you can even see a cursor, hopefully. All right. Yeah, so yeah, I'm very happy to be here and talk about classification of pain. Now, classification is an extremely dry topic. Nobody really likes it, but I've received feedback from patient organizations who feel that it actually might improve their situation if their conditions are classified in a better way. And there are other implications that this may have in daily life. So I will present the classification that started as an IASP product, but then became part of the World Health Organization's own international classification on diseases and related health problems. So it's no longer ISPs, it's actually the World Health Organization classification. I have lots of slides on that. I will not show all of them extensively, just give you some examples. All of that can be searched freely on the internet, so you can look for things that you're interested in. The big question is whether such a classification has any effects in real life. And we have published a number of studies, so-called field trials, which I think demonstrate that it has implications in real life once you have implemented it. Now the big topic is it's not implemented automatically. A famous date is January 1st of this year. But the only thing that happened January 1st this year is that it is permitted to report death counts based on ICD-11. And there's a 5-year transition period before countries have to do it that way. It's basically a software change and that's it. Morbidity classification is really a national competence, and I'm sure the Moldovan Pain Society is working with the ZIP program of EFIC on trying to move things in your countries, and everybody has to get it going in their own place. And this may make it actually interesting to you. You saw my conflicts of interest, so I think we can now move into the topic. So the first thing we had to define is what's chronic pain. And there are wonderful conceptual definitions: pain without a warning function, or pain that has outlasted the normal healing process. The problem is that we cannot operationalize these criteria in any way with few exceptions. And therefore, we took The same step like many other conditions, very stupid. We took a time criterion, 3 months. This was a consensus among different fields from headache, acute pain, all the way to chronic musculoskeletal pain, that this would be a fairly meaningful cutoff. You've heard Anne Mai just a little while ago, and he told me that for the field of migraine headaches, it was very important that at some point it was defined as between 3 hours and 3 days. And if it's beyond 72 hours, people were not included in the clinical trials. And this is what we think should happen in chronic pain. Clinically, of course, you can be a little bit more flexible, but for research, it's very important. So it's very important to keep in mind, this is supposed to be a starting point, not an end. Starting point for more systematic handling of pain, and that is all types of pain. We'll get to that in a moment. So that's a stupid definition, 3 months. And then when is it important to code it? When you need to treat it. And it could be a symptom of something else. In many cases it is. And then that something else might already take care of the pain, but maybe not. And therefore, even in those cases, we call them chronic secondary pain syndromes, it is very important to use these codes for some patients. And then sometimes there's chronic pain as a disease. If you don't like the term, you can call it a chronic primary pain condition, but it's the same thing. And in both cases, we need specific diagnostics, treatment, rehabilitation, and everything. And the inspiration came from the headache field, but there are also other fields that have a similar distinction between primary, which is a disease, and secondary, which is a symptom of something else. This is a complex slide. Fortunately, it has been published, so you can look it up. It's open access paper. So we have chronic pain divided into 7 subcategories. So chronic primary pain is 1, and we have 6 additional chronic secondary pain categories. 3 of them are etiology related. So if it's related to cancer, it's treatment, to surgery or other trauma, or a disease or lesion of the nervous system, neuropathic pain. And Ralph Baron will talk after me in more detail about that. And then the other 3 categories are more systems-based. So we actually duplicate the headache classification. It's basically a cross-reference. And we, that is ISP, Headache Society, and many other people noticed that orofacial pain didn't really have a good classification yet. So the orofacial pain specialists between 2016 and 2018 created their own classification, which is also part here. And then we have the vast field of chronic secondary visceral and chronic secondary musculoskeletal pain. So this is basically all of internal medicine. And here you have all of orthopedic surgery also linked. So very complicated. The arrows are important. They mean difficult differential diagnosis. So whether a chronic musculoskeletal pain is primary or secondary may not be very easy clinically. But conceptually, in either case, you can put it into a box and classify it and handle it. So that's basically the structure. Now let's move into chronic primary pain, which is basically chronic pain as a disease. There is a little bit of WHO family of classifications terminology that you need to know. There is the term linearization, because in essence, a classification is a relational database that has lots and lots and lots and lots of entries. Also has functioning and interventions and many more things in it. But then there's something they call the shoreline. And above the shoreline, these are 6 digits available for coding for mortality statistics, basically. There's no international morbidity statistics.
Professor Tridi, I'm very sorry, but our interpreter
I'm too fast.
Catch you. Please slow a little bit. We have Romanian translation.
I know that, and before this session, I figured maybe I really have to make sure that I treat your translators well. Thank you, Oksana, for mentioning that. So, yeah, there are parts where I talk fast, but the important ones I talk slowly. So here, this is an important one, and I should talk more slowly. Thank you for that. So mortality statistics linearization, that's the mortality statistics that is reported. And for morbidity statistics, there is no real international comparison yet. We think there will be, and it's very, very different from country to country. Now, I don't know about Moldova, but it may be used for morbidity statistics also. And here you can see the number 1 example is chronic widespread pain, and a subtype of it is fibromyalgia. So fibromyalgia is below the shoreline, but I will show you in a moment that it has its own code in the foundation layer. Another one is complex regional pain syndrome. And although there are two conditions where chronic pain is the disease and there's still several unknowns around them, I think hardly anybody will ever confuse fibromyalgia with CRPS. It's clinically quite straightforward for the specialist. And this was quite a success. It used to be classified as autonomic nervous system disorder, but a special interest group of IASP has applied for a reclassification as a primary pain syndrome, and that was granted last year. And so that's an important point here. Here, just as an example, what it means, fibromyalgia. Fibromyalgia here is present in the foundation, in this relational database. It is a child of chronic widespread pain, and this chronic widespread pain is also present in the linearization for mortality. Fortunately, people don't die of that. So probably this will only become relevant when it enters morbidity statistics. And here's another example for low back pain. Don't worry about the next number of slides, they're all very complicated. I will only show a few examples here. The next category, this is a secondary pain, where the chronic pain is due to either cancer or its treatment. So we have one category that is called cancer-related pain, and it's divided into due to the cancer itself or its treatment. And that exhausts the 6 digits that we have. So you cannot code more than that for the mortality statistics. Below, we have lots of other things in the foundation layer. For example, if it's due to a surgery, then that's coded in the foundation. And since post-surgical pains are also a condition, the question arises, what is it when the surgery is for cancer? Well, an innovation in ICD-11 is that any given entity can be the child of more than one parent. So if the pain is due to cancer surgery, it's both part of the cancer treatment pain and surgical pain. So this hopefully will simplify things in the future quite a bit. As an example, the example is slightly different. Very frequently, chemotherapy can induce a painful polyneuropathy. That has a foundation entry because it is very frequent. It's only visible above the sea level as chronic post-cancer treatment pain. So you cannot distinguish here whether it's post-surgical or post-chemotherapy. But I will show you in an example from Thailand that in clinical practice, this is already very, very important to have that. Now, the next topic would be chronic post-surgical. So I leave it at that. So there are examples. Neuropathic, just to ease Ralph Aron's task, with the levels that we have above shoreline, we can distinguish peripheral and central neuropathic pain. But all the entries that are very frequent have their foundation entries. And we can add more to them and make this decision tree much more complicated. And don't know to how much detail Ralph Aron will want to go. Headache, orofacial pain, very, very complex. You handled that in the previous session. Visceral pain, also very, very complex. So you can see here, this is an etiological distinction. So whether it's due to inflammation, rheumatoid arthritis is part of that, whether it's due to vascular mechanisms, sorry, no, I was in the wrong chapter. Inflammation that would be like morbus Crohn and others, the inflammatory bowel diseases. Vascular mechanisms like any cardiac symptoms, or mechanical factors if you have, for example, chronic gallstone or something like that. And then the real life is really hidden below. And here a lot of cleaning up needs to be done because there are too many diagnoses and not everything has been clarified. If you're a specialist in that field, you can actually make a proposal. There is a proposal platform. And if you join colleagues from other disciplines and other countries, you have a good success rate to actually make your good proposal then included in the classification. So it clearly is a living classification, quite unlike the old books that you might know. It's equally complicated with musculoskeletal pain. So rather than go into more detail, I will show the next summary. We have a section on chronic pain in ICD-11. A slightly disappointing part is that it's not like mental disorders or cancer, a chapter of its own. It's part of a funny chapter, which is called Certain Symptoms, blah, 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 which are important problems in medical care in their own right. And if you think about it, this is what organizations like EFIC have always said that characterizes chronic pain. It is an important problem in its own right in those people that then need these codes. And the codes should lead to actual treatment. We distinguish primary pain, which is basically disease, and secondary pain, where it can be a symptom of the underlying disease. And an important point is that this classification is relevant when we need pain management. And there are quite a few examples where the pain management may be needed beyond the official healing of the underlying disease. And therefore, it may be a way to earmark certain patients as having a chronic pain problem that when, let's say, the rheumatologist is finished treating them, don't fall through the gaps, but are then continue treated well. We expect lots of good things. So obviously, better diagnostic coding. The diagnostic coding should lead to better management. And in Germany, we had a preliminary step in that direction in 2009, which has dramatically changed the entire multimodal pain management and its reimbursement in our countries. So there are precedents that it has worked. And I've just heard a lecture that in Japan, they're now actually instituting national centers for multimodal management, and they are evaluating them, and all of this in this context. Healthcare statistics, I don't have to talk about that, but also for research programs. I have a few slides on that a little bit later. Here's one more thing. Initially, we only intended to have that from the ISP perspective, but it's part of the official WHO classification that pain severity is more than just intensity. You may know that concept, but it's now part of the official WHO classification that distress and disability are equally important as intensity. And that can also lead to quite a bit of a change. We had to accommodate time course. Not all chronic pain is continuous, so that is accommodated. And very importantly, most chronic pain conditions can have some mental comorbidities, and the psychosocial factors can always be coded together with any of the chronic pain conditions, not only with pain as a disease, but also with chronic secondary pain conditions. So if morbus Crohn is associated with some, let's say, anxiety or depression, then you can mark it in this classification system. So that's what's available in the internet. Does it work? Before WHO accepted what we had presented, they wanted to see some evidence. So in 2015, they told us you need to do a field trial of the classification that we had published in 2015. So we got a few clinical colleagues from 4 countries to code their consecutive cases. About 500 cases were coded. And they didn't have what I just showed you. They just had our 2015 paper with the 7 categories that they could use. And then they could divide their patients into the 7 categories. And you can see quite a few of them had primary pain conditions. There were very few cancer patients in that sample. But pretty much everybody could be coded. Yeah? Only 15 cases could not be coded. So this is wonderful exhaustiveness, which WHO requires. The uniqueness needed 2 steps. So in the end, it's also 98. However, initially, there were about 100 patients that received 2 codes or more. But some people have 2 pains, and then 2 codes are fully appropriate for 2 pains. And then this condition that I mentioned, the surgery was for cancer. So is it post-cancer or post-surgery pain? Nowadays, it's the same code, and it's double parented to the 2 conditions. So if we take into account these things, then we have this fantastic uniqueness also. Another field trial came a bit later that was in a way more primitive. So line coding means there was a line definition of something, and people had to say whether it's, for example, chronic non-specific back pain or not. And here we had more participants. We had about almost 200 experts, 35 countries involved, although we had about 2 months or so because we need to write a report with a fixed deadline. And WHO didn't have the website operating before the summer break. So I'm quite impressed by those people who were participating. It's also published. So accuracy for the secondary pain conditions was much better in ICD-11. For the primary pain conditions, so fibromyalgia is fibromyalgia. People knew that. So that was not a difference. And you can see in this red box that for the secondary conditions, it makes a huge difference. And then perceptually, from the user's point of view, it's also much easier and more intuitive. So that's also a nice outcome for ICD-11. And here I mentioned Thailand. So one hospital in Bangkok took all their cases on one calendar year and had them classified, I think, by 3 attending doctors, once according to ICD-10, and the same cases again according to ICD-11. And you can see here, ICD-10 gives you meaningless codes. So what's an other chronic pain? How do you treat other chronic pain? Low back pain, what is it? Primary or secondary? Well, we see in the ICD-11, the majority was with structural changes, so orthopedic cases that could benefit from a surgery. That's not visible here. Pain in limbs, what is that? Well, it was many peripheral neuropathic pains. Then, as I mentioned here, chronic cancer pain. Impossible to code nowadays. There are lots of cancer, and each of them sometimes is painful, and that doesn't show up in any statistics whatsoever. So clearly, the outcome here was quite positive, and that was also published last year. So I would like to encourage you to do the same thing for your hospital. Yeah? And then if pain doesn't accept it, pain reports probably would, or the European Journal of Pain, because we need more evidence about some more details. Now for drug development, it's quite interesting. In both Europe and the US, for a single neuropathic pain model, let's say postherpetic neuralgia, the classic one, if you have 2 trials that are positive, you can get the license. In Europe, a new category was created, peripheral neuropathic pain, which meant if you have 2 or more different models, then you can get an indication for all peripheral neuropathic pain. So we're extrapolating to all of them. And you can even get a general indication of all neuropathic pains in Europe. Now, FDA is very slow in changing their rules. So they have been discussing that. People have pushed them. However, if at some point in time the US would take on ICD-11, it is a done deal because peripheral neuropathic pain is a diagnosis. Yeah? So it can have tremendous effects in the long run, not immediately, but in the long run. And quite interestingly, for my animal licenses in the state of Baden-Württemberg, they want to know, as additional information, what clinical condition we are wishing to model. And I was quite surprised to see last year, they use already ICD-11. So I was very happy to show them the pain-related codes. So 6 secondary and 1 primary set of conditions easily distinguished by specialists. And this might be sufficient to primary care. I didn't mention some of the participants still use it because they find it so useful. And then if you have these codes, you may trigger referral for multimodal management. And I mentioned in Germany, we had a variant only for our country in 2009 that has already done that. And the clinical studies and preclinical studies related part I already mentioned. I'm sorry, I'm still talking too fast, but we're nearing the end. This is about the implementation part. So there's an entire family of classifications, and there are certain committees at WHO. We have annual meetings. So about 2 weeks from now, the next one will be held in Geneva. So important dates were that the version that I'm showing you was basically finished in 2018. It was adopted in 2019 by the World Health Assembly. And at the same time, that's very important, ICD-10 was abandoned. So the 2019 version of ICD-10 is the last one that will ever exist. And COVID-19 isn't in it. There are emergency codes, but they are not systematic. So eventually, the pressure to introduce ICD-11 will raise on all the countries. This is about, but you can just search for ICD-11 at WHO. You will find these. You can access all of this, and you can make proposals. And then there are certain committees that handle these. And it's also, I think your country is computer affine. So if you want to have a software, you can access the entire classification via software. It's no longer just a book, software access. And there's a Creative Commons license to utilize that access. So it's all prepared for practical use. These two slides are from the presentation in the United States in 2018, when this version was prepared, and Donna Pickett presented what would it be good for. Mortality statistics, I mentioned that. Morbidity statistics, not really implemented. They're more special to some certain diseases. For reimbursement and resource allocation, most countries, if not all countries, use some variant of a classification for that purpose. And we have, therefore, national modifications in many countries. And the question is, do we still need them? Maybe not. So the idea is that maybe there will be one generic global world overarching classification. And clinical research and other topics are also possible. Donna Pickett was also asked, well, when will the US implement ICD-11? And then there are many things that need to be done before. And we did a similar analysis for Germany, and you can do it for Moldavia. You will find certain things that are needed. And then basically, they noticed to introduce ICD-10, it took them 7 years. And therefore, in 2018, Donna Pickett said, well, the minimum would be 5 years. Since, as far as I know, the US has not decided to move, it's not going to happen the earliest in 2023, but rather 2027. And the same story applies to Germany as well. So we have done some analyses. We haven't set a date yet. We don't even have an exact timeline. And what are the issues? So licensing is being clarified. There are still some issues around it that we will talk about 2 weeks from now. National modifications. Translations are possible, so you can translate them to your language. And if you have other countries that speak the same language, you can team up. So Germany and Switzerland together teamed up for the German version, and I think Luxembourg and Austria helped a bit. So that's possible. But then how do you implement this with care and reimbursement? This is going to be very, very tricky. But smaller countries may be faster than bigger countries. So I think it's a great opportunity for you to maybe do it in your country. So what are the steps? I mentioned for mortality statistics, software will be changed. So by 2027, I guess we will have the mortality statistics, but hopefully people don't die of chronic pain. Morbidity statistics, completely unclear. Global burden of disease is a separate system. They may or may not use it sooner or later, I don't know. I know that in my country, we have done analyses. Actually, our ministry has not even cleared it for publication yet. So I don't know what happens. And in the US, they started to look at it in 2018, but I think they have not moved yet. So what are the shortcuts? Well, if you're allowed to, you can use the codes. And there are several health services around the globe that simply use it because it's much easier to use. And if you want help, you can have assistance from the Global Advocacy Working Group at ISP. And I think we have one member from Moldova who is attending this meeting, if I'm not mistaken, and also from Marburg University, Windfriedrief. You can try it out with your own hospital data and see if you're skeptical, is it really better? What is better? What's not? Implement it in your software. Maybe create a national modification like we did in Germany several years ago, whatever you want. So many things that you can do, and I hope you didn't fall asleep with such a dry topic. Here are many, many people who were involved. I think, what did I have here? Windfriedrief, Antonia Barke, Bea Corvisi, and Kine Hay at Marburg University. They are really the leading specialists on pain classification there, and they will certainly be happy to help anybody who wants to implement. Thank you very much for your kind attention. And I apologize to the translators.
Dear Professor Tweed, thank you a lot for presenting this important topic. It is very important to have an instrument for classification of diseases and for pain, and is a difficult issue to make changes in the countries to adopt modifications, and it is long-term effort. In Moldova, at least, we need to teach and to educate physicians, students, that this kind of classification exists, and to promote pain education among professionals, firstly, and after we should organize structures too, I think.
Yeah, what was helpful in Germany was we had multimodal pain services that were kind of getting along, but there weren't any good co-classification codes to identify the patients that needed them. And we started with something that is not exactly identical, but similar to chronic primary pain. And we used the somatoform pain disorder code. We made a change to it, and that was the starting point. And now we have three major classes of chronic pain conditions that are triggering multimodal pain management. One is coming from the somatoform pain disease corner, one is coming from neurology that Ralph Baron probably will talk about, and the third one is musculoskeletal. And if you think about post-surgical, it's also mostly neuropathic. And cancer is also very frequently neuropathic or musculoskeletal. So with these three corners, even without having IC11, I think it worked. And maybe a similar trick can work for you.
We have questions for you.
Yeah, please.
So I think Jana will be the first one.
Dear Professor Treat, thank you for your comprehensive lecture, and it's nice to see you even online here.
Yes,
so,
indeed.
My question from the chat was about, is there a chance that in a new ICD, the pain and all the pain symptoms will be introduced as an independent chapter? Because attending the international conferences, we saw a lot of work that was done to introduce pain as a part of the international disease classification. And I think it will be the next level to introduce it like an international chapter, independent chapter. Thank you.
Well, actually, I'm fully with you. So we only got involved with WHO on that topic in mid-2012, so in reality in 2013. And 2013 was a year that they initially wanted to have the entire thing finished. There is a precedent, so sleep disorders have their own chapter. They were part of psychiatry initially, now they have their own chapter. And we are now considering when and with which justification we want to make an application that pain will receive a chapter similar to the sleep chapter. I think what we need is published evidence. So we need to show with real life data that this classification is useful, leads to better management. And then we could probably easily form the international consensus, because I think all the ISP chapters will agree to do that and move it up one level. And we might even get support from, let's say, the musculoskeletal health world, because they also know that chronic pain conditions are somewhat different from inflammatory or surgical conditions. So I fully agree that that's the next level. We've started some considerations, and and the Global Advocacy Working Group of ISP has that on the agenda. And please keep mentioning it with an EFIC. Yeah.
The next question will be from Associate Professor Marina Sangheli.
Thank you very much, Professor, for your very useful lecture. So it's very important to understand the principle of classification and to be more easy to use it. So my question is about such practical part or side of this classification. So DRG standardized, let's say, classification especially in inpatients clinic. Does it influence our diagnosis because of insurance. You know, every clinic tried to diagnose the patient with the more paid, let's say, diagnosis. So how much are paid pain as a disease, and does it will influence or no?
Yeah. So definitely, you mentioned diagnosis-related groups. We have that system in Germany as well. And this is why we needed this code F45.41, the only one that I know off the top of my head, which is F45.4 is somatoform pain disorder. And we created a subcode, pain with somatic and mental conditions. And that one only exists in Germany, but you can copy this. There's a paper by Winfried Rief in English language that was published in, I think, 2007 that describes the definition. And with that definition, we could get into the operations and procedures system. So we had, no, sorry, it's also DRGs. So we have classes of DRGs, and we have 3 DRGs that can trigger the multimodal pain management. So I think your question is right on target. And we didn't have 7 different ones. We have one that is pretty much similar to the chronic primary pain. Then we have one that's musculoskeletal and one that is neuropathic. So, and the only thing that we needed in Germany was to have something for the primary pain, which in our case was this modification of somatoform pain disorder. And that collected enough cases that we were above shoreline, that we were visible in the healthcare system as an economically important clientele that we are serving. That was the trick. And then later on, neuropathic and musculoskeletal pain also followed. So I think by focusing also on chronic primary pains and either modify ICD-10 F45.4 or try to push for what WHO would call a seed implementation. So WHO would like to have some countries to implement some things early. So if you somehow get your Ministry of Health to be interested in the seed implementation, you could actually use that thing for that purpose for diagnosis-related groups that then trigger reimbursement. And it worked also easiest for inpatients in Germany. For outpatients, we still have a bit of a problem. Thank you very much for that question. And I wish you success. Try it. And if you then encounter questions, ask me. Yeah.
Thank you a lot. So I don't see other questions in the chat. So I thank you for your presentation, and I wish to meet each other physically, not online, in Moldova, and to discuss this issue and other issue on pain and health.
Okay, thank you very much. And thank you very much for the very good questions. And good luck with pain medicine in your country.
Thank you, Professor Tridi. The next moderator will be Associate Professor Marina Sangheli and our colleague from the Ukraine, Volodymyr Romanenko. Please go ahead.
Good afternoon once again, dear colleagues. We will continue with the next topic on neuropathic pain. But before that, we will start. I'm honored to introduce my co-chair, Professor Vladimir Romanenko from Ukraine. He is the professor of neurology with special interest on pain and especially on neuropathic pain. He participated in several clinical studies on the problem of pain. He is a member of the International Association for the Study of Pain and the main coordinator of the scientific projects at the Ukrainian Association for the Study of Pain. Please, Professor Romanenko, we are glad to hear to you further.
Dear Marina, thank you very much for introduction, and thank you and all my colleagues from Moldova for invitation. It is a great honor and pleasure to be with you today, and it is even a bigger privilege and honor to present today Professor Ralph Baron, who is one of the well-known and globally renowned experts in neuropathic pain, and a good friend and colleague, and the person who I have personally cited, the works of whom I have personally cited numerous times in my own scientific way. So it is really great privilege and honor to have Professor Ralph Baron today together with us on this conference. And he has huge affiliations. I will probably not go through all of it because it will take another 5 minutes of our time or so. So without any further ado, I would like to pass the word to Professor Baron, please.
Well, thank you very, very much for this nice words and this kind introduction and the invitation to be present here with you, even if it's only virtually. I'm really, it's really a pleasure for me to be here. So you invited me to give some ideas about neuropathic pain, as you already mentioned. And I hope you can see screen now. Is that okay? Good. So this is the title you suggested, so chronic neuropathic pain classification, but I think most of the classification issues were just mentioned by Rolf Detlef Trede. Diagnosis, how to diagnose neuropathic pain, and obviously the management, what is new and what do we have to do if it comes to the treatment of neuropathic pain. So what I would like to do is I would talk a bit about the underlying mechanisms of pain generation, because I think it's very important to understand the neuropathic pain mechanisms, because then we can perhaps target our treatment approaches, so the drugs we will use to these mechanisms, and we can understand why we are using these different drugs in these different states. So this is just to mention the people who are doing all the work back in Germany. So you know that I'm based in Kiel, which is in the very, very north of Germany. And so this is the team, my lab, and also the conflicts which I have. And they, again, do all the work except this one who's giving the talks and traveling and so forth. So this is the agenda which I would like to go through today. I divided my agenda in 3 parts. So I would like to convey some ideas about the obligatory. So what do we have to know if it comes to neuropathic pain? Briefly, the definition and some overlap, obviously, with Rolf Detlef's talk, as he already mentioned. But then coming to the tools we have to diagnose neuropathic pain. So the signs and symptoms of neuropathic pain, which are so characteristic, and we all have to know these signs and symptoms to make the right diagnosis. And then the use of the rational treatment strategies, as I mentioned earlier. So why are we using some medications, some drugs, and how do these drugs act on the different mechanisms? Then followed by some new ideas, which is really a hot topic these days, is the personalized treatment strategies in neuropathic pain. You know that personalized or individualized or precision medicine is very, very en vogue in many areas of medicine, in particular in oncology. But I think we also can adopt this concept and practice this in our neuropathic pain field. Some words about disease modification, and then I would love to talk a bit about killer cells, about inflammatory reactions in neuropathic pain and chronicity. And the last bit is about the obsolete, so what we should not do in the treatment of neuropathic pain, so what should we avoid? So the obligatory number one is the definition. What is neuropathic pain? And I think you all know this. This is a pain which arises as a direct consequence of a lesion or a disease. So this is very important. So you have to find a lesion or a disease to diagnose neuropathic pain. And this should affect the somatosensory system. And this can be in the peripheral nervous system or in the central nervous system. And I just brought some ideas about etiology and about this classification. So if it comes to peripheral neuropathic pain, so we stated peripheral neuropathic pain, and you found this in the ICD-11 classification as well, as Rolf Detlef-Trede mentioned. But we distinguish didactically between the focal nerve lesions, which occur in the periphery, and I listed some examples here: phantom limb, zoster, we heard about zoster, and postoperatic neuralgia, but also others, which you can see and read here. And then there are, again, peripheral neuropathic pain states, which have a generalized distribution, and we call them, as neurologists, polyneuropathies. And here are some of the etiologies which are very often associated with polyneuropathies and very frequently with painful polyneuropathies. And then, as we mentioned earlier, the lesion also can occur in the central nervous system, and this is very often associated with stroke, for example, in the thalamus, spinal cord injury, or even multiple sclerosis. So this is the etiology-based classification of neuropathic pain. So what are the characteristic signs and symptoms of neuropathic pain? So what do we have to ask our patients for symptoms, and what do we have to assess for signs in neuropathic pain states? Some examples. Many patients describe a burning sensation. So this seems to be very typical for neuropathic types of pain and can be used to distinguish this from other types of pain, like nociceptive pains and so forth. Also, these are ants and crawling, prickling, tingling sensations are very typical and characteristic. Numbness is typical as well. And then if it comes to the assessment, you see here a pain which is elicited by a very, very light touch to the skin. A stimulus which normally does not induce any pain, but in neuropathic pain, it might lead to a severe pain. The same holds true for a pinprick stimulus, which might be much more intense perceived by the patient as in normal volunteers or in other pain states. So these are the evoked types of pain, which also are characteristic for neuropathic pain. And you might know that we developed a special questionnaire just addressing these questions. This is in German now, but we have this translated in many, many languages. These questions are addressing exactly these symptoms of pain which are typical for neuropathic pain, and therefore we can use this to identify and to screen for neuropathic pain entities. This questionnaire is called the Pain Detect questionnaire. So now let's switch gears a little bit and go to the treatment strategies and the rationale behind our treatment strategies. So just imagine a primary afferent neuron. So this is a nociceptive fiber over here. This is the spinal cord, the second order neuron in the spinal cord, and this is the brain. So what happens to the primary afferent neuron, to the pain fiber, if you like, in the periphery if this fiber is hit by a lesion or a disease, so neuropathic pain? So and this is animal experimental work which has clearly shown that there is a change in the expression of channels and receptors at the membrane of the pain fibers induced by the nerve lesion. And in particular, important are sodium channels, here in blue, and the TRPV1, the transient receptor potential vanilloid 1 receptors, which you see over here, which are highly expressed, induced by the nerve lesion. So normally these channels and receptors are not present, or very, very few of them are present on the membrane of nociceptive fibers. But under these pathological conditions, they are highly expressed in the periphery. And we now know that this is likely linked to specific symptoms, which we were mentioning before. And this is the attacks mainly induced by the sodium channel expression, overexpression, these shock-like, electric shock-like attacks, and the burning sensation, which we also mentioned due to the overexpression of TRPV1 receptors in the periphery. We call this the concept of peripheral sensitization. So these neurons are sensitized and they develop ectopic activity. That means that they start to fire constantly action potentials to the spinal cord. So this is ectopic activity, spontaneous activity. So this is the bad side. So the underlying molecular mechanisms leading to pain or specific symptoms. But there's also a good side, because we can specifically attack these channels and receptors with drugs and medications. For example, we can attack the sodium channels with lidocaine and the capsaicin channels with capsaicin. And there are topical formulations available which we can use, and I've shown you here some examples. So this is a patch, sodium channel blocker, a lidocaine patch, which is approved for post-herpetic neuralgia, at least in Europe. And this is the capsaicin patch, which you can also apply topically. And just to remind you, this is only acting in some millimeters in the skin to calm down these neurons in the periphery. So it's no uptake in the system, in the blood, and therefore we do not have any interactions with other medications and no systemic side effects, which I think is very nice. So just some examples. The lidocaine, the topical lidocaine, which we have available, is again approved for post-herpetic neuralgia, but there's evidence for other neuropathic pain states as well. You have to apply this for 12 hours, and then you have to give the skin a 12-hour rest. It's a 5% lidocaine in the patch, and again, no interactions, no systemic side effects. Very similar, the capsaicin, which is approved for peripheral neuropathic pain, for all the peripheral neuropathic pain states, as Wolf Detlef mentioned here in Europe. It's 8% capsaicin. And the interesting thing with this application type is that you have to use one application for half an hour or an hour, and then you have a reduction of pain for up to 3 months. So one application and reduction of pain for 3 months. This is, I think, a very interesting application way. Okay, so the next mechanism, the rational mechanism, which we should know, is a central mechanism. And this is what I call the calcium channel expression mechanism. So just, you know that if you have a barrage of action potentials from these peripheral fibers, from these nociceptive fibers to the spinal cord, there is a change in sensitivity in the spinal cord as well. We call this central sensitization. So these second-order neurons are sensitized secondarily. And if central sensitization is present, then A fibers, the blue ones over here, which normally convey non-noxious stimuli like touch or vibration. So these are the myelinated A beta fibers, for example. Was that for me? No.
No, that was Oksana microphone.
Oh, sorry.
Oksana, okay. Okay. So the activity in these fibers may gain access to these nociceptive second-order neurons, and then this is the mechanism behind mechanical allodynia, for example. So if you touch the skin, you activate these A fibers, and via this route, you will can activate the second-order neurons in the pain system, and this is then felt in the central nervous system. And we now know that in the mechanism of central sensitization, calcium channels are involved. And this is all the green calcium channels in the rat here in animal experimental work, which is upregulated on the endings, the terminals of these fibers, of the nociceptive fibers in the central nervous system. So calcium channel upregulation in the central nervous system is involved in central sensitization and leads to evoked types of pain like mechanical allodynia. And again, we can use this mechanism of pathophysiology to target these specific channels. And we use medications like gabapentin and pregabalin, for example, because they are calcium channel modulators, and therefore we can reduce the central sensitization in this particular area, and we can reduce phenomena like allodynia. So what is the evidence for pregabalin, for example? There's lots of evidence in the peripheral neuropathic pain states like post-herpetic neuralgia, polyneuropathy, but also in the central pain states, there's some evidence. And you see here the dosage which is recommended and some important information about side effects. For gabapentin, again, a calcium channel modulator. This is licensed for peripheral neuropathic pain states. Lots of evidence here. And you see the dosage which are recommended and so forth. So in the last bit of mechanism which we should address and discuss is the descending control systems. So normally in all of us, we have some descending pathways coming from the brainstem over here to the spinal cord over here. And these are modulating pathways. And you see a green pathway which is going down. And this is, as I always say, the good one. The transmitter is noradrenaline, and this is an inhibitory pathway. So if you activate the green one, you inhibit the transduction of pain through the spinal cord over here. And the other, the purple one, contains serotonin as a transmitter, and this is a facilitatory pathway, which enhances the transmission through the spinal cord. So with this normally physiologically present pathways, you can really modulate the pain transmission through the spinal cord. And under physiological circumstances, both pathways are equally activated. But what happens in a neuropathic pain states, and you see this here. So if the arrow is going to neuropathic, then we have an inhibition of these green fiber. So these fibers is weaker and weaker and weaker, this fiber tract, and this was the good one. So then there is a predominant activation of the bad facilitatory pathway, which clearly then leads to more central sensitization and transmission through the spinal cord. So you can also demonstrate these in functional MRI graphs today, showing that these areas in the brainstem, the bad facilitatory areas which project down to the spinal cord, are highly active in nociceptive pain states, leading to central sensitization. But again, you can manipulate the system by using drugs which act primarily here on the noradrenergic reuptake. And these are reuptake blockers, inhibitors, like the antidepressants, in particular the tricyclic antidepressants, which lead to a blockade of the reuptake of noradrenaline. Then you have more noradrenaline in front of your synapse, and this will lead to more and more inhibition of this system. So this is the mechanism of action of antidepressants in chronic pain, and in particular in neuropathic pain. And again, there's lots of evidence for this, for the antidepressants. And here I'm talking about the tricyclic antidepressants in many, many peripheral and also central neuropathic pain states. And you all know the titration, the recommended titration. So this brings me to a summary of this part. So what I wanted to show you is that we have lots of different underlying pathophysiological mechanisms in our patients, and we can address these mechanisms independently. We talked about some oral and systemic medications, so antidepressants, for example. We talked about anticonvulsants, which act on the calcium channel, which is gabapentin and pregabalin. We talked about anticonvulsants or sodium channel blocker like lidocaine. We didn't talk about the opioids today because they are really third line medications now in the guidelines, which I will show you at the end. We talked about some topical therapy approaches with lidocaine and capsaicin patches. And you can use combinations in particular with the systemic and the topical therapies. But in all these guidelines, there are no NSAIDs, no classical non-steroidal drugs, classical analgesics, but because there's no evidence that these drugs are working in neuropathic pain states. So now some ideas about the personalized treatment of neuropathic pain, the strategy which I already mentioned. So just imagine in your clinical practice, perhaps tomorrow, you see two patients with painful diabetic neuropathy. Diabetic, let's assume. And one patient, the one says, well, I'm suffering from thermal hyperalgesia, mechanical hyperalgesia, and allodynia, all these evoked types of pain. So if you touch my skin, this is extremely painful, and so forth. Okay. The other patient, exactly the same etiology, it's diabetic painful polyneuropathy. He says, well, I have something completely different. So I'm suffering from burning. It's a spontaneous burning sensation, but my skin is not hypersensitive, it's hyposensitive, it's numb. So you can do with whatever to my skin, it's not hurting. And I have ant crawling as well. So and if you see this, I think you immediately think that there should be different underlying mechanisms operating in these two patients, although they have exactly the same etiology. And if this is true, then you should perhaps treat these different types of patients differently. And therefore, we thought perhaps we can distinguish these two groups of patients with sensory profiling to use a technique which we call quantitative sensory testing, so a test of the sensory qualities, which we mentioned here, to profile our patients. And in fact, this is the protocol, the German protocol of quantitative sensory testing, which we established together with Rolf Detlef many years back, where we use different sensory stimuli, and most of them we discussed already, in the patients to profile these patients as precisely as possible. And now we also have a bedside form of this, because the quantitative testing protocol is expensive, it's time consuming, but we can do it on a bedside as well. And we have invented some tools, as you can see here, for the bedside testing. We call this Fiver Assess, which you can read here, which is published. And what we did is we used in all the European countries which were involved, so this is a big network approach, a European network, where many of the labs on neuropathic pain were involved, we used these sensory testing protocol, exactly the standardized sensory testing protocol in all the patients in our labs. And there were many neuropathic etiologies, so polyneuropathies, zoster, and radiculopathy. We put all these patients together from all over Europe in a database. You see this here. Then we did the sensory testing in all of them. And then we used a statistical trick. We used hierarchical cluster analysis, which is a pattern recognition technique, to sort them, to identify different subgroups of patients. So we clustered them, and you see the different groups of patients. And these are the results which we found with the QST. There are some patients, I do not want to go into detail, the red ones here, they are dominated by thermal hyperalgesia, and therefore we call them thermal hyperalgesia subgroup, the red one. And there's another one. This group is characterized by sensory loss. Just remember our patients in the practice. No evoked phenomena here, but also in the negative range, the sensory loss. And then there is a third group, we call it mechanical hyperalgesia, which is dominated by mechanical hyperalgesia. So this is pinprick hyperalgesia or even allodynia. So 3 different groups of patients across all the etiologies we included with entirely different sensory profiles. And now we can speculate about the mechanism as well. And we call this the fingerprint, the quantitative sensory testing fingerprint of our patients. And just for the thermal hyperalgesia, we think that this upregulation of receptors and channels we were discussing earlier is the major underlying mechanism of pain generation in this group of patients. If you look in the mechanical hyperalgesia group, so there we think there's a degeneration of C fibers because there was a loss of the small fiber range, which also leads to a central sensitization. And then, as we mentioned earlier, the A fibers may gain access to the system, which leads to the mechanical hyperalgesia, which is obviously the dominating sensory phenomenon in this particular subgroup. And now, and this is the most important thing, the first clinical trials have been performed in these subgroups. And I just would like to give you some examples to show that clearly the subgroups can respond better to a certain therapy than other subgroups. This was a trial with a TRPA1 antagonist. This is a transient receptor potential A1 antagonist, which was performed in a cohort of diabetic painful neuropathy patients. And you see here in gray, always the placebo, and here the active. And this drug is performing very nicely in the subgroup of thermal hyperalgesia, whereas if you look at the entire group of patients, this is the gray one, there was no statistically significant distinction between both. So again, the subgroup is responding nicely. Very similar, a different trial with oxcarbazepine. You see here, again, the hyperalgesia subgroup, nice separation between placebo and the active, and only very little in the blue, the sensory loss group. And these were the 2 subgroups which were compared in this trial. And this is a trial with pregabalin in traumatic peripheral neuropathies. And you see the green one is the one, so the mechanical hyperalgesia, which responds very nicely, whereas the blue one over here doesn't do the trick very well. So I think clearly the first studies underpinning the idea and the hypothesis that this is true, that we can identify subgroups of patients with sensory profiling, which respond better than others. This is the approach we used. Okay, so the second new one, which I really, because I'm a neurologist, I'm really interested in, is the disease modification. So we have learned that neuropathic pain is due to a lesion of a neuron. So if it would be possible to induce a disease modification, so induce a regrowth of nerve fibers, for example, in our patients, a regrowth of healthy nerve fibers, then this would be a causative treatment approach, disease modification. And there's first evidence that the drug capsaicin, the topical capsaicin patch, is able to induce a disease modification. So this one is performed by Praveen Anand in London. And he used skin biopsies, and you see the skin biopsies here, and I got this from Claudia Sommer. These nice graphs. These are pain fibers in the skin, in the epidermis, and you can stain them and count them. And Praveen Anand did exactly the same. He looked at the intraepidermal nerve fiber density. You see here the control values. So this is normative data, normal patients, normal people. This is the number of fibers before the treatment with capsaicin, and this is the number of fibers 3 months after the capsaicin treatment. And you clearly see an increase in the fiber density in these 3 months. And this is a cohort of very stable chemotherapy-induced polyneuropathy patients. So indicative of regrowth of fibers, a regeneration of fibers, increase of fibers as compared here with the baseline characteristic. We were interested in a very specific subtype of C fibers. These are the so-called peptidergic C fibers. And the peptidergic, they are TRPV1 positive, and they are involved in the flare reaction and the axon reflex flare reaction due to the release of CGRP, calcitonin gene-related peptide, at the endings of these branches of the neurons. So if you activate these fibers, you can induce a vasodilatation around the activation site. And this is a neurogenic vasodilatation induced by the peptide CGRP, and therefore it's a peptidergic C fiber. And what you can do, you can measure this particular function of fibers if you measure the vasodilatation capacity. And you see this here, this is a laser Doppler, and we stimulate here in the middle of this area, these fibers, and you can measure the vasodilatation. This is the first peak over here, which is clearly an indicator of the function of peptidergic C fibers. And since we think that these peptidergic fibers are specifically important for the generation of neuropathic pain, therefore, we were interested in these fibers in particular. And we did exactly the same approach as Praveen Anand in London did. We looked at the function of these fibers and controls. We did it pre-capsaicin in neuropathy patients with neuropathic pain. And then we induced a degeneration with capsaicin. You know, there's a reduction in fibers already, I think, 3 days after the application. And then there's a regrowth of these fibers. And we could identify the regrowth already 4 weeks after the capsaicin application. And this was correct for the responders, for the pain responders. So the patients who really responded well at this marvelous regeneration. And our hypothesis is that this is the situation before the capsaicin. We have some fibers which are hyperactive, these red ones. Some are degenerated. It's a partial nerve lesion. Then you apply capsaicin. This leads first to a retraction of the fibers due to the capsaicin. And already 4 weeks after the application, you see a regrowth, an ingrowth of these fibers into the skin of healthy fibers. They are not sensitized anymore because these were pain responders. They were pain-free at this 4 weeks after the treatment. So again, indicative of a regenerative property of capsaicin in this particular setting. And I think this is really interesting to mention. And the very last bit are the killer cells in chronicity, which I think is very new and you should know. So what we did, we looked in patients with neuropathic pain with the so-called FACS analysis in the cerebrospinal fluid of these patients for natural killer cells. That are these CD56 positive cells in the CSF of chronic pain patients. And we could clearly demonstrate a very nice correlation between the counts of killer cells in the CSF and the parameters of central sensitization and chronicity. And as you can see here, the more killer cells you have in your CSF, the less, the smaller the likelihood is that you develop central sensitization and chronicity. So the killer cells are protecting you of a chronicity of your pain. And this is very interesting because there are very brand new animal experimental data showing that killer cells are recruited in nervous tissue to clear the damaged neurons. So it's if you think of a partial nerve lesion, the killer cells will eat the partially damaged neurons, and therefore you can reduce your pain. So I think it's a very new and interesting idea that inflammatory processes mediated by these blood cells might be involved in chronicity. So the last bit are the oxalate. This is relatively easy for you, I think, to use conventional analgesics. We have mentioned this for the treatment of neuropathic pain. You shouldn't use SSRIs for the pain treatment. So the selective serotonin reuptake inhibitors, there's no evidence whatsoever for these drugs. You should indicate topical treatment only in peripheral neuropathic pain states. So it's obsolete to do this in central pain states because the mechanism is obviously in the central nervous system. You can't reach them with a topical treatment. And you shouldn't recommend opioids as first or second line. They are always third line in all treatment guidelines. And you see exactly these in the guidelines, which were published by Nana Finderup in Lancet Neurology some years back, which we mentioned here. SSRI is not for pain treatment, topical not in central pain states, and opioids not recommended as first and second line. Yes, and with this, I'm at the end of my talk, and I would really thank you again for having me there and for listening. Thank you very much indeed.
Thank you very much, Professor Baron. While we are looking for questions from the audience, which I don't see yet, maybe they will appear, and my co-host will help me with it. I would like to take advantage of having a chance and ask you a question. What do you think about the future, about the possible perspectives in terms of new treatments and new targets for neuropathic pain treatments? What do you think is waiting for us in the future, and what could possible trajectories look like?
Well, it would be very, very good to have the capacity to look into the future, but we can speculate perhaps a little bit. Well, there are several, I think, very interesting targets which are coming up, not just the ones we were mentioning a minute ago. So we have new drug targets, new receptors and channels, which are really worthwhile to study. Many companies are involved in disease modification approaches now, which we mentioned briefly, really to induce a regrowth of the damaged neurons, which would be, I think, a causative treatment, which would be very, very good. There are some ideas about more topical interventions, topical patches to restrictively act on topical targets. I think this briefly is the horizon. Inflammatory processes involved in neuropathic pain are also a very hot topic. And then these are the new scenarios which we can mention. But stratification of pain, precision medicine with this approach which I was talking about, I think this is really future, because pain patients are so heterogeneous, as you know, so they are so different, and we have to identify, I think, the subgroups which might respond really better to one specific medication. And I think in the future, we will not only use sensory profiling, we will use a genetic profile, we will use inflammatory profile, we will use biomarkers, and so forth, to really identify the right patient for the right treatment. I think this is the future.
Thank you. Thank you very much for the answer. I think I saw raised a hand from some colleagues, but now it's not there. If there are any questions still, please you may address it. If there are no, I would like to ask another question, which maybe
Marina.
Marina.
Yeah, I have a question, but first of all, I want to thank you very much, Professor Barrow, for such a comprehensive lecture. So it's impressive how deep the science move, understanding the pathophysiological mechanisms and how that will lead to do the treatment more personalized for the patients. I want to ask you, so first of all, my idea about, not my idea, but the ideas that I had to the conferences and in the literature. So many pain conditions are mixed pain conditions, and we try to distinguish nociceptive and neuropathic pain. Papers show that when there is a painful stimulus, the sleeping nociceptors are triggered by inflammatory component in the surrounding tissue, especially in both as nociceptive as neuropathic pain. So this neurogenic inflammation doesn't answer to traditional non-steroidal anti-inflammatory drugs. So different drugs are used for this inflammatory treatment that are discussed now. For example, TNF-A blockers or thalidomide. So what is your opinion about this?
Well, I think we will, as you mentioned, we learn that there is an overlap more and more about inflammatory problems and classical neuropathic pain problems. I mentioned this with the killer cells, but you mentioned TNF-alpha dependent strategies and so forth. So there's clearly inflammatory reactions in the periphery of a lesioned nerve. And this will induce things like central sensitization as well. Is absolutely correct. And I think we have to go this route as well to observe the effect of, for example, as you mentioned, thalidomide, TNF-alpha blockers in the treatment of neuropathic pain. So far, we have not clearly succeeded in doing this. You know, there are several trials having looked at these drugs without much success. I think personally that this was also a problem of not having subgrouped these patients before. Yeah? Otherwise, if you can identify these inflammatory things more precisely in a given patient, I think then you will succeed.
Thank you. Vladimir, you have one more question?
Well, yeah, actually, I was about to ask almost the same thing about the role of inflammation. And well, yeah, you already touched. I just wanted maybe to highlight it once again. You already stated it in your presentation, and it's like very widely known that NSAIDs are not effective, we say, and not like the drug of choice in neuropathic pain conditions. But if we speak about inflammation, do you think there still may be some role and importance and sense of NSAIDs in some certain particular neuropathic pain conditions which are accompanied by, for instance, aseptic inflammation or any other form of inflammation?
Yeah, well, absolutely. I think it's absolutely true. So the message I wanted to convey, saying NSAIDs are not effective, it come from many clinical trials, as you know, that they couldn't show efficacy. And I know I see this in my clinical practice every day, that even now, although we are talking about NSAIDs and neuropathic pain and so far for years now, patients are treated with NSAIDs. And therefore, I think the main message should be to avoid NSAIDs. But having said this, I have to admit that we were involved in a big clinical trial where we tried to identify neuropathic as well as nociceptive component in diabetic neuropathy patients with some tools. And we could show that 15% of the patients with diabetic neuropathy clearly showed signs, symptoms of nociceptive pain. And then this was a huge trial with 800 participants. And then we asked them, what therapy do you like? So it was an open trial. It's not a controlled trial. It's not a placebo-controlled trial, but it was an open trial. And we asked them, what medications are you on? What do you take? And guess what? The 15% with these nociceptive elements, they liked NSAIDs. And therefore, exactly what you say, I think a subgroup may benefit from NSAIDs as well.
Thank you. So,
question, if you allow me, please. So I would like to ask about the patients who don't answer to the first and second line treatment. So what is the next step? Do we move to strong opioids or to the invasive methods?
I think both. Yeah, what we are doing, we are treating patients with opioids. We like to start with weaker opioids, I think, as you did, but we have lots of patients with strong opioids as well, which is a third line therapy and which is good. And I have many patients who really benefit from opioids, who are stable on opioids for a long time, and where I do not see any problems in terms of addiction and all these things we are discussing today. And the other step would be to be more invasive, to go for spinal cord stimulation, for example. And there are new trials on diabetic neuropathy with SCS, which is very beneficial. I think this is a possibility. And there's there's a lot of discussion now whether you should do an invasive treatment like spinal cord stimulation before you put a patient on strong opioids for many years, for example. Yeah, you have to think and evaluate this, what might better for the patient.
Thank you very much, Professor Baran, for your brilliant presentation. And we had a great honor and privilege to listen to you sharing your experience. So we are waiting for you to other conferences. Vladimir Romanenko, Professor, thank you for your agree to participate in our conference as well, and to all the audience. And so we will move to the next session. I would like to introduce the moderators of this session, Professor.
I'm sorry. We have some technical issues, so we have to take 1 minute break, and then we will come with the next session and the moderators, Professor Oleg Pascal and Associate Professor Svetlana Pleshka. Please don't go.
Thank you.
So, Professor Pascal, the floor is yours.
Thank you. Good afternoon to everybody, dear organizers of this conference, dear guests and colleagues. I am honored to open and to moderate the next session with my colleague Svetlana Pleshka, Associate Professor at the Department of Physical Medicine and Rehabilitation. And I would like to introduce the next speaker, Catherine Doody. She is an associate professor in the School of Public Health, Physiotherapy and Sports Science in University College Dublin. Catherine is qualified in physiotherapy, completed a Master of Science in the University of East London, UK, and Master of Science Mindfulness-Based Intervention, and PhD in University College Dublin. Catherine has held the position as a head of subject and associate dean of physiotherapy, director of the Master of Science in Neuromusculoskeletal Physiotherapy. She also is a founder and co-director of the Center for Translational Pain Research in University College Dublin. Also, Catherine is a member of EFIC Education Committee that developed the curriculum for the European Diploma in Pain. And now I would like to call upon our dear speaker, Catherine. Please, it's your floor.
Thank you. So thank you to the Moldovan Pain Society for the invitation to speak today on assessment and management of chronic musculoskeletal pain. My name is Catherine Doody and I'm based in University College Dublin, that's in Ireland. So I'm speaking to you today from Ireland. It took me a while to find a map with Ireland as the centre of the universe, but here we are. As you can see, we're on the very west of Europe.
Next place on our latitude would be Newfoundland. So we have the large Atlantic Ocean coming in across Ireland, dumping all the moisture on us, which makes our island very green. And also we get a lot of rain. But here we are. This is the Health Sciences Centre in UCD, where I'm based, where the sun is always shining, as you can see. So today's talk on chronic musculoskeletal pain assessment and management, I'll speak about chronic musculoskeletal pain from the perspective of a biopsychosocial approach to both assessment and management, also with reference to the newer terminology changes in the ICD-11 and also the International Association for the Study of Pain, recent pain terminology changes. As implicit in some of the recent changes to terminology is that we consider maybe looking a little bit more at pain as an entity in its own right. So we may consider using some aspects of pain mechanisms assessment in our assessment and considerations for treatment. And finally, I'll speak a little about what the current evidence says about treatment of chronic musculoskeletal pain. So we know that chronic pain is a considerable problem. In Europe, we have an incidence of chronic pain of approximately 20%. For musculoskeletal disorders, we have chronic musculoskeletal pain of about 13% in Denmark, and variations in data on this, like in the UK, they say between 15 and 50%. I think this is to do a little bit with how it's classified and described. This data here on the slide is from the Global Burden of Disease Study 2017, with just the musculoskeletal disorders data taken out. So it's giving incidence per 100,000 population by age and sex. And we can see here that we have an increasing incidence as we age, and increasing incidence for women as opposed to for men. Again, from the Global Burden of Disease Study, just with musculoskeletal disorders, we can see here on the diagram in green, the single most biggest cause of chronic musculoskeletal pain would be low back pain. So that's in green. And also following on from this, we have osteoarthritis, neck pain, then we've gout, rheumatoid arthritis, and other musculoskeletal disorders represented in there. Actually, in the first diagram, as we can also see the incidence in Western Europe and in Central and Eastern Europe here, which are quite similar, really. And the second diagram then shows again, over the life course, that we have increasing incidence, particularly of osteoarthritis as we age, and low back pain tapering off a little, and neck pain. So how do we then start to classify and consider and assess chronic musculoskeletal pain? So we know that chronic pain has traditionally been defined as pain that persists for longer than 3 months. People have different classifications and ways of describing it. This is a very common one. And in the recent ICD, International Classification of Disease 11, there is a new category for chronic primary musculoskeletal pain, which is considering primary pain as being an entity really in its own right. And then we also have chronic secondary musculoskeletal pain, which would be secondary to a specific disorder, maybe chronic back pain or osteoarthritis, as we mentioned. However, it's not completely straightforward, I think, as most things are not. This is the ICD-11 classification for chronic pain. And we can see on the left, we have chronic primary pain, and on the right, we have all the chronic secondary pain syndromes. So in here, then, we have chronic primary pain at the base here, and chronic secondary pain, musculoskeletal pain. And we have overlap between these. So we can see they have a double arrow, and I have just overlapped them here together, as this is an issue, I think, probably the next thing which will be researched and defined further following these new classification systems. So how do we tell if somebody has chronic primary musculoskeletal pain or chronic secondary musculoskeletal pain, and how do we tell if it's one more than the other? And the answer is we're not really sure yet. There have been some recent publications proposing, or one in particular, how this might be done, but it does require further empirical validation testing in order for it to be to validate this, really. So also just to note here that there's an arrow going, a double arrow from chronic secondary musculoskeletal pain up to chronic widespread pain, which will include fibromyalgia in there. So there's considerable overlap here, really, I think, is the message. But I feel that implicit in these new classifications, particularly for chronic primary pain, is that we consider a little bit about the underlying pain mechanisms that may be responsible for the generation or maintenance of a person's pain presentation. So when considering assessment of people with musculoskeletal pain, then we know that we need to use really a biopsychosocial approach. We're trying to understand really and quantify as best we can and describe a person's overall pain experience. So using a biopsychosocial approach, we can consider maybe basic pathophysiological processes, maybe disease processes, physiological process under the bio part of the model. And then we can also consider the affective components, the effects on mood, overall suffering for the person, social aspects, participation issues, behavioral effects of chronic pain, in addition to considering and assessing sensory aspects of pain. So we know that living with chronic pain is really a significant challenge for individuals. And so it's important to try and understand this, really. And the other issue about the biopsychosocial assessment is, although these issues can contribute to a person's pain experience and will be in their descriptions of their pain experience, these associations can be bidirectional. So in other words, management that can promote resilience, understanding, support, increased participation, engagement with life, increased function, can help to reduce the impact of pain and maybe have some effects on the overall pain experience and maybe on the pain itself, but that would be more secondary normally. And then how best to do this type of assessment? Well, there are some very good guidelines from the Initiative on Methods, Measurement and Pain Assessment in Clinical Trials. That's the IMPACT guidelines, and they suggest looking at 6 domains altogether to cover the multidimensional aspects of the overall pain experience. And I like this one from the British Pain Society, where they have this on their website. There's a little PDF you can download, and they have summarized many or translated many of the IMPACT guidelines into quite a short and easy to use booklet. And in this then they have the pain dimensions and then the corresponding outcome measures. So they suggest looking at pain quality interference, physical functioning, emotional, social functioning, quality of life, and then overall patient reported global ratings. This is the patient's overall assessment quantified of their current pain experience. And looking a bit further into these methods, then most of these are patient-reported outcome measures. So you're depending on the patient's report here. Patients can fill these out themselves or can be done in association with their clinician. And these are covering all of the dimensions really of the biopsychosocial assessment of pain. So for example, here from the British Pain Society, the brief pain inventory would cover pain quality and interference together. So some of these measures cover many different dimensions of the biopsychosocial assessment. So we may not need separate ones for each one, depending on the patient, or if it's for a research study, depending, again, we won't need all of these. And I suppose, unfortunately, in both the clinical and research communities, we don't really have an overall agreement internationally on what would be the best measures to use. So they all measure the different dimensions of pain, but we have many, many different outcome measures. So that makes it difficult then to amalgamate data. It's a little bit trickier if people are trying to do reviews or meta-analysis of these data, or indeed if they're trying to come up with guidelines. So in this here as well, we also have, you can see, assessment of pain mechanisms, and this links back a little to the changes in terminology and maybe viewing pain is in a little bit of a different way. So we have patient-reported outcome measures also for central sensitization syndromes. Originally, this was designed for, it's the CSI. It has a cutoff score for central sensitization. And we also have many measures for many years for neuropathic pain, like the LANS or Pain Detect. And then we can also use techniques like quantitative sensory testing. QST, as it's known for short, are graded noxious or non-noxious stimuli, which are going to assess overall somatosensory function. There are some simple measures we can use as an add-on really to clinical assessment. To look then, if we're thinking of including a little bit more on pain mechanisms in assessment and considerations for treatment, just reviewing again, I know you've had some lectures today on a classification, but briefly reviewing again just pain mechanisms terminology. We have 3 main categories of pain proposed by the International Association Study of Pain: nociceptive pain, the one everyone's most familiar with, neuropathic pain, again, just pertaining to a disease or lesion of the somatosensory nervous system only. And then the more recent terminology change was in nocioplastic pain, where this is basically saying that there is a certain degree, a break in a link between nociception and pain perception, or a stimulation of nociception and pain perception. So there may not be any discernible tissue damage causing activation of peripheral nociceptors, and still the person is complaining of quite significant symptoms of pain and other symptoms also. So again, I think these terms are all a little bit different, and they are terms that are evolving. And the other big thing about these definitions here is that there's a mixed, an assumption of mixed pain states, pain mechanisms in different individuals presenting with pain to your clinic or your research study. So there may be mixtures and components of all 3 of these, or maybe 2, or just 1. So if we were considering using quantitative sensory testing, to note that although they're called quantitative, they are psychophysical measures. So we're really asking the patient's response to the application of calibrated, graded, noxious or non-noxious stimuli, but it is the patient's response to that. So we can quantify it to a degree, but there are still patient-reported measures to a large degree. They can be useful in assessment, give us some more information in relation to pain mechanisms. They're not telling us where a specific lesion or problem is, so they're quite general methods, but they can, there is some evidence that they can be helpful as predictors of outcome of treatment or monitoring treatment, and can show us differences in nervous system function really, and pain processing between people who have chronic musculoskeletal pain and those who don't. So 3 simple measures that can be used really at bedside are pressure pain thresholds to measure hyperalgesia, and this can be done with the pressure algometer, which will give a readout in kilopascals, or other force pressure measure rather. Temporal summation, which is assessing enhanced central nervous system activity. And this can be assessed with a weighted pinprick, for example. There are other ways of doing all these tests, and I'm just pulling out 3 simple ones. And then thirdly, we can look at conditioned pain modulation, which will assess the descending pain pathways. So with this method here, the third one, we are applying a noxious stimulus, a conditioning stimulus to a part of the body. In this case, it's the hand submerged in a cold water bath to 4 degrees. We apply PPTs, pressure pain thresholds, pre and post the application of the conditioning stimulus, and we would expect the pressure pain thresholds to have increased. So pain perception should be the perception of pain should be lessened really after activation of the descending pain inhibitory pathways, and this can be dysfunctional, in which case the opposite will happen. So with hyperalgesia, firstly with pressure pain thresholds, we're looking at a shifting really of the threshold for perception of pain to be moved to the left, so it'll be decreased. With temporal summation, we're applying a barrage really of impulses to the nervous system. This could be a weighted pinprick, so it's a noxious stimulus really. It's activating C fibers, barrage of C fibers to the dorsal horn, and this is the physiological phenomenon of wind up. So we will get enhanced feeling of pain from repeated stimuli with excitation of the nervous system, increased excitation. And then thirdly, with conditioned pain modulation in an intact state up here, we would expect there to be some kind of increase in the pressure pain thresholds, but this may be impaired in some people. So it's telling us a little bit about pain mechanisms, and there have been extensive work done by our German colleagues looking at quantifying and describing these huge somatosensory profiles of people and normal data for database and standardization of these measures. So I'm just pulling out 3 which might be useful more in a clinical setting. Some research around these here that we can see in this systematic review of 25 studies with people with low back pain compared to healthy controls had significant decreases in pressure pain thresholds at remote sites, not in the back, but remote sites of the body compared to control. So indicating there's some kind of sensitization or excitation in the nervous system, and also increased temporal summation at the local site, but this wasn't as consistent across the studies. And the results for CPM, conditioned pain modulation, were very mixed. So they didn't make any conclusions about those from their meta-analysis. In this large systematic review on the left here, this was a review of 37 studies looking at the predictive capacity of QST. There were 15 studies of OA, 15 for the knee, the neck, 6 low back, 3, and they were able to include 34 in the meta-analysis altogether. So they did find that pain hypersensitivity, as quantified by sensory testing at baseline, was associated with poor outcome in all of these studies. For pain intensity in 30 studies, for disability in 11 studies, so poor outcome for intensity of pain, disability, and negative affect in 3 studies. And this study on the right here is one we did in UCD a couple of years ago. We looked at 156 people with moderate to severe osteoarthritis pain of the knee. And we did find that higher temporal summation and lower pressure pain thresholds emerged as robust predictors of non-response to physiotherapy programs. So there is some evidence that they may be a little helpful in predicting outcome, but the results are a little mixed. Just the same, it's worth bearing in mind. So how might we, the various categories that are proposed by IASP, for example, nociceptive, neuropathic, nocioplastic pain, how do we recognize these clinically? And this is the difficulty, really. I think it is, there is no international consensus or gold standard for doing this as yet, but it is emerging, I think, and the research is continuing and the papers coming out on this. So in this study here, this group did a large Delphi study on for 49 experts from 15 different countries to ask them what they thought represented nociceptive, neuropathic and nociplastic pain. And following rounds of the Delphi survey, there was broad agreement for a few main signs, symptoms across these three categories or classifications really of pain. There were 17 altogether for nociceptive pain, but there were 3, as can see here, like responsiveness to non-steroidal anti-inflammatory, signs of inflammation, predicted pain recovery based on expected tissue healing time. And for neuropathic, there were 37 different indicators. And again, these were largely based around assessment of nerve damage. Nociplastic pain, 22 different ones, but 3 or 4 main ones, including diffuse, widespread, poorly localized pain, general hypersensitivity, however it is assessed, multiple somatic symptoms like fatigue, sleep problems, memory problems. And then the other one is a mixture of all of these. So mixture of neuropathic and nociceptive with 78 indicators, nociceptive and neuropathic 27, and neuropathic and nociplastic, sorry, I think I'm getting a couple of these, 17. So they were quite mixed for the mixed ones also. So it's tricky how to do this clinically. So overall then, a biopsychosocial assessment is merited for assessing a person's overall pain experience. So we're really trying to understand how all these different dimensions are affecting pain, and remembering that it can be bidirectional, which is what is useful for management of pain. And considering some consideration of pain mechanisms, I think, is useful, particularly in light of the new classifications of disease, both from the ICD-11 and the IASP classifications. So following all this then, how do we manage chronic musculoskeletal pain? So I'm going to review briefly now the clinical practice guidelines for chronic musculoskeletal pain, some specific ones, recent systematic review, which pooled numbers of these together, and then look at a couple of reviews for evidence-based guidelines, as evidence in physical activity appears in all of the guidelines. It's one thing everyone seems to agree on. So firstly, here are the NICE guidelines from the UK for both assessment and management. I'm just going to focus on management at the moment of chronic primary and secondary musculoskeletal pain. Now, they do have specific guidelines for different areas. So all the different conditions you spoke about earlier, for example, low back pain or neck pain, which come under chronic musculoskeletal pain. But in the overall guidelines for chronic primary and secondary musculoskeletal pain, they're saying really they're promoting exercise and physical activity programs. Within that, they're not making recommendations about specific exercise programs because the evidence is quite mixed as to which is best. Psychological therapies, they are recommending in particular acceptance commitment therapy and CBT, acupuncture also, and then pharmacological management. And just to note here that they don't recommend pain management programs explicitly in these guidelines. And that's an intervention with 2 or more components, usually including a physical and psychological component delivered usually by trained health professionals. So not recommend, they're splitting them up. And these guidelines have been some criticism of these guidelines for this. And also, I think, for being they're quite explicit about ACT and CBT as opposed to other psychological therapies. Other guidelines from the UK, from the Scottish guidelines, which are all island guidelines as well, they have a little bit broader in their guidelines, and they're including more about supporting people to self-manage. That's a big thing here, pharmacological management again. And then they do recommend pain management programs, exercise and physical activity, and advice really to stay active. And just to note here, they mentioned this here, I'll just come back to this towards the end again, that clinicians should be aware of the possibility that their own behaviour and the clinical environment can impact on reinforcement of unhelpful responses. And I think what's useful about this is the clinician can impact for helpful responses for the patient also. And this is really good to know, I think, and I will just show some research about this at the end. It's always great when you come across a systematic review where somebody's put everything together for you, as is the case here. So this is a review, a recent review of 44 different clinical practice guidelines were appraised, and they have included in their recommendations 11 of these guidelines as they were deemed to be high quality guidelines. And these were 4 on back pain, 4 on OA, 2 on neck pain, and 1 on the shoulder. And coincidentally, they all also came up with 11 recommendations. And they're saying that we should use patient-reported outcome measures to evaluate progress, providing information and advice again, and education, physical activity and exercise, resumption of work or continuation of work, non-surgical management always prior to any surgery. However, there may be instances where absolutely surgery would be indicated depending on the individual condition. So these are high-level guidance, but the messaging is pretty clear in terms of education, advice, exercise, physical activity, and of course pharmacological management, which I'm not addressing in this talk. So just pulling out then about exercise in particular, because it is in all the guidelines, and I guess it's my interest from a physiotherapy perspective. In this big Cochrane review of physical activity and exercise for chronic pain, for 21 reviews, approximately 20,000 participants when all the data is combined, conditions including low back pain, OA, neck pain, fibromyalgia, and others. They're saying that there are some favourable effects for reduction of pain and maybe function, but they're small to moderate in effect sizes. Maybe mixed results more for psychological function and quality of life. We don't know what intensity, duration, and frequency in terms of exercise is best, and these really need to be researched further. And for low back pain, then exercise guidelines, again from Cochrane, 249 trials here, 24,486 people altogether when you amalgamate the data. And most of these studies would measure pain and disability, and they find that exercise is probably more effective for pain than no treatment, usual care, or placebo for people with chronic low back pain, but they can't make specific recommendations again. So we need to do more research as to what works best for different groups of people, what types of exercise, because these types of exercise included in these studies would include everything from resistance to flexibility, to yoga, to Tai Chi, to walking programs, etc. So I guess most importantly, to consider finally, what do patients say about self-management type interventions for chronic pain? So at this large review here of 27 qualitative studies where they're using qualitative data analysis and methods of collection to understand from the point of view of the participants themselves or people with pain, participants in the study. So it's 487 participants. So what facilitates or impedes self-management? And so the patients are saying that a big thing here is the healthcare practitioner. So like what they're saying in the Scottish guidelines, the healthcare practitioner is really important from the patient's perspective. The healthcare practitioner can influence the patient to facilitate the patient to come to a place of acceptance, increase self-efficacy, improve people's knowledge and understanding of pain, and be a support person for somebody trying to manage a challenging long-term, maybe lifelong condition. And similarly, the healthcare practitioner can negatively impact on that as well, as the Scottish guidelines are telling us, and reinforce internal barriers to like non-acceptance and low self-efficacy. So poor communication between healthcare practitioners then and patients can really reduce understanding of the benefits of self-management. However, good communication between both can improve acceptance, self-efficacy, and help people to set their own goals to facilitate change in their lives. And here are just some of the quotes from the patients in some of these studies. In grey here, I thought this would be suitable for colour for if things weren't going so well. That, you know, people feeling they're not being trusted and not validated, and they're not being believed. That they would like to set their own goals. Like this case, the healthcare practitioner seemed to think the patient wanted to be able to hoover, but they didn't. Who would want to be able to hoover? I don't know. Maybe it's a goal for some people. And on the right here, then, this is when it goes well, that the patient is saying, obviously in the first one, the healthcare practitioner listened really well. She guided her to a solution, or another person the healthcare practitioner explained what to do. She could see what to do herself. And then, having learned all these things, the next step then is to learn to live with the condition. And this is a nice quote here, I think, which summarizes nearly everything I've said. And it's from the Lancet. There was a series of articles in the Lancet, Rethinking Chronic Pain in 2021. And the editorial here is saying, a strong therapeutic alliance is critical to help people understand. So it's education, shift expectations, helping people set realistic individual goals, and prioritizing function and quality of life, considering this bidirectionality in the whole biopsychosocial model, as opposed to a focus on pain relief or complete pain relief. And then reassurance and support and validation for people is really, really important to support them through their pain experience. And the biopsychosocial approach is a great model to use for assessment and treatment, and then also consideration of pain mechanisms in assessment, and can help inform treatment within the overall biopsychosocial approach, and within the context of the change in terminologies and that all that brings with it for our understanding of pain. And thank you.
Thank you very much, Catherine, for your interesting, comprehensive, and useful information. And sorry. And dear colleagues, I received an information that there were some technical problems when I presented brief biographic data of Catherine. And let me repeat briefly that Catherine Doody is an associate professor in the School of Public Health Physiotherapy and Sports Science in University College Dublin. Catherine is qualified in physiotherapy. She completed a Master of Science in the University of East London, UK, and Master of Science Mindfulness-Based Intervention and PhD in University College Dublin. Catherine has held position as a head of subject and associate dean of physiotherapy, director of Master of Science in Neuromusculoskeletal Physiotherapy. She also is a founder, co-director of the Center for Translational Pain Research in University College Dublin. Catherine is also member of the EFIC Education Committee that developed the curriculum for the European Diploma in Pain. Thank you very much for your presentation. And now probably we will go to the questions. I will check the chat. Please.
We don't have any questions in chat yet. Can I have one question?
Yes, sure.
First of all, I want to tell thank you for this presentation, very full, which cleared a lot of questions from my personal list of questions I prepared for today. I had a list of questions, but most of them were clarified because of your nice presentation, Catherine. And we have discussed today a lot about classification of chronic pain on primary and secondary pain. We know that musculoskeletal pain is especially challenging for patients and physicians, and for illness like headache or for other diseases from this list of primary chronic pain, it's a little bit more clear because we have well-established criteria, for example, for primary headache. However, for musculoskeletal pain, the criteria is not so clear. Nociplastic mechanism of pain is thought to be the base or fundamentally in this primary musculoskeletal pain, and the criteria for nociplastic mechanism is known, and they well defined by International Association of Study of Pain, but we cannot use it. It's also is not a complete one-to-one mapping to primary musculoskeletal pain. There has been some attempts for criteria to make a criteria for primary musculoskeletal pain. In recent publication, I saw that Eva Kozik tried to present some attempt to make criteria for primary musculoskeletal pain, but they are not yet validated. So my question is, which tools, maybe some secrets you have and some principles you use for diagnosis of primary musculoskeletal pain?
I think this is the question, isn't it? How do you do this in clinical practice? Although the research is increasing enormously and our understanding of pain and pain mechanisms, and especially for chronic musculoskeletal pain, has increased enormously in the past number of years, translating that into clinical practice is the thing. And I think it's very difficult, and there isn't really international consensus around this. So, for example, if you're using a biopsychosocial approach, we have great international consensus on the domains to look at. There's about 6 domains. Everyone has agreed on those. But actually, which measures we use, we're not agreed on. So I have worked both as a clinician and a researcher, and for both perspectives, I think it would be wonderful if we could all agree internationally on which are the best ones to use, because they have all been, all the ones suggested, I put up a big list there, they've all been validated and they're reliable. So, but we use different ones. So when you're trying to review data and some of those meta-analysis I presented there of hundreds and hundreds of studies, and researchers are trying to translate one into the other and, you know, make some commonality between different outcome measures. So we haven't decided, you know, as communities how to do it. There was a very large review done quite recently where they looked at how in the published literature, how are people describing nociceptive, neuropathic and nociplastic pain, and they reviewed 220 odd papers, and they found there are 264 different criteria altogether for these 3 categories that people are using in the published literature. So there isn't a consensus. They found that most researchers, clinicians, are considering underlying pathology, aggravating and easing factors, responses to treatment, and characteristics of pain. They could group them under 4 main headings, but not come up with specific ones. That Delphi study I presented there, with where they surveyed, was it 40 or 50 experts across numbers of 15 different countries. They came up with common ones, but not total agreement. So we haven't operationalized this fully yet, I guess, is the answer. And I think the new classification from the ICD-11 is really, really useful, particularly looking at chronic primary pain and then looking at chronic secondary pain. Now, the overlap for musculoskeletal pain, there's obviously quite a bit of overlap, and there have been a couple of recent attempts to come up with criteria for this, one versus the other, but there isn't agreement yet on this. I guess this will happen over time.
Thank you very much. Thank you very much. Here in Moldova, we still in the very beginning of organizing of this rehabilitation for patients with chronic pain. So we have a lot of questions, we have a lot of things to do here. And one more practical question: how important to devise this primary, secondary chronic pain from practical point of view when you apply some, rehabilitation methods, or it's not?
Yeah, I think that's a great question. It is really important, I think, and I think it is changing our practice probably quite quickly from a rehabilitation point of view. So people we considering now who have more nociceplastic pain when we're reusing the IASP definitions, or we're thinking more now the ICD-11 as chronic primary pain. From a therapy rehab perspective, we're thinking we will incorporate more sort of top-down approaches, education, maybe sending people for psychological type interventions, pain management programs. So we're doing less of hands-on. Traditional physiotherapy, we use manual therapy. So traditional manual therapies less. We would use those more now for a definite type of pathology with a more cause and effect symptom response to a more kind of pattern to symptoms like nociceptive type pain. We use more of our traditional modalities. So I think it is changing practice quite a bit, actually. Yeah.
Thank you. Maybe some questions more?
If there is time, I have one question, please.
Yeah.
I want to ask if there are any studies, that prove the efficacy of physical exercise or comparing physical exercise program in primary and secondary musculoskeletal pain. So to see differences, because so recently we thought about such study and in the Department of Rehabilitation, and it is very interesting if it is worth to do.
Yeah, I think that'd be a great study. And I don't think there've been any done yet. So there will be people patients in the studies who will have degrees of nociceplastic pain or nociceptive pain, or maybe neuropathic pain, depending on the patients that are recruited into the study, but not comparing both. So that would be very interesting to do. So identifying people maybe with more nociceplastic pain and giving them a particular type of intervention, and people with more nociceptive and giving them another, and seeing how they respond would be the next thing, I think. I'm sure those studies, probably someone's planning them as we speak. Yeah.
Thank you.
Thank you.
Some other questions? If no other questions, I want to thank you once again for your brilliant presentation, for this nice conversation, and we invite you to Moldova. Here we have a very expressive period of time during the year: white winter, very green spring, very hot summer, and quite colorful autumn, and best wine in Moldova. And we want to ask you for possibility to collaborate with our department in future.
Okay, thank you. That'd be lovely. Yeah, Thank you very much. Thank you. It's a pleasure to speak here today. Thank you. Thank you very much for the invitation.
I would like, Catherine, to thank you once again for your brilliant presentation. And as told my colleague Svetlana, we are trying at our physiotherapy department to introduce this ICF frame of assessment and setting the management. And your information is very useful with regard to this topic, and we will be grateful to collaborate and to have some collaboration in this domain. You showed us that you are expert in this area, and we have a lot to study. And thank you very much.
Okay, thank you. I'd be delighted to hear from you afterwards. Okay, thank you very much again for the invitation. Thank you.
So we can switch to next session, yeah?
Yes, the last but not least important is our cancer pain session. We have our colleagues from oncology department here. Please go on.
Dear colleagues, good afternoon to all. Good afternoon to conference participants, to all the presenters. Next talk and the last talk in this list is about cancer pain, and I have the big pleasure to introduce Silviu Briu, who is a specialist in anesthesiology and pain management, director of the Institute of Pain Medicine, Tel Aviv Medical Center, Israel, Director Institute for Cannabis Research, Tel Aviv Medical Center, Israel, Honorary Secretary of European Pain Federation, past President of the Israeli Pain Association. At the same time, Dr. Briu is a co-chair of Task Force on Cannabis-Based Medicine and chair of the Working Group on Cancer Pain of European Pain Federation. He also participates in numerous national and international committees and has many publications in journals and books in areas of pain, including acute pain, neuropathic pain, CRPC, cancer-related pain, opioids, and cannabinoids. His main research interest is neuromodulation, psychological aspect of chronic pain, postsurgical neuropathic pain, and medical use of cannabinoids. He received grants from European Union for development of an international pain registry, Pain Out. I already have a list of questions to you, Mr. Briu. Thank you for joining us today, this late afternoon. The mic is yours.
Microphone, please.
We can hear you. We can't.
And now? Can you hear me?
Yes, now we do.
That's good. Okay. I said, thank you very much for inviting me. I'm happy to be part of your very nice and successful meeting. I've been in Moldova a few years ago, 4 or 5 years ago, and I was very pleased. In my position as Honorary Secretary of European Pain Federation, I'm here to give our greetings and to share our happiness that you are part of us, and success to your meeting.
Can you put your slides all screen?
Can you see it? I put it.
No, we see it, but smaller, not full screen.
It's full screen. I put it again. Why? I don't know why. And now? Can you see my slide?
Yeah. Yes, we can see them, but we can see another part, small one in the right part.
That's what I'm sharing my.
I see all the screen actually.
Okay, you can go, I think.
Let me know if something technical is not working well. So I'm leading the Pain Institute at Tel Aviv Medical Center. We have quite a big pain facility. We are seeing every day around. We're ambulatory medical facility. We have around 100 patients every day. working from 8 o'clock and 7 o'clock in the evening. And I developed in my clinic, in our institute, a special unit for chronic pain patients, having a devoted doctor and few other staff to take care of this special population of patients. So today I'll go over the pain definition in general, prevalence and epidemiology of cancer pain, a new, let's say, topic of changing etiology in cancer pain patient, and a special topic that I'm taking care, and I think that is very important for us to treat cancer pain and altogether in cancer survivors. So regarding pain, we are looking at two aspects: a sensory discriminative. If you hear the previous talk about chronic primary or secondary pain, but I'm looking in let's say another a sort of other direction. Is a pain can be sensory or discriminative, let's say where and how much, and affective and cognitive in terms of unpleasant and appraisal. So at the end of the day is the pain perception of the patient, how our patient is perceiving this bad influx. So is bothering him or her, is not bothering him, is affecting her life or no. This is at the end of the process what's bad for our process, because there are patients who are moving around and are can live with their pain, with big amount of pain, and there are patients with something very small, a small low back pain affect him and putting him in bed for 1 month. So this is the bottom line of what I'm saying: the pain perception and the pain attitude of the patients. Looking in terms of physiology,
I'm very sorry for bothering you, but can you just stop sharing and share again?
Yes.
Your
yes,
slides are not moving, please.
Okay. Now you can see me, and I'll share again. How is now?
It's very good. Thank you.
Good. Okay. In terms of physiology, we are looking at a process that started at the level of the skin: transduction, conduction, transmission, spinal dorsal cord, and the end of the process is again perception, experience, and modulation. Sometimes who is experienced with pain can take and can bear a bigger amount of pain that someone else who is just at the beginning, let's say, of the process. In cancer pain patients, it's even more complicated and more difficult to understand, because pain seems to be for most of them worseness of the cancer or cancer disease. So it doesn't really mean it's only pain; it's all the process all together. So cancer pain is a mixed mechanism of pain, presenting as a pure neuropathic, visceral, or somatic pain syndrome, and rather it may involve inflammatory, neuropathic, ischemic, and compressive mechanism at multiple sites. So to make it simple, it's not only inflammatory, neuropathic, or ischemic. It's for most of the patients, it's all together. It's not a very clear and pure pain syndrome. I'll share with you two ideas how can we explain the cancer pain. One is called the total pain theory, that take in consideration all the aspects. This means that it's physical, psychological, social, and even spiritual, and put together the comorbid causes caused by the treatment and cancer, the anxiety, the psychological, they are depressed and anxious, fear of suffering, taking in evidence past experience of illness and past experience of cancer. Social, they are losing their job, they are starting to be lonely. They have financial concerns, worry about future of the family, and for some of the patient, dependence of benzodiazepine or opioids, and spiritual. There are many patients that this is a very important way to fight with disease. Part of our anger of fate, because they are sick, because they are losing their family and their job, are part of the patients are trying to find the meaning of fate. And at the end of the day, the fear of unknown. The other way to look at the pain is the loser pain model that is pushing four stages: nociception, pain, suffering, and pain behavior. Not all the pain patients are suffering, but all the pain they are suffering have pain. This, you need to understand this, because a patient with pain that can compete and can take care of himself is not all the time suffering. This is very important to know in our mind. The quality of life is a very important issue in this meaning of fight the disease. And as I said, the pain perception and pain behavior, the cognitive behavioral component, are very important in the way that you can help our patients, even without drug or procedure. Just talking with them and help them to increase their trust. They can go over the disease and they to understand the disease. So regarding numbers, prevalence of cancer pain, around 50% of the patients have pain at the time of the diagnosis of cancer, varying between 20 to 75. Up to 60% of the patients receiving active treatment means can be chemotherapy, surgery, radiotherapy, have pain during their treatment. And at the end of the day, up to 100 of the patients have pain at the terminal phases of their illness. And it's very important to know, as I said, I'll focus on this specific issue of cancer survivors. Around 30 to 40% of cancer pain survivors have chronic pain. So, as I said, most of the cancer that provoke more pain are urogenital, lung, and head and neck. And as I said, during the curative treatment, 30% of the patients have pain, and in all the stages, around 50% of the patients. So there are very, very big numbers. Taking into consideration the big number of cancer pain patients, we are looking of around 50% of the patients that are already presenting with pain at the time of diagnosis. Part of them are getting worse during the treatment and during the last stages of their life. As I said, to sum it up, the numbers, we need to understand that up to 50% of the cancer have pain at time of diagnosis. 2/3 of the patients with advanced cancer suffer from moderate to severe pain, and exist around 5 to up to 10% of the patients that have pain unrelated to cancer. They have back pain, they have osteoporosis, osteoarthritis, so it doesn't matter the name of the pain. It is not related to cancer disease, but influence the magnitude of the pain by this disease. From where the pain is coming, first of all, is related to tumor involvement. Up to 80% of pain problems in inpatients, cancer population, 60% of outpatients population is related to tumor involvement. Of course, metastatic bone disease, hollow viscous involvement, and nerve compression or infiltration are most common causes. Minimum 20 or 25% of the cancer population are suffering from cancer therapy, chemotherapy, radiotherapy, invasive surgery. As I said, 5 to up to 10% have pain unrelated to not related to cancer, and we didn't. A very important and very humanitarian type of pain is generalized pain in a dying cancer patient in the end stage of the disease. Talking very didactic, we are making the 4 types of cancer pain: somatic, visceral, neuropathic, and headache and facial pain. But as I said, most of the cancer pain patients are suffering from a mixture of disease, like say visceral neuropathic or somatic and neuropathic. Most of them have a neuropathic component of the pain. This is an example of somatic cancer pain, vertebral metastasis. But again, compressing a nerve will have a neuropathic component. Visceral cancer pain, all the cancer is an abdominal cavity. Neuropathic cancer pain, I'll talk more or less. This means that any kind of nerve is involved in a tumor or in a paraneoplastic disease, or affected by treatments like chemotherapy. Neuropathic pain can be due to tumor-related, directly compression of the nerve, changes in neuronal milieu due to tumor growth, inflammatory response, but also related to treatment, chemotherapy-related neurotherapy, radiation-induced fibrosis during injury of peripheral nerve, and of course, lots of cases of post-surgical, post-surgical neuropathic pain after mastectomy or tumor resection that involve nerve. Neuropathic can, as I said, is the issue of chemotherapy-induced pain. I'll talk further in my talk. Is a very important and very difficult to treat pain syndrome. Other issues of neuropathic pain are brachial plexopathy, lumbar plexopathy due to metastasis or tumor in lumbar spine, epidural spinal cord compression, sciatic neuropathy, and many other issues when the nerve is directly involved or indirectly by toxins like chemotherapy or tumor growth involvement. How are we facing? I think in 2009, Breivik and his collaborator published this study showing the prevalence of cancer pain in different European countries. You see the medium response was 70%. So around 70% of the country are reporting that their cancer pain patients are suffering from severe moderate to severe neuropathic pain. It's going from 43 in Sweden to 95 in Italy, 88 in Israel, also very high number. And you can see the figure. In all the countries, the figures are bad, even you can say very bad. So we need to understand that we are not doing that well. We have enough drugs, enough knowledge, but putting together all the logistics and treating the patients is not the best issue that you can do. Probably there is now no other study that show up in the last years. We are, I hope that we are doing better than in the figure in this study that show very bad treatment of cancer pain patients. Another very difficult to treat issue, as I said, is the bone metastasis is more frequent in men, 60%, than in women, 40%. And these are the number of metastases in a few hundred patients. It's a very old study, but quite actual, showing that in the old patient, around 50-60 men, the presence of bone metastasis is high or very high and difficult to treat, and provoking also fracture and more than the bone pain. As I said, the issue of changing, what I'm calling changing pathology in cancer pain. I think lead pain is related directly to carcinogenesis, 69, more to 60 than to 90. cancer-associated pain indirectly linked to the patient care. We know that this patient care can suffer from low back pain, postherpetic neuralgia, and many other issues that are related to or not related to the pain, therapy-related pain, and cancer-independent independent pain. We need to understand that even with patients who survive the cancer, any kind of pain is a bell ring that something wrong is going back. And besides the issue of pain is the issues of anxiety and depression that come together, we need to reassess and this patient very fast in order also to treat the pain and the disease. Second, to see that is not a recurrence of the cancer, and also to treat the anxiety of their patient, that everything that is not normal of them is again they are linking to their old cancer disease. Very graphical model of pain in cancer, and then they can putting together more or less my old talk regarding the how the pain is coming. Is, let's say, this is diagnosis, and there is no usually a very clear line. Is coming with good person, it's called remission, or part of them are CARD and are becoming survivors, and the issue of chronic pain in survivor patients. And we are aiming to restore, alleviate pain and restore functionality and quality of life in these patients. There are lots of procedural surgical due to the cancer pain due to metastatic disease, pain of the end of the life when things are going bad. And in this patient, we need to reassess to treat the suffering and to improve comfort and what remains of their life at the end of the process. This is summing up all the things that I spoke till now. So regarding numbers, cancer pain experienced by 55 or half of the patient undergoing treatment for cancer. 66% of patients who have advanced metastasis of terminal cancer. I believe from my practice that around 60 to 70% of these patients, we can treat patients quite well with not very complicated resources. But we have at the end of this around 30% of the patients, we can't treat them, we can't help them, and we need to go to very complicated or invasive treatments in order to help them. Another issue that is very important to talk when we are talking about cancer pain is the breakthrough pain. Usually we can treat well or very well the background pain, but it's very difficult to treat the breakthrough pain. And the breakthrough pain impact is very important because it's increasing the anxiety, depression, is putting the patients away from their try to work. So there are healthcare costs. They are kinesophobia. They are not willing. They don't want to go because they are afraid that the pain will come back. So you need to understand that is another issue that more difficult to treat the breakthrough pain because it's short, very important, but with long consequences. So take all the time in your mind that we have two kind of phases: the breakthrough pain and the basic base of the pain. They are not the same treatments. They are quite different other drugs, and we need to treat them in another way. Is around 60% of the patients with cancer pain suffer from breakthrough cancer pain. Is very affecting their willing to work, to be mobile, and to be part of the family. One of the last issues that I want to talk is what means cancer pain survival. Understanding survivorship, it means that these patients have passed all the stages of the cancer and survived. So they have no sign of cancer after finishing the treatment. They are living with, through, and beyond the cancer, and the point of beyond the cancer. They have a clear diagnosis of cancer. They've been treated and received treatment over a long period of time. There are three phases of survivorship: acute, very just at the beginning of their stage of survival. Extended survivorship starts at the end of initial treatment and goes through month after the end of the treatment. And permanent survivorship is years have passed since cancer treatment ended. There is less of a chance that the cancer may come back. Let's say 5 years more than they finish their active treatment. They are in follow-up, and nothing bad is coming in their life. One good issue is that we are treating quite well the cancer, and the number of cancer survivors are increasingly very, very much. You can see the numbers in the United States. In early 70s, they've been around, the number is around 4, and now we are around 16. So 4 times more survivors than in 40, more or less 40 years. Is quite important and quite good for us that we know to give very good treatment for cancer patients. We are improving our medical knowledge and treating these patients much better. As I said, there is no issue that starts up in the last decade. Pain and cancer survival, a cognitive effective model of system present under certain treatment of disease recurrence. All these patients, they'll have in their back of mind that the disease may come back. There is no way to take this away from their mind. And this is a message that you can reassess the patients and treat them and help them. And part of them, they do have pain and even important pain. There are, I put here a few articles that I think that are more important to know. A very, very important issue, maybe in the United States, less in Europe, for this kind of patient is addiction. Many of them have been heavily treated of opioids. It's a very good drug for certain period of time, but they became addicted and they are still going with opioids in this survival period without having very bad pain. So there are very few evidence-based cancer pain guidelines in this population. We don't really know how to treat them. There is quite a new issue. Besides, opioids are the cornerstone of acute and pain or advanced disease, but not in survivors. We are trying now. We are facing quite I don't want to say epidemic of addiction in this specific population. Therefore, higher need for multimodal pain and a plane of care of balancing pharmacological and non-pharmacological techniques. And usually we need to have an interdisciplinary team. And the goal is to improve function and limit adverse of treatment, and start trying as much as possible to give more non-pharmacological help than pharmacological help in these patients. Another very nice article showing how to screen, treat, and assessment and mitigation and universal precaution in this population of American Society of Clinical Oncology. So, trying to sum up what I said. These are the most frequent chronic pain syndrome in cancer pain patients, starting from chemotherapy, body complication, vascular necrosis, hormonal therapy-related pain syndromes. You have lots of sexual disparities and myalgia, osteoporotic comparative fracture, radiation-related pain syndrome, all together. In patients who have stem cell transplantation, arthralgia, dysuria, eye pain, paresthesia, sclerodermia, like skin changes, surgical pain syndrome, like after breast cancer, lymphedema, post-amputation, phantom pain, post-mastectomy, after radical neck dissection, severe neuropathic pain. And as I said, the last thing that I'm talking about is chemotherapy-induced pain, very severe, very difficult to treat, and usually is going over years and years and years without very good results. Is a direct effect of the nerve of the chemotherapy agents. Some extra things, because I think that treatment should be broadly talking in maybe another talk or another way, and because it's a very long story to treat cancer pain, starting from very simple drugs, going to neuropathic drugs, opioid and procedure, and put all together, putting in the multidisciplinary approach, giving the psychological assessment and support that the patient needs. I want to say few drugs that we are not really, they are very old, usually quite cheap, and we start to use them again. Methadone and ketamine. Methadone was been elaborated during the Second World War, so it's not a new drug. Ketamine, the same. There are very good drugs for acute and neuropathic pain cancer, and are not that used that much that I think that should be used. There are not very simple drugs, but again, the results are quite good. Interventional pain treatments. Since in my institute, Pain Institute, we have usually a referral from difficult pain patients. We are doing this kind of procedure, even destructive procedure like radiofrequency or cryodenervation, less alcohol and phenol as in the last decades, but we are moving to new treatments, and we are working together with neurosurgical department, having using very destructive patients like cordotomy in this kind of end of the life patients. We do use neuromodulation for the patients who have a long period of life, the good prognosis, or are cured, spinal peripheral nerve modulation. And as I said, neurosurgical treatment for intracranial pain should be taken in consideration for these patients when their prognosis is bad or the pain is so difficult to treat that we are behind any kind of treatments. We do use also intrathecal morphine pumps for these patients. And I need to say that a very important issue is to have a palliative service that know better than not only palliation but only pain, is working together with the pain services and can collaborate together with all these issues together: pain, palliation, neurosurgery, and having the psychology issues together. So to sum up my talk, the good news is there is an increase of cancer survival rate. The bad news, increasing chronic pain in cancer survivors. We are not doing that well, as I said in the last survey. Hopefully, we will improve in all. Is not only in one country, is all over the Europe. The opioid epidemic and addiction problems occur also in survivors. There is a high need for improvement for non-pharmacological approaches to treat chronic pain in cancer survivors. There is the issue not one size fits all approaches. We need to tailor the treatment for every patient, because everyone has his own disease and own background, and we don't usually succeed to treat one patient with all the patients with one measure. We need more drugs and approaches for chemotherapy-induced peripheral neuropathy, and again, the health economical issue are very important. Also in this patient, there are more resources and more money and health staff to treat cancer, but less to treat pain or other symptoms in this patient. My message is make the pain visible, and when it's visible, all of us will treat it better. Thank you very much. I'll be happy to answer to the questions.
Thank you very much, dear Dr. Bill. It was a very comprehensive approach and a large view. Actually, I've seen not many people speaking about survivorship and pain relationship. So it's very good to hear about it. So one question which I would like to address to you, reading all this, your professional involvements, it's about cannabis, cannabinoids, and pain. Can you tell please about this? Because cannabis just brings some laugh when you speak to students. Doctors know less about cannabinoids. I would be happy now to hear your opinion. Where is the place of cannabinoids in our contemporary pain management?
So I'll divide my answer in 2 or 3 stages. First of all, we need to understand my first message. Cannabis is not curing any kind of cancer. Up to today, there is no study that shows that cannabis is really curing any kind of cancer in human. First issue. Second, cannabis is a sort of on-top drug for appetite, pain, vomiting, and other symptoms of cancer, even for well-being. In my country, there is the idea of medical cannabis. Every cancer patient can get cannabis legally, and many of them are using. Part of them are saying that it help them with some in a matter or no. I think that is not the best pain killer, but it's moving. Let's say it's moving the focus from the front to the back of the mind, of taking care of pain is one issue. And I think that once you have something that may help patients in a way or other, we, not me, not myself, we don't have any problem to treat them also with cannabis. A problem starts when, again, in what's called the survivors. Do you need to continue the treatment with cannabis or other painkillers? Yes or no? We don't have a question yet. There are side effects of cannabis treatment, definitely less maybe than in other heavy opioids, but we have seen side effects with cannabis treatment. Unfortunately, I had the last sentence. We don't have a pill of cannabis. Most of the patients want them to smoke cannabis, and part of them, around 20% who are using oil extract of cannabis in my country.
Okay, thank you. Mr. Brill, another question which was again rising from your CV. We don't have enough data usually about pain incidents, not clear, not very detailed, but you were participating in an international kind of project, and you developed a pain registry. Can you tell, please, a little bit about it? Maybe Moldova is also a candidate to be part of such projects in the future.
Depends in which population, first of all. The pain registry developed together with many other countries in acute pain patients, 1 day first post-operative day or 2 post-operative days. This is the pain registry. So it means that you need people who will go to the patients one way to ask few questionnaire of pain and to make it to put it in a computer one way. This is not that simple. You need manpower, you need time, and you need patients who will cooperate. And if you want to know, let's say, in terms of cancer pain or chronic pain, it's possible to do The easiest way nowadays is to do internet survey. Survey is not that complicated. You need to internet platform, everyone have it in questionnaire, and to go to as many many possible patients. Let's say, if you think that in a country, I'll give you an example, the incidence of cancer, of chronic pain, not cancer, it's around 25%, so it means 1 in 4 will have pain. So you need to ask 1,000 patients, 1,000 old patients, in order to have 250 yes. If we want to have more, we need to send this questionnaire to 10,000 adult patients in order to have response that we want to do. It's not that complicated. It's quite simple to do. It not really cost money. In one way, you need someone who to use a very good statistician to use the data and to put it together. But it's not very complicated nowadays. And when you have these things to work.
Excellent. Maybe we can interfere later on this as well.
Yeah.
Mr. Brill, you at the beginning of your talk, you said you've been in Moldova before.
Yeah. In a pain meeting.
I didn't notice you around the Institute of Oncology. So please take next time a chance to visit us.
I'll be more than happy. Yeah.
I'm sure we will have a lot about to talk. Thank you very much for your presentation. I don't want to interfere with closing ceremony, which is going now. It will start soon.
Definitely.
So thank you very much again.
Thank you very much for inviting me, to organizer, to Oksana, and hope to see you sometime. Bye.
Thank you very much.
Thank
Oksana?
you, Dr. Brill. Okay, I will take over from here. Thank you, Dr. Brill, to come here. And I hope you don't forget Romanian, so we can speak Romanian.
We can speak very nicely Romanian. It's not that easy to me to give a talk, but to speak is my pleasure.
Yeah, of course.
Face to face, I'll speak Romanian, definitely.
Okay, thank you very much.
Bye, Oksana.
And now I think we will start our closing ceremony, and we will have some thanks speech, and we will go home.
Cu prilejul frumosului eveniment, doresc să vin cu un mesaj de felicitare pentru mult stimatul domnul profesor Ioan.
Please, we will ask Professor Odobescu to give his final talk, and if someone else will do, please.
Good evening. We began, it was morning, and now it was a very, very long day, but very fruitful day. A really bright scientific event and multidisciplinary event with a very high educational quality. Faculty absolutely brilliant, the best professors, best presentations from all over the world concerning pain management. They brought not only the latest pathophysiological data on the chronic pain, but also some tips and tricks brought from their personal priceless experience that is very, very valuable for us, for young neurologists and for experienced neurologists. I think everyone enjoyed this fantastic event that was consisted by 2 parts, chronic pain and chronic headache. Very interesting, and different specialty come together in this event. I think Oksana Grosu carried on her delicate shoulders all the organizing difficulties. And I am very grateful, and congratulations for Oksana Grosu. Oksana, now you deserve all you want. Thank you very much.
Thank you, Professor Odobescu. Mrs. Angeli, would you like to say something?
So I agree with everything Stella told. So I want to congratulate you for organizing such an impressive conference. So really, we have a great honor to have such professors that are well known in all over the world. So we had a lot of lectures that were the best, as Stella told. So I congratulate on this fact, and I congratulate on the fact that 30 years of activity of Laboratory of Functional Neurology had very successful and fruitful. So the results are seen today. So congratulations to everybody. Thank you.
Thank you.
Thank you. Someone else would like? Okay, then I will take a little bit of your time, and I want to say a big thanks to International Headache Society and EFIC for their endorsement of our scientific program and for financial support. I want to thank all the speakers that come here virtually and share their experience and their knowledge. They are all very amazing. The speakers from the headache field knows me and they answer quickly the emails, but the speakers from the pain field answer to a stranger emails and agree to come here and to deliver their presentations. So thanks to our sponsors and thanks to our team that helped to organize this conference. And now we will have some videos. They will be in Romanian. Please enjoy them.
Cu prilejul frumosului eveniment, doresc să vin cu un mesaj de felicitare pentru mult stimatul domnul profesor Ion Moldovanu, fondatorul Laboratorului de Neurologie Funcțională, dar și pentru colectivul care în anumite perioade de timp am avut tangențe cu activitatea laboratorului. Domnule profesor, vă mulțumim pentru suflul nou care l-ați adus în neurologia autohtonă, pentru ambiția și motivația științifică care ați abordat-o pe parcursul anilor. Totodată, doresc să aduc mulțumiri și doamnei profesoare Stella Odobescu, care ca un adevărat mentor ne-a fost mereu alături, ca o călăuză și ne-a îndrumat în activitatea științifică și nu numai, dar și în plan personal. Vă mulțumim, vă apreciem și cu plecăciune vă spunem la mulți ani!
Bună ziua! Sunt Oxana Grosu, medic neurolog, activez în cadrul Laboratorului de Neurologie Funcțională în calitate de cercetător științific. Marcăm astăzi, prin această conferință, 30 de ani de la lansarea Laboratorului de Neurologie Funcțională în Republica Moldova și respectiv fondarea ceea ce ulterior avea să devină Școala Neurologiei Funcționale. Sunt mândră să zic că sunt discipolul acestei școli. Am avut onoarea să învăț de la cei mai buni mentori și să activez cu cei mai entuziaști colegi. Mulți dintre discipolii acestei școli au plecat să ne reprezinte în afara țării sau în discipline conexe. Ne amintim cu drag de ei și de timpul petrecut împreună. Felicitări, dragi colegi, prosperare Școlii de Neurologie Funcțională din Republica Moldova, la mai mult și la mai mare, cu drag de voi, al vostru discipol.
În spatele acestor 30 de ani există foarte multă muncă și pasiune, efort științific și practic. 30 de ani înseamnă durabilitate, ascensiune, afirmare și progres. 30 de ani de reușite valorificate prin algoritmi noi de diagnostic și tratament cefaleilor și tulburărilor vegetative, 30 de ani de formare și instruire ale medicilor, 30 de ani de dăruire pacienților. 30 de ani de numeroase cercetări științifice, programe de doctorat, conferințe naționale și internaționale, numeroase publicații și planuri frumoase pe viitor. Pe parcursul acestor 30 de ani, oameni deosebiți ai acestui colectiv minunat au știut să înlocuieze valori deosebite umane și profesionale tinerilor generații. Sunt onorată să fiu una din doctoranzii care a susținut teza de doctor în cadrul acestui laborator sub conducerea doamnei profesor Stella Odobescu, șefa laboratorului științific de neurologie funcțională. Sincere felicitări, stimați colegi, cu frumoasa aniversare! Vă doresc multă prosperitate și realizări frumoase în viitor!
Mult stimate domn profesor Moldovanu, mult stimată doamna profesor Odobescu, onorată asistență, dragi colegi! Iată-ne la 30-a toamnă împlinită a laboratorului cefaleei și tulburării vegetative. Multe din obiectivele setate au fost realizate. Vorbim despre un colectiv puternic, cunoștințe trainice, medici devotați, care au dus faima țării noastre departe de hotarele ei. Vreau să duc un cuvânt de mulțumire și recunoștință pilonului acestui centru, domn profesor Moldovanu, care m-a luat sub aripa lui și m-a adus și m-a infiltrat într-așa un colectiv excepțional. Domn profesor, dumneavoastră ați împărtășit rezervele din experiența dumneavoastră valoroasă în formarea bazelor cunoștințelor în cefaleie și tulburărilor vegetative. Și nu în ultimul rând a formării unei echipe și lucrului în echipă în domeniul științific. Vreau să vin cu un cuvânt de recunoștință către doamna profesor Odobescu Stella, care pentru aportul dumneavoastră inteligent, delicat, în susținerea persoanei mele, absolut de atâtea ori de cât a fost nevoie. Dumneavoastră, domn profesor, cât și doamna profesor Odobescu, sunteți identificați ca niște persoane extraordinare, care permanent țineți și tindeți către un lucru făcut excepțional și făcut la cea mai înaltă perfecțiune. Ați dăruit timp, ați dat dovadă de devotament față de oricare persoană cu care ați avut punct de tangență. Vreau să vă doresc dumneavoastră personal, cât și centrului, care este rodul muncii dumneavoastră, să rămâneți mereu pe aceeași vibrație de undă pe care am simțit-o eu ori de câte ori am fost alături de dumneavoastră. Vă doresc ca în drumeția dumneavoastră să aveți multe încă lucrări științifice, să mergeți să continuați mai departe în aprecierea sau în dezvoltarea acestui drum de aflare a tuturor tainelor ale cefaleilor și tulburărilor vegetative. Cu mare respect și stimă, Violeta Maticiuc.
Bună dimineața tuturor! Mă numesc Gabriela Pavlic, am fost cercetător științific în cadrul laboratorului de neurologie funcțională între anii 2009-2013. De mai mulți ani am emigrat din Republica Moldova. În prezent activez într-un spital regional în clinica de psihiatrie într-un oraș mediu din Germania. Mulțumesc colegilor care au oferit posibilitatea de a mă adresa participanților acestui seminar online dedicat problemei durerii cronice, care este o problemă indiferent în medicina contemporană, indiferent de regiune sau naționalitate. Doresc tuturor participanților obținerea de informații practice și utile pentru ajutarea pacienților cu aceste probleme și mulțumesc organizatorilor pentru eforturile depuse în organizarea acestui eveniment. O zi bună în continuare!
Stimați colegi, bună ziua! Laboratorul Neurologie Funcțională este parte importantă a ecosistemului științific al Institutului de Neurologie și Neurochirurgie Deomid German, dar și al întregii comunități științifice a Republicii Moldova. Cu ocazia celor 30 de ani de activitate, aș vrea să aduc sincere felicitări, în primul rând, întemeitorilor acestui laborator, domnului profesor Ion Moldovanu, domnului profesor Victor Vovc, doamnei profesor Stella Odobescu, dar nu în ultimul rând cercetătorilor care realizează cercetările științifice cotidiene. Cu toții merită respect și apreciere pentru activitatea lor prodigioasă. Ei merită sprijin pentru atingerea noilor obiective. Le doresc tuturor sănătate, tenacitate, succes, pace.
Dragi colegi, în ziua aceasta aș dori să vă felicit în prezență, dar trebuie să mă limitez la video. Am făcut cunoștință cu Institutul de Neurologie și Neurochirurgie atunci când am fost studentă și am venit la prelegeri și la seminare. Și după o prelegere, țin minte, m-am apropiat de domnul profesor Moldovanu și l-am întrebat dacă pot să fac o cercetare științifică la catedra dată. Vreau să spun că vă admir pe voi toți. faceți lucruri deosebit de complicate, de dificile. În condițiile Republicii Moldova reușiți să faceți cercetări științifice bune, să primiți granturi, să primiți burse, să călătoriți la congrese internaționale și naționale, să organizați tot. Bravo! Sunteți într-adevăr bravo!
Mulțumim tuturor colegilor care au venit cu felicitări. Mai avem o felicitare din partea doamnei Sirica Ala, care din păcate s-a îmbolnăvit. O voi transmite în scris. De asemenea, mai avem o felicitare de la colegii din Moscova. De asemenea, ei ne-au transmis clasificarea internațională a tulburărilor cefalalgice în limba română, care va fi ulterior expusă pe site pentru toți doritorii care doresc să o utilizeze. De asemenea, vreau să vă informez că mâine vom avea un atelier de lucru care va fi doar în engleză. Cei care doresc să se alăture, în special colegii tineri, sunt așteptați cu drag. Și toată înregistrarea conferinței va fi expusă ulterior pe pagina durere.md și va fi transmisă celor care s-au înregistrat. Vă mulțumim că ați venit, toate bune, la revedere!